Assalamu alaikum wa rahmatullah. Welcome everyone to our lifestyle medicine webinar. My name is Tanima Mtari and I'm going to be your first lecturer for today. So we will start off with a brief introduction into lifestyle medicine, focusing most importantly on how we can eat smart, on what we can eat, why and when, starting from the life cycle of early pediatrics and how diet can impact their development and their growth and later on their life as adults and also their health. So because good nutrition is essential for achieving growth and development, screening and assessment should be an integral part of healthcare, starting from the newborn period. So effort should be made to enhance appetite and intake in children who are not with their families or their familiarity is important to these food options. In addition, having a simple nutritional screening tool can help in identifying children who are at risk for malnutrition, affecting 1/4 to 1/3 of children admitted to hospital. So, malnutrition can be very prevalent among children who are hospitalized, and this will poorly impact their health as adults later on in life. So when there are problems with growth, a proper intervention and referral is very important. And following the checklist of A, B, C, D, E factors can be used to assure the completion of all assessment factors. In addition to this, poor health habits will limit the access to service, and long-term use of multiple medication are very common health risk factors. And having nationally credentialed dietetic professionals are best able to provide appropriate nutrition information as it pertains to wellness, good health, and the quality of life. So, in particular, children with developmental disability and special health care needs frequently have growth alterations such as failure to thrive, obesity, or growth retardation. Also, they could suffer from metabolic disorder, poor feeding skills, medication nutrition interaction, or even dependence on enteral or parenteral nutrition, depending on their severity of their health condition. So, nutrition service should be provided throughout life in a manner that is interdisciplinary, family centered, community based, and even culturally competent. So, a very common nutrition disorder in newborn or children is failure to thrive. So, this is a diagnostic term used to describe infants and children who fail to grow and develop at normal rate, and it indicates protein, energy, vitamin, and mineral insufficiency. So, in many pediatric centers, 1/3 of the referred children are malnourished, and failure to thrive is considered a complex problem which can be caused by many medical or social factors. And without a treatment, chronic illness or even death in severe cases can develop. So, having a proper diagnosis as well as intervention are important for preventing malnutrition and developmental delays. Also, having careful attention must be paid to growth chart and medical history. In addition, if there is food refusal or poor feeding, vomiting, or irritability, and failure to thrive, these are commonly found in both infantile feeding disorder and common treatable medical conditions. So, weight is considered the most reliable marker for failure to thrive. And according to the American Academy of Pediatrics, failure to thrive is established when weight or weight for height is less than 2 standard deviation below the mean for age and gender, or if the weight curve has dropped more than 2 percentile line on the National Center for Health Statistic growth chart after previously being on a stable pattern. So other indexes include small head circumference, muscular wasting, apathy, weight loss or poor weight gain, and learning failure such as having slow talking skills and behavioral problems can develop as well. So infant with DS or even intrauterine growth retardation or premature birth will follow different growth patterns than the usual or healthy children or infants. Uh, and they will also monitor carefully to evaluate for failure to thrive and prevent it from developing. So about 25% of normal infants will shift to a lower growth percentile in the first 2 years of life and will then remain at that percentile. And this is not considered failure to thrive, but because of their low birth weight status or prematurity. So primary failure to thrive originates from social environmental defects or inadequate feeding procedure or even caretaker behavior. So adolescents' mother may need a lot of support and education in order to prevent failure to thrive in infants, and having proximity and touch are especially disturbed in feeding disorders. For example, for the mothers that provide less touch that support growth, and the children demonstrate signs of touch aversion with early intervention by trained home visitors that may promote a more nurturing environment and reduce developmental delays. While in cases of secondary failure to thrive, this originates from some disease states such as cancer, allergy, or chronic infections, cleft palate, or other physical or mental disabilities. So, growth failure plus fever of unknown origin and anemia in older children or teens can suggest that the onset of Crohn's disease and evaluation is recommended. Also, about half of the causes of failure to thrive are organic, while the other 50% are from inorganic causes, with the American Dietetic Association suggesting at least 5 medical nutrition therapy visits for infants and children who are suffering from failure to thrive. So, in these cases, the intervention objective should be that all children with failure to thrive need additional calories for catch up growth at about 150% of the energy requirement for their expected weight. Also, using calculations for determining the need from the most current pediatric manual of clinical dietetics is recommended. And identifying with correcting the etiologies such as decreased energy intake or increased nutrient sources or metabolic demand. This will determine if malnutrition is primary from faulty feeding pattern or dietary inadequacy, or if it is secondary from disease process interfering with food intake. So we should teach the parent or caretaker on how to properly feed and how to determine the needs, also advising parents to support nurturing during feeding and providing the most optimal nutrition capabilities with a normal growth pattern. by achieving a daily gain of 30 grams for young infants, and extra weight might be desirable for catch-up growth. So using a nutrient-enriched formula are probably not necessary but can be very effective. Also providing a schedule for feeding for infants' age to support the catch-up growth and improving their brain development. So conducting a thorough nutrition assessment and acquiring actual intake record when possible is also required, and evaluating the child's nutritional history and growth in comparison with the percentile of other same age children, and if special growth charts are needed, using those instead should be recommended. And most importantly, we should discuss the finding with the parent or the caretaker, and we should calculate the energy and protein need carefully. While not easy to do, indirect calorimetry can be needed in these cases to further assess their caloric intake. In addition to this, we should check the recommended intake for all nutrients and provide adequate intake of zinc and vitamin B6 as determined by the infant age, and about 120% of the recommended daily allowance is common practice in these cases. Also, we should monitor the growth on a weekly basis and their feeding behavior if they are accepting their food intake or not. And if the infant is dehydrated, then we should provide adequate amount of fluid, but failure to thrive can be aggravated by excessive consumption of fruit juices and sweetened beverage, also which may replace other nutrients dense food. Therefore, limiting the fluid intake to about 4 to 6 ounces on a daily basis and introducing better nutrient dense food option is more important. So providing meals and snack at a scheduled time, supporting a comfortable social and emotional environment is very important. And having family meals and allowing children to be part of meal preparation are also important. And if failure to thrive in children are strictly vegan, then we should monitor for vitamin B12 and D and B6 with iron, zinc, and calcium deficiency. And if needed, we should give them these as supplements. Also, tube feeding may be useful as a supplemental or alternative feeding method, and having nightly feeding is an effective recommendation if it can be managed by the caregiver appropriately. So evaluating the medication that is given for any reason to determine if some or all affects the nutritional intake, and adjusting the diet as needed is recommended. Also, having endogenous cannabinoids or other appetite enhancers are being studied for their safety and effectiveness in failure to thrive, but still there are no current medical recommendations for their use. While for herbs and potential supplements, they shouldn't be used for failure to thrive, and there are no controlled trials to prove their efficiency in these patient populations. But probiotic has been found to be useful for their live microorganism with the health benefits of GI disorders, cancer and infant allergy, or failure to thrive, as well as infection. While for zinc supplementation, they may be needed during catch-up growth in malnourished children, and we should avoid prolonged or excessive doses of these supplements as well. And most importantly, for nutrition education, we should describe appropriate nutritional intake according to age and any predisposing medical condition. Also, encouraging the use of appropriate growth charts at home. to monitor if the patient is growing successfully and following the plan or if it needs any adjustment. In addition to developing a progress chart for developmental milestones and growth spurts that follow sustained weight gain, therefore, it should be monitoring the growth frequently. So we should offer simple, specific instructions when needed, such as mechanics for breastfeeding and typical intake for children of the same age. While if the formula is being used, we should teach about improper mixing of formula that is common and help correct any misunderstanding. Also, we should discuss nutrient densities such as milk versus sweetened carbonated beverage and whole fruit versus juice intake. We should also explain the proper use of over-the-counter vitamin and mineral supplements and age appropriate for the child, and address any harmful or unusual dietary habits with practical suggestions that should be offered regarding nurturing and emotional support for the child and balancing class that may be beneficial. So, coordinating the referral to child welfare services where neglect is suspected and referring them to programs that can help them whenever appropriate, with follow-up that should be provided at outpatient clinic or by home visit. And for the food safety, we should teach the patient about appropriate hand washing procedure and sanitation by hand washing with soap and hot water that is recommended before preparing the formula or meal, and how to use clean utensils and containers for mixing the formula. Also, before using tap water for formula preparation or to give as a beverage, we should let the cold tap water run for 2 minutes to remove any lid from the pipe that can be present. And they should follow the 2 hour rules of discarding any beverage or food that has been left at room temperature for 2 hours or longer. And we shouldn't use honey in the diet of infants. This will decrease the potential risk as of botulism if it was prevented from intake until 1 year of age. We will be taking a quick 10-minute break for Salat al-Asr as we continue our discussion. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, as we have briefly had an introduction into lifestyle medicine and what to eat and how it can affect our health from early infantile stages, we will continue our discussion with another common infantile disease that can affect our uh, health from infantile stage, which is large gestational age infant, known most commonly as infant macrosomia. So, infants whose weight is more than the 90th percentile for gestational age are classified as large for gestational age. And a birth weight that is height of 3,000 gram or 4,000 gram at 40 weeks is considered to be macrosomia. So, obesity and gestational diabetes will increase the risk of having a large for gestational age delivery. And infants may also be born to mothers who are multi-parents, therefore can also affect this condition. So macrosomia in newborn will raise the risk for birth-related problems that can include hypoglycemia, respiratory distress, aspiration pneumonia, bronchial paralysis, or facial paralysis as well. And these neonates will have a higher body fat and lower lean mass than the appropriate gestational age infant. Also, cord plasma adiponectin and leptin levels are very high in large for gestational age infants, and the adiponectin is involved in regulating the fetal growth. While after birth, a rapid adaptation is necessary for these infants to be able to maintain independent glucose homeostasis. So this process is compromised in large gestational age infants, and controlling the maternal weight gain remains an important goal for successful pregnancy outcome. Also, a high birth weight may eventually promote impaired glucose tolerance, diabetes, obesity, or even cancer. And the intervention objective will be to allow adequate growth rate and development, preventing rapid phase of hypoglycemia, maintaining energy intake at the desired level while allowing adequate growth in these infants, and preventing obesity and its consequences for the infant as much as possible. Also, monitoring the serum lipid or bilirubin as deemed necessary is recommended. While for food and nutrition, feeding the infant often, as indicated by the infant appetite and the goal weight pattern, is recommended, but controlling the total glucose intake if the infant shows signs of hyperglycemia. Also, altering the intake of fat as determined by the lipid profile and maintaining sufficient level of protein if the energy needs to be restricted from the carbohydrate or fat. So for the common medication used, insulin can be necessary to control hyperglycemia, but we should be aware of any excessive insulin which could aggravate hypoglycemia. And for herbs, they shouldn't be used for large gestational age infants because there are no controlled trials to prove their efficacy for any related problems. And for nutrition education, we should discuss the normal growth pattern as appropriate for the infant and reviewed in concrete with the pediatrician with signs of hyperglycemia and hypoglycemia that should be discussed with the caretaker to avoid the development of further complications. Also, reviewing the risk inherent in another pregnancy, especially if the mother has diabetes, and counseling can be beneficial in these cases. So, teaching the patient about appropriate food sanitation procedure and preparation, and following the 2 hour rules of discarding any beverage or food that has been left out at room temperature for 2 hours or longer to avoid the complication of food poisoning or contamination. And in contrary to large for gestational age, another very common problem is a low birth weight or prematurity. So every newborn is classified as one of the following. Premature, that is about 37 weeks of gestation, full term between 37 and 42 weeks of gestation, or postpartum, that is after the 42 weeks of pregnancy. So in prematurity, this is generally correlated with low birth weight, and low birth weight infants may be smaller for their date, having intrauterine growth retardation, or have dysmaturity. So a low birth weight infant weight is less than 2,500 grams, or the 10th percentile for gestational age at birth. While a very low birth weight infant will have a weight that is less than 1,300 calories a gram and are especially prone to nutrient channel deficiency, and infants who weigh less than 1,000 grams are called micropremeses. So low weight or BMI at conception or delivery, as well as poor weight gain during pregnancy, are associated with low birth weight, as well as prematurity and maternal delivery complications. So in the United States, infants who are born to mothers younger than 20 years or older than 35 years are more likely to be preterm than infants born to mothers between the ages of 20 and 35. So teens should be consulted to delay pregnancy until they are adults. So a low birth weight infant have a higher risk of mortality, morbidity, as well as poor growth. And typical problems of low birth weight or prematurity infants include hypoglycemia, hypothermia, jaundice or dry skin, and decreased subcutaneous fat, as well as anemia. So admission to the neonatal intensive care unit is common, especially for respiratory distress, and having adequate nutrition support almost immediately after birth is important to prevent growth restriction. So undernutrition at critical stages of development, especially of protein, will produce long-term short stature, organ growth failure, neonatal defects of the number of the dendritic connections, and later on behavioral as well as cognitive outcome or issues. So without nutrition starting immediately after birth, the infant enters a catabolic condition which limits the normal development and growth of these children. So during the first month after discharge, very low birth weight infants need to have nutritional support to help promote early catch-up growth and mineralization. So careful and frequent monitoring of the growth pattern is needed to prevent developmental delay. Also, premature breast milk has higher electrolyte, protein, and MCTs level than the mature breast milk. So breastfeeding in the NICU has been found to be very beneficial and has long-term benefit to the child and their catch-up growth as well. So feeding on demand is best for the children, but preterm infants have a lower energy expenditure when they are fed breast milk than when they are fed formula. So early feeding will increase the intestinal lactase activity, which is a marker for intestinal maturity and may even influence the clinical outcome. And nearly all studies have shown that minimal enteral feeding approaches promote the capacity to feed enterally and to enhance their growth outcome as soon as possible. So omega-3 fatty acids are important for healthy infants, and maternal dietary intake of DHA is important as well. So the brain, the retina, and the neural tissue are rich in DHAs and arachidonic acid, and therefore these should be recommended for the infant. While milk has a distinct advantage over formula in avoiding nephritizing enterocolitis and minimal enteral feeding will regimen can produce less of the NEC than the more aggressive enteral feeding. So caution must also be used in feeding as overfeeding has the potential to produce adipose tissue or even obesity, which then lead to insulin resistance, glucose intolerance, as well as diabetes. So supplementation for premature infant remain controversial, but glutamine doesn't decrease sepsis where selenium supplement has been found to decrease it. So overall, the American Diabetic Association recommends at least 5 medical nutrition therapy visits for high-risk premature infants to avoid these complications and these side effect development. So in the intervention objectives, binge feeding of distilled water or colostrum as soon as possible for infant without respiratory distress is recommended. So early feeding, that is 3 to 5 days after birth, tend to allow the babies to mature faster and they have fewer days of intolerance and a shorter hospital length of stay with earlier tolerance of full feeding as well. So the intervention objective also include encouraging the mother to breastfeed as long as it is possible, with taurine that is especially important nutrient in breast milk. And if tube feeding is needed, the mother can accept breast milk to be given to the infant, as it can also be supplemented to meet the special needs for these infants. So supplement with essential fatty acid and DHAs assure adequate intake of folate and vitamin B12 to prevent anemia and other associated complications as well. And providing glucose as soon as possible after birth to adjust according to frequent measurement of the plasma glucose to achieve and maintain normoglycemia. Also, when possible, using enteral feeding instead of parenteral to reduce the onset of cholestasis and osteopenia in these children, and gradually increasing the energy and protein to meet the need of rapid growth while for protein, ensuring a proper weight to casein ratio. So, with parenteral feeding, including amino acids in proper amounts, especially cysteine, taurine, and tyrosine with glycine and arginine, is recommended. And intravenous tropamine can be used, but we should be sure that selenium is provided as well. So, promoting catch-up growth and development is required. And while long-term effects such as metabolic syndrome occur among low birth weight or premature infants, later in life will be effective for the nutrition support that is needed. So prevent illnesses, rickets, respiratory distress, hypoglycemia or hyperglycemia with NACs, infections, obstructive jaundice, and tyrosinemia is our primary intervention objective. In addition, while in the radiant warming, we should provide water at about 60 to 80 milli per kg of body weight and gradually increase this content to 150 milli per kg. Also, adding electrolytes on the second day is recommended to ensure that they get all the required nutrients and electrolytes from their diet. So on day one, breastfeeding or giving glucose, advancing by 20 milli per kg on a daily basis is recommended, and progressing to special formulas such as Similac, Special Care, or Enfamil premature formula is also recommended. So within the 7 day, the diet should provide about 120 to 150 kilocalorie per kg of body weight on a daily basis, and carbohydrate should be about 40 to 45% of these intake, while protein should be specified according to age. So tube feeding initiation starts at 10 to 15 milliliter an hour at 1/4 strength, and then progressing as the tolerated desired rate. And special products have been developed for very low birth weight infants, as there are numerous supplements available to be given to these children. So, in addition, using total parenteral nutrition, if not feeding by day 3, that include the glucose infusion, that is about 15 milligram per kg per minute. And if the needs are similar to the enteral need, but having crystalline amino acid infusion will promote positive nitrogen balance by using 1 gram per kg as soon as possible. Also, there may be subtle and delayed hunger cues from the infant, and if there is a poor sucking or swallowing instinct that exists, then the infant may need gavage feeding and feeding every 2 hours, or even using continuous drip feeding and changing to bolus feeding when full strength is being given. Also, the micronutrient need of a stable preterm low birth weight infant may be as following with high level of calcium, vitamin E, as well as iron in the formula with vitamin D, folic acid, sodium, and more importantly, we should avoid hyponatremia. Also, giving them vitamin C with phosphorus is very important. So, monitoring the need for vitamin A and B12 with magnesium and zinc is recommended, while other nutrients should be provided according to the dietary reference intake table for the newborn babies. While for the fat, it should be between 5 to 7 grams per kg to meet half the energy need without giving them excessive carbohydrates. So, having soybean oil providing essential fatty acids in the form of linoleic acid and exogenous carnitine may be needed to take the essential fatty acid into the mitochondria, while inositol may be needed if there is respiratory distress. So, nutrient intake will depend upon the patient condition and their health status or associated complications. While for the common medication used and their potential side effects include hyperkalemia and hyperglycemia, and with the use of continuous intravenous insulin that is needed. So sometimes supplemental thyroid hormone or iodide might be prescribed, and other medication can be used for associated underlying conditions. Therefore, we should monitor for their side effects. Also, using caution with vitamin supplement and early vitamin supplementation can promote increased asthma, especially in Black children. And herbs shouldn't be used for low birth weight infant or premature infant because there can be any allergic reaction or asthmatic reaction. Therefore, they should be avoided. Also, glutamine supplementation doesn't seem to elevate the necrotizing enterocolitis, therefore should be recommended in the shouldn't be recommended in these cases. Also, teaching the caretaker or parent about increasing nutrient need for low birth weight infants with special formula that have 80 kilocalorie per deciliter and have MCT oil with extra protein, calcium, phosphorus, and sodium is recommended. So emphasizing the progression of infant feeding for an adequate growth pattern and weight, and catch-up is common by 2 to 3 years of age in this population. Also emphasizing the impact or the importance of nutrient density for growth, such as vitamin E and B6, as well as not overfeeding with excessive non-protein energy that is stored as fat regardless of their source. Also, we should monitor their tendency to aspiration for lactose intolerance and for other problems. Therefore, we should feed them slowly to avoid these side effects. So the child may benefit from the WIC program if available, and follow up in the clinic or home visit is recommended, with offering tips such as using small frequent feeding and using quiet calm environment for feeding as well. Also avoid using honey for their potential risk of botulism under 1 year of age. So we have previously discussed how lifestyle medicine can affect our health starting from the infantile period and how this can later on affect our health as adults. So another important lifestyle medicine factor is the carbohydrate and diabetes mellitus and how these two correlate and can cause affect our health conditions. So diabetes is a group of metabolic disease that is characterized by hyperglycemia resulting from a defect in insulin secretion or insulin action or even both. So hyperglycemia of diabetes is associated with long-term damage, dysfunction, and failure of various organs, especially the eyes, kidneys, the nervous system, heart, and blood vessels as well. So diabetes can affect about 24 million Americans and 54 million are estimated to have pre-diabetes, while over 200,000 individuals die each year of related complications. So diabetes is divided into distinct types, which are type 1 diabetes, 2 and gestational diabetes, with other types of diabetes such as maturity onset diabetes of the young. So in type 2 diabetes, this comprises about 90% of all diabetes cases that is affecting both by being affected by both the genetic factors and environmental factors as well. So the adiposity associated inflammation and insulin resistance are strongly implicated in the development of type 2 diabetes as well as the metabolic syndrome. So activation of the nuclear transcriptor factor beta has been linked with a variety of inflammatory diseases, including diabetes. While antioxidant species, herbs, and omega-3 fatty acids can help to suppress the inflammatory pathway, which can sometimes lead to diabetes. So amino acids are also important. They support the cell signaling, gene expression, and hormone synthesis. So while physiological concentrations of amino acids and their metabolites, such as nitric oxide, are required to elevate the level of their product, these can contribute to oxidative stress and further damage to the body. Also, dietary supplementation with one or a mixture of arginine, cysteine, glutamine, and other amino acids can be beneficial for ameliorating the health problems, including fetal growth restriction, neonatal morbidity, and mortality with obesity and CVD, also metabolic syndrome and infertility. So the etiologic classification of diabetes is type 1 diabetes that results from autoimmune beta cell destruction that is usually leading to absolute insulin deficiency. And in type 2 diabetes, this results from a relative deficiency or insulin resistance in most cases. While in gestational diabetes, this is diabetes that is first diagnosed during pregnancy. And there are other specific types of diabetes that are due to other causes, such as genetic defect of beta cell function, also known as maturity onset diabetes of the youth. Also, the genetic defect in insulin action and diseases of the exocrine pancreas, such as pancreatitis or neoplasia. Also, in cases of endocrinopathies, acromegaly or Cushing syndrome, as well as drug or chemical induced, such as nicotinic acid or glucocorticoid medication, and infections, including in cases of congenital rubella or cytomegalovirus, and other genetic syndromes that are sometimes associated with diabetes include Down syndrome and Turner syndrome, as well as many others. So the general classification of diabetes is type 1, that's the immune mediated, and type 2, the insulin resistant, and type 3, the maturity onset diabetes of the young, and 4, gestational diabetes. So in type 1, this is usually the patients are not usually obese, but often will have decent weight loss. They will have short duration of symptoms such as thirst and frequent urination, and the presence of ketones at the time of diagnosis, with about 35% presenting with ketoacidosis. So there is often a honeymoon period after the blood sugar that are in control, during which the need for insulin diminish for a while, and having low doses of long-acting insulin, such as glargine, can prolong the honeymoon phase of these conditions. Also, the ultimate complete destruction of the insulin-producing cell, needing exogenous insulin for survival, and having ongoing risk for ketoacidosis, and only about 5% will have family history in a first or second degree relative of diabetes. While on the contrary of type 2 diabetes, they are usually overweight at diagnosis with no history of weight loss. They usually have sugar in the urine but not ketones, and 30% will have some ketone in the urine at the time of diagnosis. And about 5% will have ketoacidosis at time of diagnosis, and often will have little or no thirst at all, and a minimal increase in urination, but they will have strong family history of diabetes. And about 45 to 80% will have at least one parent with diabetes, and it can span across many generations of their family. And about 100% of them will have first or second degree relative with diabetes, and they are typically from African, Hispanic, Asian, or American Indian origin. So disorders that are likely to cause insulin resistance are common, and about 90% of children with type 2 diabetes have dark, shiny patches on their skin that is known as acanthosis nigricans, which are most often found between the fingers and between the toes, or even on the back of the neck, that is sometimes regarded as having a dirty neck, and in the axillary creases. So, in the maturity onset of diabetes of the youth or of the young, this is a rare form of diabetes with several varieties that exist from the same condition, having an early stage of onset, about 9 to 25 years of age, with autosomal dominant inheritability. So, results from defects to the insulin producing cell caused by genetic factors in the pancreatic beta cell function has been found, and symptoms can run the gamut from the mild elevation in the blood sugar to the severe disturbance. So, moody can occur in all ethnic groups, and gene abnormalities are rare and can only be identified through testing that is currently available only in research laboratories. And usually, the patients in this condition are not obese. So, environmental stressors such as illness or puberty can unmask the genetically limited insulin secretory reservoir in patients with undiagnosed MODY. And unlike type 1 diabetes, it doesn't cause polyuria or polydipsia or even extreme hunger. And the primary goal is euglycemia in these cases. Also, fasting insulin and C-peptide levels are usually normal or elevated slightly. And for assessment in diabetes, we should have assessment for mood disorder, contraception with reproductive and sexual history, current treatment, medication, meal planning as a result for glucose monitoring and patient use of data. Also, eating pattern with the nutritional status and weight history with growth and development in children and adolescents is recommended. Also, having their exercise history, their family history of diabetes, the frequency, severity, and causes of acute complications such as ketoacidosis and hypoglycemia. Also, the history and the treatment of other conditions, including endocrine and eating disorders, with infections, including those on any part of the skin or dental or urinary tract prior to their current one. So the laboratory tests with symptoms and special examination that result with the related diagnosis include lifestyle, cultural, psychosocial, educational, and economic factors that influence the management of diabetes, while other medications that may affect the blood glucose level with previous treatment programs and management, self-management education for the management of these conditions, and having their A1C levels recorded and reported accordingly to ensure that they get the needed help when there is hyperglycemia. Also, the risk factors for atherosclerosis include smoking and hypertension, also obesity, dyslipidemia, and family history as well, with symptoms of celiac disease in type 1 diabetes patients as well can be detected or can be found. And symptoms and treatment of chronic eye, kidney, and nerve disease is also recommended in patients with diabetes and having assessing the function of the heart, the peripheral vascular, foot and cerebrovascular complications that are associated with diabetes, and controlling substance use or smoking behavior. Also, evaluating for diabetes include screening for prediabetes and diabetes in high-risk asymptomatic undiagnosed adults and children. Also, having oral glucose tolerance tests that may be considered in patients with impaired fasting glucose to better define the risk of diabetes. And testing for diabetes should be considered in all individuals at the age of 45 and above. So the classic symptoms of diabetes include polyuria, polydipsia, and unexplained weight loss, plus one of the following conditions. The first is symptoms of diabetes and a casual blood glucose level of 200. And casual is defined as any time of the day without regard to the time since last meal was consumed, and fasting blood glucose level with 2-hour blood oral glucose tolerances, or both that is appropriate with the reference value, and conducting 2-hour blood glucose level during or GGT. Also, for nutritional therapy, this is the medical nutrition therapy has replaced diet therapy, and there is no single diabetic or dietary recommendation for patients with diabetes, but the recommended diet is at an individualized nutrition prescription based on the assessment finding and the treatment plan. So, medical nutrition therapy considers the usual eating habits and other lifestyle factors with strategic patient counseling that should identify the benefits of the plan, self-efficacy, their obstacles, and lifestyle changes that the patient is willing to make. And these interventions will help to reach the desired outcome that the patient requires. Also, using open-ended discussion and counseling will encourage the client to assess and determine a realistic self-management plan, and medical nutrition therapy should be offered in phases according to the patient comprehension and readiness. Also, screening for diabetes is outlined, and the nutrition care process should include assessment, nutrition diagnosis, intervention, and followed by monitoring and evaluation. So, monitoring of the blood glucose level, medication, physical activity, behavior modification, and evaluation of cardiovascular disease or renal status are all relevant to avoid the development of severe complications. In addition to this, preventing complication is essential to ensure the best outcome for the patient's health condition. So, a diabetes educator is defined as a health professional who has mastered the core knowledge and skills, communication, counseling, and education of these factors, with the credential of certified diabetes educator that is designed as a professional who have at least 1,000 hours of direct diabetes teaching and to have successfully been completed and examined as well. So an advanced credential has been developed for registered dietitian, nurses, and pharmacists who has advanced degrees and meet the experimental requirements, and this is known as the BCADA. While for the key concepts in diabetes management, these include, first of all, glucose control as the most important thing. So improved glycemic control will benefit people with either type 1 or 2 diabetes. Also, for every 1% reduction in A1C levels, then the risk of developing microvascular diabetes complication will drop by 40%. So A1C is the primary target for glycemic control. And having a more stringent glycemic goals with A1C less than 6% may further reduce complication at the cost of increased risk of hypoglycemia. And a less intensive glycemic goal may be indicated in patients with severe frequent hypoglycemia. While for the postprandial glucose, this may be targeted if the A1C levels are not met despite reaching for prenatal and glucose goals, and the goals should be individualized, and lower goals can be responsible for reasonable based on benefit for risk assessment. So there are certain populations such as children, pregnant women, and the elderly who require special consideration when they have diabetes. So their reference value for the pre-prandial bedtime and A1C values or the reference values are different from those that we can see in male adults who have the same condition. While another important aspect is blood pressure control. The goal of the blood pressure is to be below 130 over 80 and restricting the sodium intake to 2,400 milligrams per a day to assist with the content of hypertension. So blood pressure control can even reduces the risk of cardiovascular disease by 30 to 50% and can even reduce microvascular disease by about 33%. And in general, for every 10 mmg Hg reduction in the systolic blood pressure, the risk for any complication in relating to substance use is reduced by 12%. So, in addition, having improved control of cholesterol or blood levels, including the HDL and LDL with triglyceride, can reduce the risk of cardiovascular complication by about 20 to 50%. And the goal is that the total cholesterol minus the HDL should be about 130 milligram per deciliter, and the triglyceride should be about 150. And detecting with treating any diabetic eye disease with laser therapy can even reduce the development of severe vision losses by an estimate of 50 to 60%. So comprehension, care and programs such as reduced amputation rate by 45 to 85%. While another important complication is kidney disorder, as detecting and treating early diabetic kidney disease by lowering the blood pressure can reduce the decline in the kidney function by about 30 to 70%. And having angiotensin converting enzyme inhibitors and angiotensin receptor blockers are most effective in reducing the decline in the kidney function as well. So with the protein intake that is greater than 20% of the total energy intake, there is an association with increased albumin excretion rate in these patients. So once albuminuria is present, then we should reduce the protein intake to the normal reference range, and microalbuminuria can be between 0.8 gram per kg with macroalbuminuria. So there may be a benefit to lowering the phosphorus intake to about 500 to 1000 milligram per a day. And there is evidence for benefits for the renal function, glucose, lipids, and blood pressure from weight maintaining diet, and having collaborative multidisciplinary teams that are best suited to provide such care for people with chronic conditions such as diabetes and to empower the patient's performance and appropriate self-management. So medical nutrition therapy will be provided by the registered dietitian to the patient with type 1 diabetes and type 2 has been shown to improve glycemic outcome. So it is also important to address any culturally specific eating habits. For example, recent study in South Dakota found that diet patterns after the historical hunter-gatherer type diet to be 25% supplied of energy from protein and providing better blood glucose control and even lowering the circulating insulin levels in these Northern Plain Indians in type 2 diabetes. So the same may be true for other high-risk groups, but these need to be studied as well. So a very important aspect to understand about diabetes and glucose with carbohydrates is the glycemic load or the glycemic index for the carbohydrate content. So even though that starches do have different glycemic responses, the first priority should be given to the total amount of carbohydrate consumed rather than the source of the carbohydrate. So if the use of glycemic index is proposed as a method of meal planning, then the dietitian should advise the patient evidence of effectiveness of this strategy. Also, using these can be effective strategy as studies comparing the high versus low glycemic index diet reports a mixed effect on A1C level. So in the pre-diabetes status or stage, this is an impaired glucose tolerance that is distinguished or distinguishes people who are at increased risk of diabetes, and it can people with pre-diabetes have IFG or IGT or even both, with more than 54 million Americans are affected to be in the pre-diabetes stage. Also, in the pre-diabetes, having elevated triglyceride and low HDL cholesterol level are risks for type 2 diabetes and inflammation with insulin resistance that is also impaired. So, NIH has also reported that smoking will increase the risk of insulin resistance and pre-diabetes, and under recent criteria, normal blood glucose level should be 100 milligrams. So most people with pre-diabetes go on to develop type 2 diabetes within 10 years of development or diagnosis, unless they make some lifestyle changes. So studies have evaluated various interventions among people with GP and risk factors for the development of diabetes, and the diabetes prevention program was a large prevention study of people who are at high risk of diabetes. So half of the participants had MATS at the beginning of the study, and lifestyle intervention with metformin therapy has reduced the development of the syndrome in the remaining participants. Also, lifestyle intervention, including modest weight loss from a low-calorie, low-fat diet, and increased moderate intensity with physical activity such as walking is recommended. So, people who are treated with an intensive lifestyle intervention can reduce their risk of developing diabetes by half over 4 years, and whereas people who are treated with metformin reduce their risk by only one third, and metformin is most effective among younger, heavier people. And in the stop NIDVM trial, they found that treatment of people with IGT with the drug Acorbaz reduces the risk of developing diabetes by 25% over a 3 year period. So the benefits of weight loss and physical activity strongly suggest that lifestyle modification should be the first choice to prevent or even delay the diabetes, and the dietitian play an important role in the nutrition education and counseling for these behavioral changes. So in the pre-diabetes, there are classification and tests as well. The most important test is the impaired glucose tolerance test. Other used diagnostic tests include oral glucose tolerance test and 2-hour plasma glucose assessment test. There is also the impaired fasting glucose, and these testing values include the fasting plasma glucose after 8 hours of fast, and it should be between 100 to 125. And for the intervention, the objectives are to increase the probability of reverting from the IGT to normal glucose tolerance. In addition, preventing further insulin resistance, hyperglycemia, or even progression to diabetes, and having modest weight loss of about 5 to 10% of body weight, and modest physical activity of about 30 minutes daily is recommended as the required goals. So walking can be encouraged for most people, and preventing or delaying heart and kidney disease, stroke, eye disease, and other undesirable conditions is recommended. Also designing a program that includes elements from the successful DBP trial, such as clearly defined weight loss goal and physical activity goals, individualized diet, and intensive ongoing intervention depending upon the condition. So for the food and the nutrition intervention, these include controlling carbohydrate intake and limiting excessive added sugars. Also encouraging less processed carbohydrate and fiber food sources with individualized according to lab, work, BMI, and other risk reduction requirements, and maintaining the protein at 20% of the total energy. Also planning fast at about 30 to 35% of the total calories, is recommended, and having low saturated fat and cholesterol may be needed to prevent or even treat hyperlipidemia. So having moderate reduction in the total energy intake is important, with modest weight loss of 5 to 7% of the body weight may be recommended, and having sufficient intake of minerals such as magnesium can be protective, while including more almonds, whole wheat, and cooked spinach or vegetables is recommended. So excessive iron and selenium should be avoided, as studies suggest that high intake of these two causes deposits in the internal organs of the body, including more specifically the pancreas. So including adequate intake of fiber and low-fat vegan diet has been found to improve glycemic and elevated lipid levels. Also, essential oils such as pancake, cinnamon, cumin, and oregano can all enhance the insulin sensitivity, and cinnamon may improve the blood sugar level as well as the lipid level. When feeding is needed, there is insufficient evidence to support their use as well. And for nutrition education and counseling, community health workers may be trained for peer counseling when administered through diabetes care centers, and having a lifestyle weight loss intervention has a goal of 7% weight loss achieved through increased physical activity, and decreasing their caloric intake is also recommended. So having monthly small group education session for a year are recommended, and weight loss is a key goal, with discussing food and meal patterns that will help to reduce the risk factors for the individual patient as well. So the look ahead action for health in diabetes trial participate of overweight adults who are diagnosed with diabetes exceed the recommended intake of fat, saturated, and sodium, which may contribute to increasing the risk of CVD and other chronic diseases as well. Therefore, it is important to address the total fat intake and to suggest increasing intake of antioxidant-rich high-fiber food as well. So having vegetarian diet can also be safely recommended for these patients, and promoting 8 ounces or more of low-fat milk and an ounce a day of nuts, filtered coffee, and cinnamon with plenty of non-starchy vegetables is recommended as well. So also exercise can seem to have or promote more reliable glycemic control compared with specific dietary protocols, and promoting physical activity that matches the client's interests and ability, with discussing how to handle the medication changes accordingly. Also, for patient education and foodborne illnesses, if the patient is using home tube feeding, then we should teach them on appropriate sanitation processes and food handling procedures. So in type 1 diabetes, uh, this is the absolute deficiency type with total failure to produce insulin, and previously used term includes type 1 diabetes or insulin dependent diabetes. And this involves the autoimmune destruction of the pancreatic beta cells. So the onset often follows viral infections such as mumps that is usually starting in children or young adults, affecting about 10% of the cases of diabetes. And beta cell dysfunction or damage is often more severe in patients diagnosed before puberty. So the signs and symptoms include polyuria, that is frequent urination, and polydipsia, that is excessive thirst, polyphagia, weakness, fatigue, irritability, and sudden weight loss. Also, there are some genetic markers that indicate diabetes, including the pathogenesis of most DM that is multifactorial, including both genetic and environmental factors or conditions. Interleukin, HLA, or other genes has been found to be associated with the risk of developing type 1 diabetes. Also, much more research is needed to clarify how these present in various haplotypes or ethnic groups and how they can affect health conditions. And hormonal imbalance will control key proteins that regulate folate and homocysteine pathways as well. So having poor folate status has been associated with endothelial dysfunction in adolescents with type 1 diabetes, and these factors of these genes can be affecting the condition as well. So warning signs of type 1 diabetes include drowsiness, lethargy, extreme thirst, frequent urination, heavy labored breathing, glucose or ketones in urine, fruity, sweaty, wine-like odor in breath, and increased appetite, sudden weight loss, and stupor or unconsciousness that can also be detected. So the diagnosis will include fasting plasma glucose test or oral glucose tolerance test, and FPG is the preferred method for these conditions, with oral glucose tolerance test following. So A1C test is not recommended for diagnosis, but fingerprint tests are also not valid in these cases. And having serious complications begin early than previously thought to be, as well as glucose control really matter as proven by the results of the diabetes control and communication trial as well. So more than 65% of people with diabetes will die from heart disease or stroke, and diabetes is the chief cause of blindness, renal failure, and amputation, and is also the leading cause of birth defects. So intensive therapy to achieve near normal glucose level will result in lower onset and progression of complication, but caution is needed to prevent hypoglycemia, especially in the very young, 6 years, and those with vision loss or kidney disease as well. So the fasting blood glucose should be measured 3 to 8 times on a daily basis when on a new insulin regimen, and this may be tapered down when stable, but protein and the nutrient metabolism are affected by the insulin availability as well. So the long-term effect of diet high in protein and low in carbohydrates are still unknown at this time, and vitamin with mineral intakes are being studied for their various impacts on blood glucose levels. So individuals who are using insulin should eat at consistent time that is synchronized with the time of action of the insulin preparation that they are using, and they should monitor their blood glucose level and determine their required insulin dose for the amount of food that is usually eaten. Also, intensified insulin therapy, including multiple daily injections, continuous subcutaneous insulin infusion with an insulin pump, and even rapid-acting insulin will allow more flexibility in the timing of meals and snacks, as well as in the amount of food that is being consumed. So the medical costs for patients with diabetes account for a significant percentage of all healthcare costs, and the national standard for diabetes self-management have been written to support the team approach of the patient care. So the use of the evidence-based medical nutrition therapy can lead to effective lifestyle changes, as well as using technologies to track quarterly their weight and lab value. That is an effective way to help the patient with their self-management. So multidisciplinary team interventions are suggested to help improve the patient's A1C levels and to reduce the complication with the hospital readmission and hospital stays as well. So the American Diabetic Association would recommend a specific number of medical nutrition therapy visits to promote the desired outcome of these interventions. So for the intervention, the objectives are to have individualized medical nutrition therapy as needed to achieve treatment goals, preferably provided by a registered dietitian familiar with the component of diabetes medical nutrition therapy. And the recommended visits will depend upon the time between the diagnosis and the encounters to ensure that the patient has the best outcome. And addressing the metabolic abnormalities of glucose, lipid, and blood pressure values with meeting the specific need of the patient, modifying drug therapy to enhance the outcome of the quality of life as well as recommended. And regularly evaluating the food and the nutrition history with their physical activity levels, with the activity pattern and weight gain to ensure that they are on the right track. Moreover, developing food meal planning with clients and sharing the plan with the medical team so the insulin regimen can be integrated and adjusted accordingly. And having in hospital setting with avoiding the use of restrictive diet is recommended as well. So, promoting lifestyle changes according to the patient readiness, education level, and skills is also recommended. And early referral for lifestyle changes and advice yield the most benefits for these patients as well. And planning the meal plan with exercise, medication, and achieving the blood glucose lipid goals is recommended, while minimizing the intake of trans fatty acids, saturated fat that should be 7% of the total calorie intake as well. And preventing early onset of complications by controlling glucose and lipid and blood pressure is also recommended as such. So if there are any complications, we should delay or even prevent the consequences. And the DCCT intensive therapy group had substantially lower complication rates with fewer than 1% became blind, requiring kidney replacement, or even had amputation because of their diabetes. Also, both the amount in grams of carbohydrate as well as the type of carbohydrate in food will influence the blood glucose level, and we should monitor the total grams of carbohydrate. That remains a key strategy in achieving the glycemic control. Also, we should teach the individuals on how to use carbohydrate with counting and how to adjust insulin doses based on planning carbohydrate intake and promoting self-monitoring of blood glucose values with multiple times per day and often during the period of illnesses. For food and nutrition, having a meal plan based on the individual usual food intake should be used as the basis for integrating the insulin therapy into the usual eating and exercise pattern. Also, choosing a variety of heart healthy food, including an average of 5 servings of fruit and vegetables and 6 servings of grains with 3 whole grains and 2 servings of low fat dairy products. In addition to this, food in the meat and fat group doesn't directly affect the blood glucose level, but discouraging the meal skipping is recommended, and determining appropriate energy intake for their age is also required. So the pregnant and growing individual should receive more of the than the sedentary people caloric intake, and the undernourished or active should receive the highest amount of these calories. And reassessing as activity or life stages changes is also required. So the monounsaturated fatty acid and carbohydrate combined should provide about 60 to 70% of the daily energy intake, and it should limit the saturated fat to 10% of the energy intake as well. Also using a plan that includes carbohydrate at about 45 to 65% of the total energy intake each day to prevent ketoacidosis is recommended. In addition to this, applying carbohydrate counting, dietary guidelines, or my pyramid food guidance principle is also recommended, and focusing on carbohydrate more than the total energy source of the carbohydrate is recommended. Also, determining the insulin to carbohydrate ratio for each individual and having one carbohydrate unit equaling 15 grams of carbohydrate of a standard starch, fruit, sweet, or milk serving based on the 15-gram carbohydrate ratio method. So for carbohydrates, they can provide consistent intake with each meal and snack with a set of dose of insulin. And each of the following portions is one serving of carbohydrate, such as one slices of bread and half an ounce or 1 ounce of cereals or half a cup of cooked dried beans and 1 cup of milk. All are regarded as one serving of carbohydrate. Also, fruit, one small fresh fruit is equal to one serving of carbohydrate, and half a cup of cooked potato or beans is equal to one serving of carbohydrate. So, most women will need about 3 to 4 carbohydrate servings at each meal, and men generally need about 4 to 5 serving of carbohydrate at each meal as well. While the active young women will need about 2,500 calories, about that 75 to 90% to 90 grams of carbohydrate, and men will need more of about 90 to 100 grams of carbohydrate per serving. So using 1 to 2 carbohydrate choices for the snacks, depending upon the body size and activity level, will determine the number of choices that is needed. And it should include plenty of fiber from rice, beans, and vegetables, and fruit and vegetables as well. And recommendations for fiber intake are similar for those who doesn't have diabetes, in about 14 grams per 1,000 calorie per day. So whole grains are a good source of vitamin E and fiber and magnesium. We will be taking a 15-minute break for Salat al-Maghrib and then continue our discussion with the impact of lipoprotein on cardiovascular disease. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, in our webinar, we have discussed the impact, having an introduction into lifestyle medicine and the impact of uh, early life nutritional intervention on eating properly, as well as the impact of carbohydrates on diabetes. And now we will continue with lipoprotein and cardiovascular health. So, first of all, cardiovascular disease include hypertension, coronary heart disease, heart failure, congenital heart defect, and stroke. So it accounts for thousands of deaths annually, and it accounts for almost 50% of deaths in industrialized nation at all in general. So despite the dramatic decline in mortality over the past 3 decades, chronic heart disease remains a leading cause of death and disability worldwide. And death rates for women have not declined as much as those for men in general. So, a classic cardiovascular risk factor are common but largely undertreated and under-controlled in many regions of the world. And about 70% of CVD can be prevented or even delayed with dietary choices and lifestyle modification as well. So there are about 12 modifiable dietary and lifestyle and metabolic risk factors, including high blood glucose level, low density lipoprotein, cholesterol, and blood pressure, as well as being overweight and obese in general. So many patients with classic cardiovascular disease risk factor can achieve a risk reduction goal without medication within 3 months after initiating their therapeutic lifestyle changes as well. And TLC include exercise training, nutrition counseling, and other appropriate lifestyle interventions based on several well-established behavior or change models as well. While the benefits of the primary prevention are greater for people who have risk of multiple factors, with the secondary prevention that is beneficial for the high risk and low risk patients as well. And adult treatment panel reports provide scientific evidence for dyslipidemia management as well. While the dyslipidemia with small dense LDL molecule is atherogenic, the dietary cholesterol is only one of many factors that play a role in the etiology of heart disease. And cholesterol is considered to be readily made from acetate in all animal tissues and has many roles in the body to play. So studies have shown a link between the intake of fruit and vegetable and whole grain with the protection against chronic heart disease due to their content of fiber, vitamin, mineral, and phytochemical content in general. So folate, vitamin B6, 12, and E with vitamin C and flavonoid all have a total dietary pattern that can be protective in these factors as well. And in specific analysis of the low-fat diet, there was no significant effect on the incidence of stroke and chronic heart disease, but there were small reduction in LDL and total cholesterol level with the diastolic blood pressure factors and these levels as well. So there are indirect benefits of diet that is lower intake of saturated and trans fat and has higher intake of vegetable and fruit using specific types of fats, including fish oil as well as fish and perhaps energy restriction as well. Also, an elderly dietary index is useful for assessing the risk factor for CVD in older adults as well. And because kidney diseases is a risk factor for mortality and CVDs in older adults, having elevated cystatin C and albuminuria are independent with graded risk factors for CVD and mortality as well. Also, for the nutrition counseling, it should be received with high priority both in medical training and in patient care for both men and women as well to ensure that they have the best outcome as well. And the American Dietetic Association estimates the cost saving per cardiovascular cases to be nearly $2,500 annually, with the nutrition, counseling, therapy reduction, the need for many medications. Also, some key components of the counseling include reduced caloric intake, reducing total fat, saturated fat, and all type of fat, including cholesterol, and increasing the dietary fiber from fruit and vegetables specifically, and increasing micronutrients with increased plant protein, while reducing the portion of highly processed food and adopting Mediterranean dietary pattern with adding physical activity and smoking cessation to the equation. So, according to the Women Nutrition Intervention study that used a low-fat eating plan that served as a model for implementing a long-term dietary intervention in clinical practice is recommended as well. And in the future, the development of functional food that contain ingredients which have prevention benefits will be important as well. While products that contain green tea with certain ECGs, omega-3 fatty acids, folate, vitamin C, and flavonoid will be popular as well. Also, hypertension can increase the risk of coronary artery disease, MI, stroke, renal failure, and heart failure as well. So, careful attention to hypertension is essential in these cases as well. So, the sodium and other minerals, according to the African Americans and Hispanic of the Caribbean descent, tend to have even a higher prevalence of hypertension. And vitamin D can play a role in heart health as well. Also, increasing sun exposure or using supplements can be indicated in these cases, while there are also many benefits in reducing sodium intake, while increasing the intake of potassium, calcium, and magnesium with whole grain can be indicated as well. So a rich source of magnesium can include nuts and seeds, soybean, and tofu, that green vegetables as well. And for chloride, restriction of about 2,300 milligram on a daily basis to replace the losses in respiration is recommended. And potassium should be no more than 4,700 to lower blood pressure and reduce the risk of kidney stones and bone losses. While for sodium, 1,500 milligram for adults is recommended, and this will decrease as the person gets older as well. And having a highly active people may need to be more. If the sodium is sensitive, therefore the intake may need to be lowered, while the upper limit is set to be 2.3 gram of sodium, and water should be at 91 ounce on a daily basis for women and 125 ounce for men in general. Also, a common cardiovascular disease that relates to lipoprotein is angina pectoris. So it involves the external chest pain or discomfort from decreased blood flow to the myocardium from a decreased oxygen supply. Often that happens during exercise as well. So having a traditional risk factor include tobacco use, hypertension, diabetes, dyslipidemia, and obesity as well. So having angina can also occur from anemia, hyperthyroidism, aortic stenosis, and other cardiomyopathies, which is an area of abnormal thickened heart muscle that impairs the heart pumping action and can cause angina during shortly after exercise. So, in a stable or a classic angina, this occurs after execution and is relieved by rest and vasodilation. It can last about 3 to 5 minutes. With intractable angina that causes chronic chest pain that is not relieved by medical treatment. And if it was diagnosed early, then the chance of living longer is at least 50%. And in addition, vitamin D provision through sun exposure or supplementation can be indicated when the serum levels are below 20. So, in an ABCD approach that is effective, A is for antiplatelet therapy, anticoagulant, and angiotensin converting enzyme inhibition, and angiotensin receptor blocker, while the B is for the beta blockade and blood pressure control, and C is for cholesterol treatment and cigarette cessations, and D is for diabetes management with diet, and E is for exercise. So management of factors leading to the metabolic syndrome is also recommended, and having cardiac rehabilitation will help to improve aerobic exercise capacity, physical functioning, and mental depression as well. And having an invasive treatment for chronic stable angina are only needed in small number of patients and currently using percutaneous coronary intervention to improve the quality of life by relieving the angina in patients with stable CAD. So the intervention objectives include relieving the chest pain and improving the circulation to the heart, also increasing the activity as tolerated with gradual increase in exercise, especially throughout program in cardiac rehabilitation. Also, maintaining adequate rest period is required and increasing activity with maintaining weight or lose weight to obese. Also, reducing the symptoms of the metabolic syndrome where present and avoiding constipation with training and controlling blood pressure and lowering the elevated serum cholesterol as well. Also, having small frequent feeding rather than three larger meals is indicated with increased fiber as tolerated, including adequate fluid intake and increasing intake of fruit and vegetables. In addition to restricting the saturated fat intake and dietary cholesterol with limiting stimulants such as caffeine to less than 5 cups of coffee or equivalent daily, and energy drinks may contain about 50 to 500 milligrams of caffeine, therefore should be limited. Also, promoting caloric control if the patient is overweight and modifying by age and gender. And if their THCY levels are high, then we should add more food with folic acid, vitamin B6, and 12 to the diet. And a Mediterranean diet that is rich in alpha-linoleic acid is effective for many patients, and it is prudent to increase the intake of olive, soybean, and canola oil with seeds and walnuts as well. And nuts can also contain flavonoids and phenols, and therefore considered to be protective and should be used often. And beta carotene supplements actually seems to increase angina with dietary sources of carotenoids that are healthier choices for these factors as well. In addition, having antiplatelet therapy or anticoagulant therapy will be prescribed, but we should monitor for vitamin K intake with warfarin. And calcium channel blockers should also be recommended for these factors. And these drugs can also cause heart failure or dizziness. Therefore, we should avoid taking with alloy or any other berry or sienna leaf factors as well. And for herbs, the patient shouldn't take herbal and potential supplement without discussing it with the physician first to avoid any complications. Also, the patient will require stress management, activity, and education about proper eating habits and discussing the role of nutrition in maintaining wellness in CVD. Also discussing in particular fiber, total fat intake, potassium, and sodium, as well as calcium and other nutrients for them. Also discussing the importance of weight control and reduction of cardiovascular risk and elevating the head of the bed to about 30 to 45 degrees for greater comfort, and using unstable angina that is dangerous and should be treated as potential emergency condition as soon as possible. So a careful food handling will be important, and hand washing and sanitation procedure should also be implemented to the patients as well. And for arthritis, this involves the inflammation of the artery walls with decreased blood flow. And with a thickening of the lining and reduction in the blood flow, this condition is linked to polymyalgia, the rheumatoid arthritis, and women who are older than 55 years of age are twice as likely to have the condition compared with other people. So the intervention objective should be to prevent the stroke and blindness, which are potential complications of these conditions. Also to reduce inflammation, to promote increased blood flow through the affected vessels, to modify the intake according to requirement and for existing problems such as hypertension. While for food and nutrition, they should follow the usual diet with increased calories if the patient is underweight or decreased caloric if the patient is obese, with reduced excessive sodium and total fat intake, but should be monitored regularly, and increase the intake of fruit. So the patient may need to include carnitine in the diet, even though that it is not yet proven. It may be reasonable to include it in the diet for more sources of vitamin E, B6, and 12. Also, with steroids, decreasing the sodium intake with higher potassium intake can be needed, and adequate high protein can also be necessary. In addition, treating with supplement of folic acid and vitamin B6 and 12 to reduce the elevated homocysteine level concentration is recommended. So the mainstay of the therapy will remain that corticosteroids given in high doses with prednisone successfully can control the inflammatory process, and side effects can include elevated glucose and decreased nitrogen level, especially in cases of long-term use. Also, methotrexate is being evaluated, but more research is needed, and having a low dose aspirin is something that is recommended sometimes. Also, for herbs, if the patient shouldn't, we should educate them that they shouldn't take any herbal or potential supplement without discussing it with the physician first to avoid any unwanted interaction with the medication as well. While for the nutrition education, we should discuss the role of nutrition in the maintenance of health for cardiovascular disease. Also discussing the effect of medication on the nutritional status and appetite, as well as if dysphagia is present, then we should discuss ways to alter the texture or liquid consistencies with even long-term use of prednisone. We should monitor for osteoporosis, cataract, easy bruising, and elevated glucose levels as well. Also, careful food handling will be important with hand washing. That is key as well in these factors. And for atherosclerosis, coronary artery disease, and dyslipidemia, this involves the progressive narrowing of the arterial wall with giving rise to the collateral vessel, and the fat deposit will accumulation occur when the heart, brain, and the leg arteries are most often affected. So the metabolic syndrome is prevalent in these cases. So obesity can lead to pro-inflammatory and prothrombotic state that potentiates atherosclerosis and the vascular lipid accumulation, as well as inflammation that is hallmark for atherosclerosis. So, as a precursor to prostaglandins, thromboxylin, and leukotrienes, all of which can lead to these factors, will have significant implication in hypertension and chronic heart disease. Also, the initial insult in the adipose inflammation is mediated by the macrophage recruitment and the endogenous activation of the toll-like receptors. And ischemia considered to be local and temporary deficiency of the blood caused by obstruction as a form of thrombosis. And people with ischemic heart disease benefit from a diet that is high in monounsaturated fatty acids, omega-3 fatty acids, and whole grains with vitamin E, vegetables, and fruits as well. Also, dyslipidemia involves hypertriglyceridemia and low level of high-density lipoprotein and cholesterol, and these imbalance in these individual lipid components contribute to the increased risk of CAD, and the serum lipid reduction will decrease the CAD risk. For each 1% reduction of the serum cholesterol, there is 2% reduction in the CAD risk. Also, cholesterol screening is recommended even for older adults, as it is when treated will decrease the risk significantly, and therapeutic lifestyle modification program is considered to be very effective with nutrition and physical activity intervention that have the potential to dramatically reduce the risk. And for the intervention objectives, these include using a team approach to support the best possible outcome, improving LDL and HDL cholesterol level to prevent formation of new lesions, and having treating triglyceride level if it is high, and treating the metabolic syndrome as well when it is present. Also, having moderate carbohydrate restriction and weight management or control can improve dyslipidemia, and correcting the elevated level of THC, and using more flavonoid phytochemicals, soy products, and fruit and vegetables all of which can be very effective. And treating hypertension by using aspirin or CAD in patients to reduce the prothrombotic status, if appropriate, is also recommended. And more importantly, monitoring for effective MTHFR genotype, as this may be useful in predicting the development of premature coronary artery disease. And for the food and the nutrition intervention, we need to have individualized diet, as there is no single diet that fits all guidelines. So combining diet with exercise and other lifestyle changes and the Mediterranean diet that tend to be quite acceptable to most people and even work well in lowering the coronary risk factors, that encourages the use of olive oil, fish, fruit, and vegetables as well. So using the isocaloric replacement of saturated fatty acid with monounsaturated fatty acid is recommended, including olive oil and canola oil, and having a diet that is rich in fruit, vegetables, and low-fat dairy products, and low in sodium and saturated fat is also recommended. Also, a diet rich in fruit and vegetables and consuming half a cup of nuts daily is recommended as well, and consuming antioxidants from dietary sources with vitamin E rich food is also something that we should recommend to the patient to ensure that they have the best health outcome. And using flavonoid from tea or berries and onions or grape juice can also be a good source. And increasing antioxidant consumption with lowering LDL cholesterol has been found to be very useful for these patients. Also, consuming a diet rich in fiber, including soluble fiber as a part of diet that is low in saturated fatty acid, is recommended as well. And consuming about 2 to 3 grams of plant of cereals and panels is also recommended for these patients. In addition, an intake of EPAs and DHA from supplements such as fish can also be very protective and healthy for these patient populations. And using fewer animal protein and more legumes or vegetable protein sources can also be very protective and helpful for these patients' populations as well. And reducing the progression of atherosclerosis associated with intensive statin treatment can reduce both the atherogenic lipoprotein and the CRP. And if the patient is using anticoagulant, then we should limit vitamin K containing food to one serving per day to avoid any negative interaction for these factors as well. Also, for the nutrition education and counseling, we should discuss the role of hereditary exercise and lifestyle habits for these patients and adherence to dietary guidelines that is significantly associated with slower atherosclerosis progression and less metabolic complication for these factors. And having a diet that is low in saturated in fat will have different taste and texture. And if one changes the diet too quickly, then it can seem dry and unpleasant, but should reduce the content of unwanted nutrients gradually to ensure that they have the best outcome from these restrictions. In addition, having sources of soluble fiber is recommended, including apple and legumes, with other whole grain foods to control the fat content in the diet to more often. And having aerobic exercise is also recommended as a method to reducing these intakes as well. Also discussing a low-fat cooking method such as baking, boiling, and grilling as an alternative method to these factors to ensure that the patient has the best outcome of their dietary restrictions and intensive lifestyle changes that is maintained for 5 years or longer may be needed with strict low-fat diet that can help in reversing atherosclerosis, but we should check on the serum lipid at least on an annual basis to ensure that the patient is still compliant with the dietary restrictions. So we have reached the end of our session. If you have any question regarding dietary interventions, carbohydrate and diabetes, or even lipoprotein, please send them on the chat.
السلام عليكم ورحمة الله. هنبتدي أول ليكتشر معانا النهاردة اللي هي Healthy Lifestyle Promotion. Our objectives for today: what is a healthy lifestyle أو healthy lifestyle definition, aspects of healthy lifestyle, و how to promote healthy lifestyle. يعني إيه healthy lifestyle؟ As the WHO or World Health Organization define a healthy lifestyle is that focuses on incorporation the 8 aspects of well-being into one's life. ايه هما ال 8 aspects of well-being؟ emotional, environmental, financial, intellectual, occupational, physical, social and spiritual. There is no longer any serious doubt that daily habits and action profoundly impact both short and long-term health and quality of life. Scientific and medical literature that supports this concept is now overwhelming. Thousands of studies provide evidence that regular physical activity, the maintenance of healthy body weight, not smoking cigarettes, as well as following sound nutrition, stress reduction, and other health-promoting practice all profoundly impact health. Conversely, inactive lifestyle, obesity, high levels of stress, and cigarette smoking or exposure to cigarette smoke and other pollutants all significantly and negatively impact health. Health promotion lifestyle focus on life promotion through a lifestyle, which consists of 6 aspects: physical activity, nutrition, health responsibility, spiritual growth, interpersonal relations, and stress management. This lifestyle promotes health and welfare and induces satisfaction, self-persuasion, and self-improvement. A lifestyle is defined as normal and conventional daily activities which are accepted by people during their lives, and their activity can affect the health of individuals. By selecting a lifestyle, an individual tries to maintain and promote his or her health and avoid diseases through having a proper diet, rest, activity, exercising, controlling the body weight, not smoking and drinking alcohol, and immunizing the body against disease. This set of activity constitutes a lifestyle. ده هو المعروف نمط الحياة أو يعني إيه lifestyle. The importance of lifestyle effect upon the quality of life and preventing from diseases. It is essential to promote and correct lifestyle in order to maintain and promote the health. Promoting health and providing public health are the most important basis for the development of communities. Health professionals who were previously focusing on treating a disease are now concerned with prevention and providing health through lifestyle promotion and eliminating a factor which negatively affect human health in any way. Application of positive behavior pattern in life is influential for individual health promotion. 35% of mortality cause can be prevented by a modification of lifestyle. Most health problems such as obesity, cardiovascular disease, cancer, addiction, which are observed in most countries, especially in developing one, are associated with the transformations in the individual lifestyle. Also, inappropriate lifestyle is one of the influential factors for the emergence of chronic diseases like colon cancer, hypertension, chronic obstructive pulmonary diseases, liver cirrhosis, peptic ulcer, AIDS, and cardiovascular disease. Lifestyle modification requires behavioral change that constitute a major part of daily habits. If lifestyle change do not promote global quality of life, provision and persistent or this motivation will face some problems. الهيلث بروموشن هو عبارة عن multi-dimensional pattern of perceptions and activity which are started by self-motivation and help in the persistence and promotion of their health and self-improvement. You can change your genes or even much of the environment around you, but there are lifestyle choices you can make to boost your health. Being informed and intentional about diet, activity, sleep, and smoking can reduce your health risk and potentially add years to your life. Getting adequate sleep. Getting the right amount of sleep and going so regularly is first on the list. It is often missed because people focus on diet and exercise, but the link between sleep and life expectancy is supported by research. What surprised some people is that the relation is a U-shaped curve. This means that too little and too much sleep can affect your health. In one study, sleeping for a long duration, defined as more than 10 hours a night, was associated with psychiatric disease and higher body mass index. A good night's sleep is important to recharge both the body and mind. It helps the body repair cells and get rid of waste. It is important in making memories, and sleep deprivation leads to forgetfulness. During sleep, your body releases hormones. Some of them keep your heart and blood vessel healthy. Lack of sleep deprives you of these hormones that are associated with the following: high blood pressure, worse heart function, over time, heart disease. Sleep helps regulate your metabolism. That's the way your body converts food to energy. Sleep deprivation can cause many problems with metabolism, including the fluctuating blood sugar levels. Blood sugar extreme also affects your mood, energy levels, and mental function. Sleep helps your mind and body relax and recover from your day. When you are sleep deprived, your body releases stress hormones. Stress can make you react in ways that aren't productive. You may act out of fear or make rash decisions, or you may be irritable. Now, what are the techniques to reduce stress? At least 30 minutes of daily moderate exercise, mindfulness and meditation, progressive muscle relaxation, yoga, visualization, slow with deep breaths. For developing good sleep. An exercise routine doesn't develop overnight. Here are some tips to get you started. Get any activity tracker. Logging at least 30 minutes of exercise 5 days a week can help improve your mood. Start slow. You don't have to do 30 minutes of exercise all at once. 5 to 10 minutes at a time makes a difference. Go outside. Getting away from a screen and into the fresh air can help reduce stress. Body up. Having a friend to exercise can be motivating and hold both of you accountable, plus it is more fun. Muscle relaxation. Stress causes your muscle to tense. So people who feel stressed may feel tension in their head, neck, shoulder, or back. Progressive muscle relaxation is a technique that is proven to reduce tension and anxiety and improve mental health. Practice by sitting or lying in a comfortable position. Then Choose a muscle group, such as your lower legs, and inhale and contract those muscles for 5 to 10 seconds. Next, exhale to release and relax the muscle for 10 or more seconds. Continue this until you have relaxed all portion of your body. Visualization. When you are in a stressful environment, visualization can be a powerful tool. To practice this technique, close your eyes and picture objects, scenes, or even that are associated with relaxation, such as an ocean, a mountain, a favorite place, or a pleasant smell. This powerful technique uses your mind to imagine a relaxing environment and in turn produce feelings of relaxation in the body. Yoga is a form of mind-body fitness that involves exercise and mindfulness or focusing on the self and breathe. Research suggests that yoga helps improve well-being, manage stress and negative emotion, and increase a positive emotion. There are many types of yoga practice and styles ranging from gentle breathing and meditation to demanding physical postures called asanas. Preventing stress and anxiety. The American Psychological Association recommends the following evidence-based ways to help manage and prevent stress. Number one, try to get rid of your stressors. Keep a journal to identify a situation that creates stress for you. While it is not always possible, evaluate whether you can get rid of or avoid the situation. This may mean asking for help, giving up some responsibility, or lowering your expectation at work, at home, or school. Number two, evaluate work stressors. If your workload is excessive or not engaging, or you are unclear about what your responsibilities are, have a discussion with your supervisor to see if any changes can be made. Number three, take care of your body. This includes eating a healthy and variety diet, getting quality sleep, exercising regularly, and avoiding excessive alcohol, caffeine, tobacco, or other substances. Taking steps to care for your physical health can help improve your immune system to fight stressors and decrease the inflammation caused by stress. Number four, create a routine. Having regularity and routine, such as waking up, eating meals, and going to bed at the same time each day, can help you feel more stability in your life, which can help reduce stress and anxiety. If that's not possible due to your work or family responsibility, finding a way to add routine into your day, such as a bedtime routine, can also support your well-being. Enjoy leisure activity. Many people, they have too many responsibilities to be able to take the time for leisure activity. However, cutting out leisure activities may actually be counterproductive when it comes to your well-being. Doing things you enjoy, such as going for a walk, reading a book, listening to music or a podcast, or watching your favorite TV show can help alleviate stress and anxiety and allow you to reset and recharge. Get outside. Many studies have shown that green spaces such as parks can help boost mood and help you recover more quickly from stressors. Try to take a walk and observe nature around you to help reduce your stress. Eating well-balanced meals. Taking steps toward a lifelong change in diet will help more than jumping on the latest fad diet does. You may have heard author Michael Pollan's signature phrase, eat food, not too much, mostly plants. Of those plants, choose a rainbow of color to make sure you get all the nutrition you need. One plus to begin with the well-regarded Mediterranean diet, it's rich in many of the healthiest foods and naturally limit less healthy choices. The more you follow Mediterranean diet, the lower your risk of a host of disease. What are the key characteristics of Mediterranean diet include? Foods high in monosaturated fat, including nuts, seeds, and olive oil. Foods high in legumes, including lentils and beans. High fiber grains, including whole grain, oatmeal, and barley. Meals high in fresh fruit and vegetable content. Use of lean cuts of poultry in some food. Moderate consumption of fish, including fish high in healthy omega-3 fats such as salmon. Low to moderate consumption of red wine. Refined sugar are used sparingly in meals. Lower consumption of red meat. Making time for activity. Best of all, physical activity is a low-cost way to boost your health and even save your money. Sometimes your health may limit your exercise option, but you can keep moving by watching your windows, mowing your lawn, sweeping a sidewalk, and other basic tasks. Once you are past age 65, you may benefit by adding balance and flexibility exercises, but keep moving too. Whether you dance, garden, swim, or go biking, choose moderate intensity exercise that you know you will enjoy. Keeping a healthy body weight. Obesity is associated with a shorter lifespan and a higher risk of many diseases. The good news is that just being somewhat overweight does not reduce your longevity. In fact, for those over age 65, it is better to be on the high side of normal than the low side. Avoiding smoking or chewing tobacco. The list of disease and cancers linked to smoking is long. If you are finding it hard to quit and you think illness comes only later in life, it may help to think of more short-term goals. Perhaps it's too expensive or indoor smoking bans limit your social outing. Managing mental health include factors such as managing stress and maintaining social connections. Research showed that people who report being happier life as much as 4 to 10 years longer than less happy people. One way to increase their happiness is to manage stress. Although we can't eliminate stress entirely, there are some ways to limit it. Take time to unwind, such as doing deep breathing exercise, yoga, meditation, taking a bath, or reading a book. Schedule regular time for this and other healthy activities. Take breaks from watching, reading, or listening to news and social media. Practice gratitude by reminding yourself daily of things you are grateful for. Be specific. Write them down at night or reply them in your mind. Focus on the positive by identifying and challenging your negative and unhelpful thoughts. Find a hobby. Research show activities like gardening, singing, playing a musical instrument, and other hobbies are linked to living longer, healthier life. Hobbies may reduce stress and provide mental stimulation. البنفيت of healthy lifestyle. Number one, healthy living improves the body posture. It spreads happiness, enhances energy level, make you feel younger, improves your metabolism, increases endurance and longevity. Summary. For a long, healthy life, the 7K lifestyle behaviors include getting enough sleep, eating a healthy diet, being physically active, maintaining a healthy body weight, not smoking, limiting alcohol, and managing mental health. These factors may seem like a part of common sense advice, but there is reason for that. They are all backed by data, and new medical research continue to point in the same healthy direction. Thank you. كده احنا خلصنا أول محاضرة. لو في أي سؤال حضراتكم ممكن تكتبوا في الشات لو في أي استفسار. طيب تحبوا ناخد 10 دقايق بريك وبعد كده ناخد المحاضرة التانية؟ تمام. نرجع 7:15. طيب 7:15 نرجع، تمام معاكم؟ اوكي بريك لحد 7:15 ونرجع نكمل المحاضرة التانية، تمام؟ طيب هنبتدي المحاضرة اللي بعد كده. Our next lecture هي Nutrition or Reproductive Health in Women. Our objectives: brief introduction, the effect of nutrition on women reproductive health, the effect of exercise on women reproductive health. Introduction: the dietary status include only intakes. When nutritional status assessment involve a combination of a dietary intake, the biochemical and anthropometric measurements, the clinical observations, the functional status, and if available, genetics. A diet plays an important role in human growth, development, and marital bodily function, and is directly related to health. This lecture provides a background on the concept of nutritional status, an overview of the methods for evaluating it, and the various tools that are available to make inference about nutritional status from dietary intake and other data. The nutritional status represents the body's state resulting from the intake, absorption, utilization, and metabolism of the diet the individual consumes. It can be measured at both the individual and group level. Disordered nutritional status run the gamut from undernutrition, which means malnutrition or nutrient deficiency, to overnutrition, excess in energy or nutrition intake, and collectively, these deviations from normal are referred to as malnutrition. A nutrient requirement: nutrients are substances that are not synthesized in sufficient amounts in the body and therefore must be supplied by the diet. Their absence leads to growth impairment, organ dysfunction, and failure to maintain a nitrogen balance or an adequate status of protein and other nutrients. For good health, human beings require energy-providing nutrients: protein, fat, and carbs. Alcohol, which is not an essential nutrient but provide energy of America, vitamins, mineral, and water. Requirements for organic nutrients include 9 essential amino acids, several fatty acids, glucose, 4 fat-soluble vitamins, 10 water-soluble vitamins, dietary fiber, and choline. Several inorganic substances, including 4 minerals, 7 trace minerals, 3 electrolytes, and the ultra-trace element must also be supplied by diet. Dietary protein consists of both essential and non-essential amino acids that are required for protein synthesis. The 9 essential amino acids are histidine, isoleucine, leucine, lysine, methionine, cysteine, phenylalanine, tyrosine, threonine, tryptophan, and valine. When energy intake is inadequate, protein intake must be increased because ingested amino acids are diverted into pathways of glucose synthesis or oxidation. In extreme energy deprivation, protein-calorie malnutrition may therefore ensue. Certain amino acids, such as alanine, can also be used for gluconeogenesis as well as for energy and are therefore called glucogenic amino acids. The amount of essential nutrient required by individuals differ by their age and psychological state, such as growth, pregnancy, lactation, inflammation, and certain disease states. Human beings all need the same nutrients, but they also differ somewhat from one another in the amounts they need. We never know precisely what an individual quantitative requirement for a nutrient is. However, extensive experimentation and observation over the past century have revealed that human nutrient requirements generally conform to a normal Gaussian distribution, and the estimated required amount has been determined experimentally. Therefore, it is possible to use statistical technique to predict recommended nutrient intake amount that are generous enough to suffice for virtually and healthy people. Conditionally, essential nutrients are organic compound not required in the diet of most people, but that must be supplied to certain individuals who do not synthesize them in adequate amounts, such as those with specific genetic defects, those with pathologies such as infection, a disease, or trauma with nutritional implications, and developmentally immature infants. Those individuals have special nutritional requirements that exceed those of normal individuals. What are the forms of malnutrition and a clinical term used to describe them? Dehydration اللي هي adequate fluid intake to meet the bodily need. The clinical term to describe it هي dehydration. A comment often occurs secondary to fever, exertion, very warm, dry climate, or because of diet with high solute loads or drug that have diuretic effects. Starvation, virtually totally inadequate intake of all nutrients. الترم المراسمس الإماسيشن الكاشكسيا occur with prolonged fasting, withholding of fluids, worsen its effect. البروتين calorie malnutrition زي الكواشيوركر protein calorie malnutrition often occurs secondary to disease and infection, probably via cytokine-mediated response to acute infection or trauma. The examples include HIV, AIDS, sarcopenia due to inadequate intake of protein and/or a cytokine-mediated response to insults. The vitamin, the mineral, or other specific nutrient deficiencies. البلاجرا اللي هي نتيجة deficiency للنياسين والتريبتوفان. السكيرفي deficiency للأسكوربيك acid. الريكت and osteomalacia. الفيتامين D deficiency in children and adults respectively. الiron deficiency anemia اللي هي iron deficiency. nutritional anemia, iron, vitamin B6, folic acid or vitamin B12 deficiency. essential fatty acid deficiency. These deficiencies often occur secondarily to inadequate food intake or inadequate dietary quality. May also occur as conditional deficiencies secondary to diseases. Imbalances increase diet-related chronic disease risk factor due to imbalance of nutrients, excess of saturated fat, cholesterol, and other atherogenic and thrombogenic dietary lipids, hyperlipidemia, and perhaps altered clotting factors, excess of salt and or sodium. ده بيبقى blood pressure risk factors. Imbalances or excess of energy yielding nutrients or related substance may give rise to metabolic aberrations and increase the risk of ill health, especially in those with certain genetic profiles. Obesity, excess food energy intake and or insufficient energy output. Excess food energy, regardless of source, gives rise to obesity and overweight. Comment, physical inactivity may increase the likelihood of excess energy intakes. Alcohol exceed, alcohol problem drinking at a very high level of alcohol intake, that may develop physical sign of chronicity. Lower level of intake, some individuals are particularly susceptible. Excess or other specific nutrients, vitamins, minerals, other specific toxicity vary. الهايبرفيتامينوزس اللي هو excess فيتامين A، hypervitaminosis دي، والفلوروزس للفلورايد. الانتاج that exceed the upper level of the dietary reference intake generally increase the risk of compromising one or more functions. The possible function vary from nutrient to nutrient. التوكسيسيتي اللي هو excess of other constituent in a food with drink or supplement. And names vary depend on a substance, lead poisoning, willathyrism. Many substances other than nutrients in food and supplement may cause illness. Food-borne disease, clinical term, food poisoning or food intoxication, salmonellosis, botulism, staph food poisoning, or others. Parasites such as beef tapeworm may cause problem, or pythons or virus in bovine spongiform. Food is a carrier for a microorganism, viruses, or parasite. Some biochemical biomarkers of intakes, exposure and or nutritional status. Iron, biomarker, hemoglobin, low specificity may different cause of anemia disease. Cut-off vary by age with sex with ethnicity. This is a good indicator for monitoring the improvement in iron status if the individual is iron deficiency. Serum plasma ferritin, this is an acute phase protein and is not specific. It increases independently due to acute or chronic inflammation, infection, malignancy, hyperthyroidism, liver disease, heavy alcohol use. Serum transferrin receptor, a specific indicator of iron deficiency erythropoiesis that is not affected by inflammation. TIBC اللي هو total iron binding capacity, non-specific and varies over the day. Erythrocyte zinc protoporphyrin is a sensitive indicator for diagnosis of deficiency. However, the specificity is limited since it is affected by lead poisoning, anemia of chronic disease, chronic infection, inflammation, hemoglobinopathy, and hemolytic anemias. Zinc, serum plasma zinc, respond to zinc supplementation, but it is easily affected by contamination and is also affected by inflammation, fasting, estrogen use, hemolysis, and chronic illness. B12 في السيرم أو plasma total zinc measure that biologically activate B12. Poor correlation with dietary zinc, also cut-off are uncertain and kits for the test vary. Serum plasma methyl malonic acid, cut-off are uncertain, test is sensitive. الفوليت البايوماركر السيرم والبلازما فوليت vary with recent intake and kits to test vary. Erythrocyte folate, kits vary والsample are difficult to prepare and cannot be stored. Serum plasma total homocysteine depend on B2 status, B12 status, B6 status, and MTHR polymorphism state. الفيتامين A البايوماركر بتاعه السيرم ريتينويل ده sensitive to intake but only if stores are low. It is not very sensitive because it is under hemostatic control. Obesity can affect reproduction through fat cell metabolism, steroid and secretion of proteins such as leptin and adiponectin, and through change induced at the level of important hemostatic factor such as pancreatic secretion of insulin, androgen synthesis by the ovary, and sex hormone binding global production by the liver. النيوتريشن فاكت النيوتريشن فاكت ليبل اللي دي بنلاقيها على كل المنتجات الموجودة في السوبر ماركت provide information about the energy and content of certain macro and micronutrient to emphasize and those to limit in food by their amount in standardized portion size for almost all processed food. Dietary supplements sold directly to consumers that contain nutrients have a supplement fact label. Both labels use a dietary standard known as percent of the daily value per serving to provide a comparison of the nutrient content with the DV, which is based on the RDA daily value, which are presented as a percent of daily value on the label to help consumer to understand the nutrient information on the product label in the context of the total diet. ودي دايما أما بنروح نشتري أي منتج غذائي لازم نشوف الكالوريز، نشوف التوتال فات قد ايه، الساتوريتد فات قد ايه، الترانس فات قد ايه، الكوليسترول قد ايه، الصوديوم، التوتال كاربس، الدايتري فايبر، التوتال شوجر، البروتين، الاني فيتامين او الكالسيوم، الايرون والبوتاسيوم. النيوتريشن fact food vary because of change in the prevalence of diet in the population with intake of little, much, or certain nutrient in the American diet. For example, there is a great concern about a prevalence of obesity in USA, and some of the change in food labels such as the bolded value for calorie reflects this concern. ما بيبقوش كاتبين الكالوري قد ايه. Some of the nutrients singled out on the food label with a daily values are intended to guide the consumer about the maximum intakes, such as sodium or saturated fat. Other included are intended to help the consumer meet a nutrient requirement من iron, calcium, vitamin D, with dietary fiber, for example, with the emphasis on nutrients of public health significance that fall short of recommendation in dietary survey of Americans. The WHO estimates that 9 to 50% of women in developed countries are severely obese, and obese mothers are much more likely to have obese children, especially if they have gestational diabetes. Obesity-associated anovulation may lead to infertility and to a high risk of miscarriage. Management of anovulation with obesity involves diet, exercise, as well as standard approach to ovulation induction. Many obese women conceive without assistance, but pregnancies in obese women have increased rate of pregnancy-associated hypertension, gestational diabetes, large babies, cesarean section, and perinatal mortality and morbidity. Among the contraceptive, weight gain affect uptake and continuation of hormonal contraceptive, although existent indicate that any such effects are small. For all methods of hormonal contraception, weight above 70 kilogram is associated with increased failure rate. يعني الكونتراسبشن كل ما الوزن كان above ال 70 ده بيزود الفيلير ريتس بتاعها. الكي بوند. Obesity and the standard American diet are contributing to 90% of ovulatory infertility. The causes of maternal mortality have shifted away from a non-preventable cause such as hemorrhage to disease of lifestyle. Cardiovascular disease, stroke, and hypertensive disease of pregnancy combined now cause 30% of maternal deaths. Maternal diet and lifestyle behaviors can result in negative fatal impacts that include obesity and autism. Ovulatory infertility. Ovulatory infertility is directly related to polycystic ovarian syndrome, PCOS. PCOS gets its name from the appearance of the ovary on ultrasound, but metabolically, It is constellation of obesity, insulin resistance, and oligo or anovulation that results in infertility, menstrual dysfunction, and hirsutism. As women become obese, they become insulin resistant, resulting in elevated level of circulated insulin. Insulin suppresses a synthesis of sex hormone binding globulin, which is crucial in binding free androgen. When LSHBG synthesis is suppressed, free androgens rise, resulting in infrequent ovulation. Population studies have shown that approximately 30% of overweight and obese women have PCOS, that the condition is present if in 5% of normal weight women. Overall, PCOS affect 1 in 8 women in the United States. In cases of ovulatory infertility, 90% are a result of PCOS. As previously mentioned, CDC reported that 71% of those population in United States is overweight or obese, which means that reproductive age women overweight or obese, and 30% of those women will have PCOS. That means that 21.3% of adult women have an impaired capacity to become pregnant secondary to oligo or anovulation. Metformin has been utilized in the treatment of PCOS-related infertility, as it improves insulin sensitivity of peripheral tissues, reducing circulating androgen levels and leading to more menstrual regulatory and restoration of ovulation. The two primary causative agents in PCOS that can lead to infertility are insulin resistance and advanced glycation and product-induced oxidative stress, both of which are best addressed with diet and lifestyle changes. Dietary behaviors resulting in obesity and malnutrition are linked with oxidative disturbance and chronic low-grade inflammations. Studies have shown repeatedly that animal foods and their accompanying saturated fats, trans fats, arachidonic acid, cholesterol, and protein are associated with systemic inflammation. Additionally, women with PCOS have higher level of anti-Mullerian hormone, and it has been shown that 1 hour of exercise per week will decrease the BMI, total and android fat mass, and improve insulin sensitivity, as well as lowering AMH levels. This suggests that mechanisms associated with ovarian dysfunction can be improved by exercise in PCOS, possibly improving the chances of conception. The pregnancy outcome. Maternal and fetal outcome are impacted significantly by lifestyle and in a multitude of ways. Because the subject area of maternal and fetal medicine is so vast, we limit our focus to the impacts of lifestyle on maternal morbidity and mortality and some fetal outcomes. Maternal mortality. The causes of maternal mortality have changed in developed nations. Historically, in this country and still in the developing world, hemorrhage has been responsible for 1/4 of maternal deaths. Today, cardiovascular disease, stroke, and hypertensive disease of pregnancy combined cause 30% of maternal deaths, while hemorrhage is now responsible for only 11% of deaths. Pregnancy has become riskier because there has been such a significant rise in reproductive age women with obesity, diabetes, and pre-pregnancy hypertension that can lead to preeclampsia eclampsia, stroke, and cardiomyopathy. Preeclampsia. Preeclampsia is a constellation of signs and symptoms that include hypertension, proteinuria, edema, and in more severe cases, headache, elevated liver enzymes, pulmonary edema, and thrombocytopenia that can lead to seizure, stroke, and death for both mother and infant. Preeclampsia is among the top 6 causes of maternal mortality, severe maternal morbidity, and adverse neonatal outcomes globally. In regard to diet and prevention, there is one observational study that looked at a community of vegan women. Preeclampsia, this rate of 0.001%, which is obviously much lower than the 3.8 rate we see in this country. The author concluded that a vegan diet could alleviate most, if not all, of the signs and symptoms of preeclampsia. Preeclampsia, like other cardiovascular disease, is a result of endothelial dysfunction and inflammation of the blood vessels. Chronic inflammation is also present in diabetes, in the obese, and in patients with autoimmune disease. It has been well verified that dietary patterns that are high in fat, particularly saturated and trans fats, and highly refined carbs, cause systemic inflammation resulting in disease. It has also been well verified that a diet based on whole or minimal processed plant food can reverse this inflammatory process. The overconsumption a role in the rise of preeclampsia in the US, but also globally. A survey conducted in 2008 found that preeclampsia and gestational hypertension were found to be higher in Bangladesh coastal regions compared to non-coastal area or during a dry season. Because of climate change and sea level rise, the salinity level in surface and groundwater are higher on the coasts and during the monsoon season. Salt from any source raises blood pressure and therefore increase the risk of hypertensive disorder like preeclampsia in pregnancy. Preeclampsia and hypertensive disease during pregnancy do not just impact the maternal health acutely, but also increase the risk of chronic disease in the long term. Emerging research shows that heart disease is an 8-fold long-term threat for women who develop diabetes or high blood pressure during pregnancy. Fetal impacts. One fetal impact of maternal hypertension is obesity. A prospective cohort study in South China found that among all women, maternal hypertension in the second and third trimester was associated with 49% and 14% higher risk of offspring, overweight, obesity, respectively, and that this finding was independent of maternal body size prior to pregnancy. Maternal dietary patterns can also impact long-term fetal outcomes. A study of men and women in Motherwell, Scotland, whose mothers had been advised to eat a high animal protein, low carbs diet in pregnancy showed that a higher maternal intake of meat and fish and a lower intake of green vegetables during pregnancy was associated with higher adult blood pressure in their offspring. Elevated cortisol levels have been shown to increase the risk of cardiovascular events, and this study revealed that both the son and daughters of women who had reported higher meat and fish consumption and lower green vegetable consumption in the second and half of pregnancy had higher fasting plasma cortisol concentration. Cortisol concentration increased 5.4% per portion of maternal meat fish consumption per day, but decreased 3.3% per portion of maternal green vegetable consumption per week. Evidence for lasting hypercortisolemia was discovered when researchers put the offspring on women who reported greater consumption of meat and fish in the second half of pregnancy through stressful experiences, compared with the offspring of mothers who had reported eating no more than 13 meat or fish portions per week. Maternal obesity also poses increased risk for the fetus. Multiple studies show that obese mothers, whether or not they have diabetes, are more likely to have a stillbirth. This study also shows that the risk of stillbirth increase in a dose response fashion. With the more obese the mother is, the higher the risk. Infants born to obese mothers are also at an increased risk of having a congenital anomaly, including a cleft lip and palate, a neural tubal defect, and cardiac defects. Additionally, excessive gestational weight gain in early and late pregnancy had a 2.4-fold increased risk for a large for gestational age infant, regardless of pregnancy BMI, putting these infants at risk of childhood obesity. Autism. The incidence and prevalence of autism spectrum disorder have risen to epidemic level. In 1981, it was 1 in 10,000. In 2000, it was 1 in 150, and our most current estimate is 1 in 68. If the current rate of increase continues, it will be 1 in 2, or 50% by the year 2050. A debate has ensued regarding whether the incidence of autism spectrum disorder is falsely elevated secondary to change in diagnostic criteria and improve surveillance, or whether there is some environmental factor that is causing an actual real rise in new cases. According to the CDC, there have been no changes in the criteria used to diagnose or treat cases of autism spectrum disorder. There has been a 30% increase in the rate since then. The rate increased from 1 to 88 سنة 2012 to 1 to 68 في 2014. New evidence reveals that the uterine environment is having an effect on the development of autism spectrum disorders. A recent study in the New England Journal of Medicine looked at brains of children with autism who had died of unrelated cause and compared them to brains of unaffected children. It is known that the brains of children with autism tend to be larger, with a relative increase in the overall numbers of neurons in the prefrontal cortex. This is a normal finding in fetus during the second trimester of pregnancy, but it resolved by birth or shortly thereafter when there is maturation of the neural circuitry. In this study, they found that despite the increased number of neurons, there were focal patches with fewer cells expressing layer-specific markers that are normally present in fully different tight cortical neuron. This means that a neuron circuitry in these children is not maturing appropriately through running an apoptosis, and that proper neuron migration is not occurring. The primary implication of this study is that this abnormality almost certainly occurred in utero during key development windows, most likely between 19 and 30 weeks of gestation. The pregnancy of this woman in this study were unremarkable, but no discussion of routine exposures or obesity was mentioned. There is a debate and uncertainty as to what is causing this abnormal brain development and why it is so much more prevalent as compared to even 15 to 20 years ago. But it does appear that maternal inflammation plays a role. There are many factors that can contribute to the development of autism. There is some component of heritability, but epigenetics and how those genes are expressed based on exposures is a bigger factor. Exposure such as pesticide and other persistent environmental pollutant have been implicated as contributing factor in a genetically susceptible individual. Combination of low folic acid consumption and regular exposure during pregnancy to pet pesticide or to outdoor sprays and fogger is responsible for a four-fold increased risk of an autism spectrum disorder, while exposure to low folate and agriculture pesticide exposure 3 months before or after are responsible for a more than two-fold increase in risk. Pesticides are neurotoxic by design, but in animal studies, folic acid have been shown to protect against ill effect resulting from developmental exposure to a variety of environmental chemicals, including ill effects of insecticide and BPA. Additionally, several epidemiological studies have been reported a reduced likelihood of autism spectrum disorder and autistic traits in children whose mothers supplement containing folic acid near the time of conception. Previous work has suggested that genetically susceptible individuals have less efficient folate-dependent metabolism gene and thus experienced a reduced risk of autism spectrum disorder associated with maternal folic acid intake. However, anything that results in elevated level of inflammatory mediator in the amniotic fluid can result in an autistic child. Maternal metabolic condition associated with chronic inflammation like obesity and diabetes thus pose an increased risk. Obesity during pregnancy increases the risk of having a child with autism by 60%, and diabetes during pregnancy doubles the risk. Higher consumption of maternal dietary fat and low consumption of preconception folate found in fruit, vegetable, and are also associated with an increased risk of having child with autism. This phenomenon is present with other inflammatory conditions as well. Infection like influenza or rubella or any other infection that results in a fever that lasts 7 days or more increase the inflammatory mediator. A relative risk for autism with influenza and rubella infection in pregnancy are 4:1 and 3.3 respectively. Another study revealed that maternal influenza doubles the risk and a fever during pregnancy lasting more than 7 days triple the risk of autistic child. The brain is particularly vulnerable to oxidative stress because of its high oxygen consumption, high content of unsaturated fatty acids and transition metal, and low antioxidant defense capacities. There is a long history of studies showing that autism is associated with oxidative stress and diminished antioxidant capacity. A 55% reduced gene expression of nuclear factor erythroid 2 A transcription factor involved in the antioxidant response has been found in children with autism. Children with autism are also more likely to have mitochondrial dysfunction and neuroinflammation secondary to over a master regulator of the inflammatory cascade. Researchers have demonstrated an active neuroinflammatory process in the cerebral cortex and white matter of children with autism, and the cerebrospinal fluid of those individuals have up to 230 times the level of inflammatory mediator like an interferon. A clinical application, a pregnant patient and those trying to conceive should be counseled to reduce animal food consumption and avoid fish or at least 1 year and then through pregnancy. Avoid processed food and highly refined carbs. Supplement with vitamin B and folic acid at least 3 months prior to conception. Avoid tobacco, alcohol, and other substances before conception and during pregnancy. Work to achieve 150 minutes of chronic, moderate physical activity before, during, and after pregnancy. Exercise in pregnancy. Regular aerobic exercise during pregnancy. Regular aerobic exercise during pregnancy have been shown to improve or maintain physical fitness. Although evidence is limited, some benefit to pregnancy outcome has been shown, and there is no evidence of harm when not contraindicated. Observational studies of women who exercise during pregnancy have shown benefits such as decreased gestational diabetes, cesarean and operative vaginal delivery, and a postpartum recovery time. Although evidence from is limited in those instances where women experience low back pain, motor exercise is an excellent alternative. Studies have shown that exercise during pregnancy can lower glucose level in women with gestational diabetes or help prevent preeclampsia. However, exercise has shown only a modest decrease in overall weight gain from 1 to 2 kilograms in normal weight in overweight and obese women. For healthy pregnant and postpartum women, the guidelines recommend at least 150 minutes per week of moderate intensity aerobic activity, example equivalent to brisk walking. This activity should be spread throughout the week and adjusted as medically indicated. Contact sport and activity with a higher risk of falling, such as skiing, should be avoided. Exercise is safe for all pregnant women except those with significant heart or lung disease, incompetent cervix, current premature labor, or placenta previa after 26 weeks of pregnancy. Generally speaking, whatever level of activity was being undertaken prior to pregnancy can be continued, and for those who had not been as physically active as recommended, exercise should be encouraged with a program tailored to an individual current level of fitness. Key point: exercise decreases the risk of postpartum weight retention. Exercise prevent and treat gestational diabetes. Current data suggests that exercise before pregnancy and during the first 20 weeks plays a protective role. Exercise provides psychological and physiological mechanisms to improve mood in pregnancy. Pregnant women who exercise report decreased incidence of musculoskeletal discomfort and complaint. Data does not support an increased risk of spontaneous abortion with exercise. Exercise has not been found to increase intrauterine growth retardation or small for gestational age infant. Exercise does not increase the risk of preterm delivery and may actually be protective. Obstetricians should be familiar with absolute and relative contraindication to aerobic exercise in pregnancy and make recommendations that are individualized by intensity, duration, frequency, and type of exercise. 150 minutes of exercise per week is recommended for healthy pregnant women. Recommendations regarding exercise in pregnancy have been in flux over the year. في سنة 1985 American College of Obstetricians and Gynecologists provided the first guideline for exercise during pregnancy based on limited evidence available. Prior to this time, women were often told to avoid strenuous physical activity, stretching, or bending for fear of pregnancy complications that might result. Since that time, a great deal of research has been done focusing on the safety, risk, and benefit of physical activity in pregnancy. Currently, both the Center of Disease Control and Prevention and the American College of Obstetricians and Gynecologists encourage regular physical activity during pregnancy, as the benefits are thought to far outweigh the risk. Benefit of exercise in pregnancy: weight management. The population as a whole is heavier today than in previous time. The fourth leading risk factor for early mortality worldwide is physical inactivity. A greater percentage of women are entering pregnancy overweight or obese, and many are gaining significantly more weight during pregnancy than is recommended. Excessive weight gain is emerging as an important predictor of adverse pregnancy outcome. Independent of pregnancy weight, women who gain excessively during the course of the pregnancy are more likely to deliver by cesarean section, have an unsuccessful trial of labor after cesarean section, develop hypertension or preeclampsia, deliver preterm, have a macrosomic or small for gestational age infant, retain excessive weight after delivery, and become overweight or obese later in life. The Institute of Medicine recently recommended a guideline for weight gain during pregnancy and provided new recommendation for weight gain based on pregnancy body mass index. And based on pre-pregnancy body mass index, exercise during pregnancy have been shown to reduce excess weight gain and decrease weight retention postpartum. In one study of women who continued their preconception exercise regimen compared to women who stopped or significantly reduced their level of physical activity during pregnancy, women who continued to exercise had a reduced rate of weight gain, thought within the normal range, and decreased subcutaneous fat deposition later in the pregnancy. Glycemic control. Gestational diabetes mellitus is one of the most common complications affecting approximately 7% of pregnancy in the United States. It is highest among obese and overweight women. Gestational diabetes mellitus is associated with adverse perinatal outcome, including an increased risk of macrosomia, maternal and neonatal birth injury, neonatal hypoglycemia, and hyperbilirubinemia, and an increased risk of impaired glucose intolerance and type 2 diabetes mellitus in the years following pregnancy. Insulin resistance in normal pregnancy is estimated to increase by 40 to 70% and is related to the increase in cortisol, growth hormone, placental lactogen, estrogen, progesterone, prolactin associated with the growth of the fetal placental unit. An increase in insulin resistance, decrease in maternal blood glucose uptake by the muscles, ensuring an adequate glucose supply for the fetal growth and development. This balance can tip, however, leading to abnormally high maternal blood glucose and insulin concentration, yielding the diagnosis of gestational diabetes mellitus. Physical activity has long been known to improve glucose by increasing insulin sensitivity in maternal skeletal muscle and increase lean mass. A sedentary lifestyle is one of the modifiable risk factors associated with gestational diabetes mellitus. Physical activity decreases risk of developing gestational diabetes mellitus and can serve as an adjunctive therapy in the treatment of gestational diabetes mellitus. This is of particular importance. A significant number of women with gestational diabetes mellitus go on to develop type 2 diabetes later in life. Many studies have estimated the impact of exercise before and during pregnancy on the development of gestational diabetes, though there are no randomized controlled studies demonstrating exercise as a means of prevention of gestational diabetes mellitus. Current evidence suggests a benefit. The influence of recreational activity on gestational diabetes mellitus risk was evaluated in a case-control study of 155 women with gestational diabetes mellitus and 386 normotensive non-diabetic pregnant controls. Both pregnancy physical activity and physical activity during pregnancy were associated with a significant reduction in gestational diabetes mellitus by 51% and 48% respectively, after adjustment for الage والrace والparity والpregnancy BMI والsmoke. Similar results were confirmed in a prospective cohort study of more than 900 normotensive. Exercise serves not only to prevent gestational diabetes, but also as an adjunctive treatment in women who have been previously diagnosed. The American Diabetes Association suggests that women without medical or obstetrical contraindication to exercise should be encouraged to start or continue a program of moderate exercise as part of treatment of gestational diabetes mellitus. Psychological benefits. Maternal mental health have been reported to have a significant impact on physical health and pregnancy outcome. Mood fluctuation are common during and after pregnancy, with the prevalence of prenatal depression nearly 11% and postpartum depression up to 16%. Several factors may increase the risk of mood disturbance during pregnancy, including reproductive hormones, the psychosocial stressor, the isolation, the personal or family history of depression, and chronic medical conditions. A consequence of untreated perinatal mood disorder can be significant and are associated substance abuse. A lack of compliance with medical care, disruption of relationships, a preterm delivery, a low birth weight, an impaired mother-child bonding, and childhood behavior. Physical activity is linked with improvement of mental health in non-pregnant women and likely confers the same benefit during pregnancy. An advantageous effect of physical activity on mental health likely result from a combination of psychological and physiological components. Proposed hypotheses regarding the psychological impact of exercise on mood, including a distraction, a self-efficacy, a social interaction, and improved body image. The physiological mechanisms by which exercise may improve mood include a release of monoamine and endorphin. Improvement noted in women who engage in physical activity include increased vigor, decreased fatigue, less stress and anxiety, with decreased symptom of negative mood and depression, and improved self-image. The excessive weight gain and physical activity are recognized as independent risk factors for maternal obesity and gestational diabetes. Aerobic exercise in pregnancy have been stratified by absolute and relative contraindication. الابسولوت contraindication of exercise, bleeding persistently in second or third trimester, الcirculage or cervical insufficiency, gestational hypertension or preeclampsia, الhemodynamically significant heart disease, multiple gestation at risk of preterm labor, placenta previa after 26-week gestation, premature labor, restrictive lung disease, rupture membrane والسيفير انيميا. دي الابسوليوت كونترا انديكيشن للايروبيك اكسرسايز. الريلاتيف زي الانيميا، البي ام اي بيلو 12، الكرونيك برونكايتس، الاكستريم موربيد اوبيزيتي، الهافي سموكر، الانترايوتراين جروس ريتارديشن كارنت بريجنسي، الاورثوبيتيك ليميتيشن، البولي كنترولد هايبرتنشن، بولي كنترولد hyperthyroidism, poorly controlled type 1 diabetes, poorly controlled seizures disorder, a sedentary lifestyle prior to pregnancy, unevaluated maternal cardiac arrhythmia. Thank you. دي كده كانت تاني محاضرة لينا. أي سؤال تحت أمركم. طيب ناخد بريك لحد الساعة 8-10 دقايق ونرجع تاني للمحاضرة الأخيرة. تمام؟ بس نرجع كلنا 8. اتفقنا. تمام، نرجع تاني الساعة 8 هتبقى دي آخر محاضرة إن شاء الله. طيب هنكمل مع بعض المحاضرة الأخيرة النهاردة، وهي عنوانها اللايف ستايل ميديسن and a woman's reproductive health. Our objective today, defining a reproductive health, physical and mental and social well-being related to reproduction, the importance of reproductive health, the impact on overall health, the quality of life and society, a lifestyle modification for risk reduction. طيب ايه هو الديفينيشن بتاع reproductive health؟ reproductive health is a state of complete physical, mental and social well-being and not the absence of disease or in all matters relating to the reproductive system and to its functions and processes. Reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. The key take-home point: regular physical activity reduces the risk of breast cancer across a lifespan. Avoidance of alcohol and tobacco across a lifespan reduces the risk of breast cancer. A plant-based diet rich in fruit and vegetable and maintaining a body mass index. A risk factor: cigarette smoking have been clearly linked to the development of lung cancer and other heart disease, and has also been shown to increase the incidence of breast cancer in postmenopausal women in both current and past smoker. سنة 2012 ال International Agency for Research on Cancer confirmed a positive association between tobacco smoking والbreast cancer. في سنة 2014 a report of the US Surgeon General revised their 2014 report of the US Surgeon General revised their 2004 statement now to report an estimated 10% increased breast cancer risk for women with a history of smoking. Tobacco smoke contains thousands of chemicals, many of which are known to be a mammary carcinogens. The most recent weight of the evidence has suggested a potentially casual role for active smoking and breast cancer, particularly for long-term heavy smoking and smoking initiation at an early age. Smoking appears to have adverse effects if initiated during adolescence or early adulthood before a first pregnancy because of heightened susceptibility to chemical carcinogens before full maturity. The breast tissue is particularly vulnerable prior to its complete maturation at the birth of a woman's first child. The role of secondhand smoking and breast cancer is less clear, although there have been some suggestion for an increased risk for premenopausal breast cancer. الألكول. Alcohol consumption وده a modifiable risk factor for cancer has become rampant in our society. Alcohol in any form is considered a carcinogen by the National Cancer Institute. Despite a consistent association between alcohol consumption and breast cancer risk, underlying mechanisms remain unclear. The most commonly investigated pathways include the effect of alcohol on circulating estrogen level and ER in mammary and estrogen in mammary epithelial cell and the carcinogen role of ethanol metabolites. Women should understand the risk across life course and the lifelong increase in risk of breast cancer from moderate and heavy consumption in early adult years. The risk of breast cancer and proliferative benign breast disease are increased by 11 and 16 for 1 drink per day alcohol intake before a first pregnancy, when breast tissue is likely at its most vulnerable stage. In premenopausal adult women, alcohol intake has been associated with higher circulating level of estradiol and estrogen. Alcohol, regardless of what type, not only increases an empty caloric intake, but also interferes with degradation of estrogen. We know that estrogen does not cause breast cancer, but can act as a fuel on a fire that is already burning. Compared to women who don't drink at all, women who had 3 alcoholic drinks per week had a 15% higher risk of breast cancer. Experts estimate that the risk of breast cancer goes up another 10% for each additional drink women regularly have each day. Women who have a family history of breast cancer should consider avoiding alcohol together or drink it sparingly. Women in general should limit their alcohol intake to less than 1 drink per day. Obesity. Obesity is epidemic and is an established breast cancer risk factor. There have been a 3-fold increase in obesity. Women with a BMI more than 30% have a significant risk of breast cancer recurrence when they have been diagnosed. This is likely related to higher estrogen level because fat tissue is the largest source of estrogen in postmenopausal women, but may also be related to other mechanisms, including a higher level of insulin among obese women. Obesity is a risk factor for type 2 diabetes, which has also been linked to increased risk of postmenopausal breast cancer. A review of 40 studies concluded that breast cancer risk was 16% higher in women with type 2 diabetes independent of obesity. With lifestyle modification, a woman's goal to achieve a healthy weight and body composition and then to maintain it throughout her lifetime. Obesity in youth is associated with early menarche and the beginning of lifelong poor eating habits. A BMI less than 25% from childhood throughout adulthood is ideal. Clean eating. Pesticide residues found in fruit and vegetable may cause adverse health problems. The exposure to a mixture of pesticides with a possible additive or synergistic effect is still not completely understood. Many carcinogenic pesticides are fat-soluble and may be embedded into adipose tissue for years. Stimulate estrogen or androgen pathways can cause epigenetics or DNA, our DNA, such as increasing the activity of cancer-promoting genes or decreasing the activity of cancer-suppressing genes. Exposure to pesticides may cause the net production of reactive oxygen species in tissue when oxidant defense mechanisms are overwhelmed, and a consequence of their overproduction is that they can cause extensive DNA and protein damage in cells. Sleep. Sleep duration is potentially modifiable lifestyle factor. Recently, results were presented from the first study to assess the association of sleep duration using Oncotype DX recurrence scores in breast cancer patients. They found a strong inverse correlation between the average hours of sleep per night and recurrence scores. specifically in postmenopausal breast cancer patients. The data suggests that lack of sufficient sleep may cause biologically more aggressive tumors. The women who report 6 or fewer hours of sleep per night on average had higher average recurrence scores compared with women reporting between 6 and 7 hours of sleep per night or more than 7 hours of sleep. One possible mechanism for the observed association may be the increased estrogen receptor activity response to reduce melatonin from lack of sleep. Working the night shift has been associated with elevated risk of numerous cancers, including breast cancers. Not only shift work constitutes a risk, but there are also many other factors which are related to disruption of the sleep wake rhythm, such as a lack of melatonin, the disruption of the circadian rhythm of the body on a molecular level, and disruption of the circadian rhythm of the release of stress hormones such as cortisol and sex hormones such as estradiol. Likewise, increased stress, the coordination of shift work with family life, irregular meals, a lack of physical exercise, and smoking contribute to a heightened risk. Several studies have looked at the addition of melatonin as a supplement at bedtime, using from 60 to 20 milligram, and show promising results from aromatase inhibition in advanced cancers to improve sleep and decrease the depression symptom. Since supplementation with melatonin does not inhibit the body production, there is no adverse effect to supplementation daily at bedtime. It is essential to develop good sleep patterns prior to undergoing cancer surgery, radiation, or chemotherapy. With practical strategies and information, women and men can correct the imbalance and develop healthier sleep pattern for the rest of their lives. A lifestyle evaluation and modification. Lifestyle evaluation and modification within 70% of breast cancers occurring in women who have no family history. We must make a change in how we view our personal risk and makes change in our everyday lives to decrease our individual risk and our global risk. Personal accountability is needed to initiate this shift in thinking, and we need to empower our sisters, daughters, granddaughters, friends, and colleagues to make conscious, healthier choice in their life. How can you begin to create a healthier lifestyle? First and foremost, we need to modify risk factors that are under our control. In nutrition, a well-balanced diet is a key component of an overall healthy lifestyle. 3 cohort studies have recently investigated the association between high fruit and vegetable intake and decreased risk of breast cancer by receptor status. All 3 studies found that women who consumed higher level of fruit and vegetable had a 32 to 50% lower risk of estrogen breast cancer compared with women who consumed low level of fruit and vegetables. In another cohort study that evaluated only dietary patterns, women consuming a higher fruit or salad pattern were observed to have lower risk of ER breast cancer. Earlier study of fiber intake and breast cancer risk reduction have been inconsistent and non-significant and were hypothesized to reduce breast cancer incidence by inhibiting reabsorption of estrogen. A study سنة 2016 revealed that there was a 30% lower breast cancer risk per 10 gram per day fiber increment during early adulthood and 14% lower breast cancer risk per 10 gram per day fiber increment during adolescence. Exercise and recreational activity. Promotion of physical activity is a key component for population-wide cancer prevention and control efforts. Exercise and physical activity have been documented to decrease a woman's risk of developing breast cancer. 3 to 5 hours of physical exercise weekly decreases a woman's risk of breast cancer by 18%. The more lean muscle mass you have, the more fat you burn, and the less fat remain to be a substrate for estrogen production. Recreational activity at any intensity level during reproductive and postmenopausal years has the greatest benefit for reducing breast cancer risk. Substantial postmenopausal weight gain may eliminate the benefits of regular activity. Epidemiological evidence supports participation in physical activity before and after breast cancer diagnosis as contributing factor in decreasing the risk of breast cancer recurrence and mortality. Stress reduction. Stress reduction is a major factor in the production of cortisol and inflammatory factor. It is well known that women with breast cancer have psychological distress during a diagnosis and treatment. Psychological symptoms in breast cancer patients are depression, anxiety, and anger. To complete matters, prior to a cancer diagnosis, a patient may be suffering from chronic stress symptoms such as irritability, headache, fatigue, anxiety, a nervous stomach, and insomnia. Creating opportunities to organize and manage stress before its tool is essential. Mindfulness involves bringing attention to one's present moment experiences, including thoughts, feelings, and physical sensations, with openness, curiosity, and acceptance. Increase in exercise plus healthy diet will lead to decrease in fat mass and increase in skeletal muscle, which lead to decrease in insulin, decrease in leptin inflammation, decrease in aromatase and estrogen, which lead to decrease in tumor progression, which lead to decrease in risk of recurrence. الفيتامينز الانتي-اوكسيدنت and mineral retinol and beta carotene والفيتامين A play an important role in immune surveillance, cell differentiation, and cell division, as well as many other functions. The genetic expression of inflammatory mediator in women with breast cancer was evaluated in a case control study looking at level of alpha, tocopherol, retinol, and beta carotene. The study showed that antioxidant nutrients have a possible biological effect in preventing breast cancer. It also supports the belief that the immune response is activated during breast cancer. Cells undergo many changes before they become fully aggressive and metastatic. At Thomas Jefferson University, they used a model of breast cancer progression composed of 4 types of cells, each one representing a different stage of breast cancer: normal, precancerous, cancerous, and a fully aggressive model. When the researchers exposed the 4 breast cell types to different concentration of retinoic acid, one of the chemicals that the body converts into vitamin A, they noticed a strong change in the precancerous cells. Not only did the precancer more likely a normal cell in terms of their shape, they also changed their genetic signature back to normal. Daily vitamin A requirement should be obtained from a diet rich in vitamin A. Best food source are sweet potatoes, carrots, spinach, cantaloupe, apricot, papaya, and mango. Vitamin D. Vitamin D modulates cell growth, neuromuscular and immune function, and reduction of inflammation. Vitamin D may not directly lower the risk of breast cancer, but it has substantial health benefit. A healthy level of 25-hydroxyvitamin D should be maintained above 40 nanogram per milliliter. Women should understand the significance of being deficient and take supplement vitamin D3 to attain a normal level. Antioxidant may play a role in risk reduction by blocking the formation of free radicals and protecting cells from free radical damage. الفوليت and other vitamin B play important role in the production and maintenance of new cells that are also needed to make DNA and RNA. The Shanghai Women's Study suggests that vitamin E and B supplement may confer protection against breast cancer among women who have low dietary intake of those vitamins. High folate intake in a prospective study of French women was associated with decreased postmenopausal breast cancer. In the women who had low folate intake and drank alcohol, an increased incidence of breast cancer was observed. Dietary source, الاسبانيش, الاسبرجس, and fortified cereals. Vitamin E and vitamin C. Vitamin E and C are powerful antioxidants that also play a role in immune surveillance. The University of Rochester looked at the role of alpha tocopherol-associated protein. It is co-expressed with estrogen receptors in the luminal cell of normal benign breast tissue. They found alpha tocopherol-associated protein acting as an anti-proliferative factor in estrogen receptor positive luminal cell in normal benign breast tissue, which serves as indirect evidence to support a role of vitamin E in breast cancer prevention. Results from a meta-analysis suggest that a post-diagnosis vitamin C supplement use may be associated with a reduced risk of mortality. Dietary vitamin C intake was also statistically significantly associated with a reduced risk of total mortality and breast cancer-specific mortality. More research is needed in the vitamin E and C breast cancer prevention. Almond, sunflower seed, avocado, salmon, and olive and wheat germ oil are the best dietary source of vitamin E. Good food source of vitamin C include citrus fruit, red and green, peppers, kiwi, broccoli, strawberries, Brussels sprout, and cantaloupe. Zinc, a trace mineral which is vital for the functioning of numerous cellular processes and critical for growth, may play an important role in cancer etiology and outcome. Immune function of many cells is impaired by low level of zinc, which gives credence to the theoretical anti-cancer benefit. Zinc is found in shellfish, grass-fed beef, lamb, chicken, toasted wheat germ, pumpkin seeds, sesame seeds, green peas, spinach. Selenium helps to produce selenoprotein, which are important antioxidant enzymes that prevent cell damage from free radicals. The Nurse Health Study, a prospective analysis, previously had found no association with selenium level and breast cancer risk, where selenium concentrations are assessed through a nail clipping. McConnell et al. They found a statistically significant inverse relation between a dietary selenium concentration in the blood and an incidence of human breast cancer. Furthermore, low selenium levels were identified in women with breast cancer. Clinical applications encourage lifestyle modification, early childbearing and breastfeeding, avoiding alcohol prior to the first Sussex pregnancy, minimize alcohol consumption through life, maintain BMI below 26%, exercise 30 to 40 minutes per day, 5 times per week. In nutrition, eat clean, predominantly plant-based, sleep hygiene, stress management. Encourage breast imaging screening based on a guideline, clinical evaluation of any breast mass, nipple discharge, abnormal lymph node, or skin changes. Regular physical activity is associated with improvement in health across a female lifespan. Participation in sports and physical activity during adolescence is strongly associated with adult physical activity levels. Low energy availability is the foundation of the female athlete triad, which also include menstrual dysfunction and low bone mineral density, increasing the risk of bone stress injuries in active female. The risk of developing type 2 diabetes and dementia, two of the most common diseases of sedentary lifestyle and aging, can be significantly mitigated through irregular physical activity and enhanced cardiorespiratory fitness. الhealth benefit of regular physical activity. The health benefit of regular physical activity start in childhood. American Academy of Pediatrics recommended that children participate in age and developmentally appropriate physical activity starting in infancy. The health benefits of regular physical activity start in childhood. The social and emotional benefit of regular physical activity and sport. While we are most likely to hear and read about the health benefit of sport and regular physical activity, some would argue that the social and emotional benefits are even greater and more important to quality of life. Weight-bearing physical activity is an important contributor to adequate bone mineral density. Wolff's law states that the BMD increases in response to a load. Women who engage in regular weight-bearing activities such as running and sports such as tennis have higher BMD than women who are sedentary. Women who suffered from female athlete triad in adolescence may have clinically significant reduction in BMD that continue to affect into adulthood. Trabecular bone in the hip and spine are more sensitive to change in hormonal milieu, aiding to insufficient level of estrogen, low dietary intake of calcium and vitamin D contribute to low BMD, while most BMD is accurate by the late 20s and early 30s, gain back a lost bone. Active women who are lower risk a hip fracture. In a large retrospective cohort study in Sweden, 1 hour a week walking or bicycling was associated with a 13% lower risk of hip fracture compared to adults with less than 1 hour a week of exercise. The mechanisms for this are many and likely include healthier BMD, better balance, and better reaction time, the latter two resulting in fewer falls. Given that 50% of hip fracture occur in people with a prior history of hip fracture, efforts to prevent the first fracture through regular physical activity across the lifespan are important from both a public health and clinical medicine perspective. Key clinical message: a girl school-based physical activity represents the greatest opportunity for children to meet a recommended level of physical activity. Physicians should assess physical activity at all well-child visits and encourage parents to regularly provide opportunities for children and their families to be physically active. Active adolescent female may be at risk for female athlete triad. Screening should be performed during the pre-participation physical evaluation. Early identification and intervention are associated with the best clinical outcomes. Multidisciplinary teams such as a physician, a sport dietitian, and mental health professional is warned for those with eating disorder and likely those with disordered eating. In adult, physical activity should be assessed as a vital sign at each clinical encounter. Those with less than 150 minutes per week of moderate intensity activity and those not performing muscle strength training activity 2 times per week should be advised and prescribed physical activity to improve health and prevent and manage a disease. Post-menopausal estrogen therapy. It is well established that the risk of cardiovascular disease in women increases significantly following menopause. Relatively few women experience cardiovascular disease at younger than 45 years of age. However, by the age of 60, cardiovascular disease is the leading cause of death among women. Multiple factors may explain the increased risk of cardiovascular disease after menopause. For many years, the increase in cardiovascular disease after menopause was attributed to the decline in androgens, estrogen that accompanies menopause. However, the Women's Health Initiative finding did not support this concept. For this reason, hormone therapy is no longer recommended as an approach to prevention of cardiovascular disease by the United States Preventive Service Task Force, the American Heart Association, or other scientific organization. Thank you. كده احنا خلصنا آخر محاضرة. Any question? I'm here. تمام، جزيل الشكر لحضراتكم، وأرجو إن أنا ما أكونش أطلت عليكم. المحاضرات كانت دسمة شوية، معلش، وألف شكر لحضراتكم. إن شاء الله حضراتكم عندكم بريك لحد الساعة 9، وفاضل زميلة أخرى هتديكوا آخر محاضرة النهاردة. تمام، بريك لحد الساعة 9 وهنرجع تاني.
السلام عليكم يا دكاترة. الصوت واضح؟ استاذنكم تكتبوا بس في الشات واضح ولا لا؟ تمام. بإذن الله إن شاء الله النهاردة دي آخر محاضرة. المحاضرة دي مهمة جدا للهيلث كير بروفيشنالز وكمان الناس العادية، فبإذن الله هتفيدكم في حياتكم عامة. في المحاضرة دي هنتكلم عن إيه؟ في المحاضرة دي هنتكلم عن دراج نيوترينت انتراكشن وإزاي نقدر نحدده، وإزاي أكتر كومن اللي ممكن الحالات الكومن اللي ممكن نشوفها كيسز في حياتنا عامة وخاصة مع الكرونيك ديزيز. We will discuss in details introduction the drug nutrient interaction and then how drug and nutrient interaction occur and common drug nutrient interaction. وفي كيس ستادي كده فعايزين نركز فيها بحيث ان شاء الله كلنا نجاوبها صح. وبعدين الفيتامينز and minerals، وبعدين الفيتامين توكسيستي، واخيرا how to take vitamin safety without any toxicity تحصل للبيشنت. First of all, we have to understand what is drug nutrient interaction وايه الديفرنس ما بين الدراج interaction. drug interaction هو occurs between two drugs interact together when taken at the same time. اكتشفوا مع الوقت ان ممكن كمان ان نيوتريشن الاكل العادي اللي احنا بناخده فلفل، خيار، خس، ايا كان، ممكن يعمل interaction مع some drugs ويأثر على الافيكاسي بتاعتها. وعشان كده ابتدوا يبي اتنشن الفتره الاخيره اهميه الدراج نيوترينت انتراكشن، وعشان كده عملوا عليه ستادي كتيره لقوا ان هو بيأثر الافيكاسي بشكل واضح. وعشان كده في بعض الادويه از ماست بالنسبه للهيلث كير بروفيشنال ان هو يدي ادفايس للبيشنت عشان يخلي الافيكاسي بتاعت الدراج مظبوطه وتوصل بالرقم بالكونسنتريشن المظبوط، خاصه طبعا في الدراج نارو ثيرابيوتيك اندكس زي الديجوكسين او الورفين. ايه اللي بيحصل لما بيحصل دراج نيوترينت انتراكشن؟ هي ممكن بتاثر على الكومن سايت اوف ابزوربشن، ممكن تاثر على الديستريبيوشن، ممكن تاثر على اليمينيشن within the body، وممكن تاثر في الفارماكودايناميك ميكانيزم، وكمان الكباسيتي. فعشان كده ممكن تؤدي لهاي توكسيستي، ممكن تؤدي لتوكسيستي في هاي دوز. دراج نيوترينت انتراكشن هو occurs between different therapeutic drug and nutrient response leading to lose أو decrease الثيرابيوتيك efficacy بتاع الدراج. وهنشرح ال different mechanism اللي ممكن الانتراكشن يحصل ما بينهم، وممكن بعد الشر تؤدي ل life threatening situation و sometimes may lead to death لو ما تلحقش البيشنت. How can drug and nutrient interact؟ الكيسز بتاعت الانتراكشن is not related فقط للprescription drugs. Although over the counter can affect the way your body uses a nutrient in food. Certain food or nutrients in food can affect the action of the medication. The interaction affects a medication on food or nutrient in food. Therefore, the medication interacts with food or nutrient in several ways. And this is we will discuss. It may be affect absorption, metabolism, excretion. It may be work on the same receptor. فعشان كده لو النيوترينت اتاخد معاه يزود الافيكاسي بتاع الدراج نتيجه ان النيوترينت مسك في الريسبتور قبل الدراج، فالدراج قعد فتره اطول في البلد فهيعمل افيكاسي مور على البيشنت. ممكن lead to nutrient deficiency that your diet may change how medication work. And this does not mean that you are taking a medication you need use a vitamin or minerals. ودي دايما تبقى واضحه بس في الكيسز قليله، بس في حاله لو الميديكيشن كان for long time. For example, we can speak about corticosteroid. Corticosteroid when taken in small quantity for short time you will not see any side effects, but if taken for long time you will see all the side effects related to gastritis, maybe affect drug for osteoporosis like bisphosphonate. عشان كده لو patient بياخد دواء over the counter like PPI for short time احنا ما بنفكرش قوي في السايد افكت اللي ممكن او الدراج نيوتريت انتراكشن اللي ممكن يحصل، لكن بنقلق اكتر لما يكون بيشنت مضطر يمشي على دواء زي PPI for long time. ساعتها we have to give advice على السبلمنت اللي هو يمشي معاه مع الدراج بحيث ما يحصلوش decrease في النيوتريشن ويأثر على جسمه قدام وما يعرفش ايه السبب، في الاخر هيبقى الدراج نيوترينت انتراكشن هو السبب. في الدياجرام اللي جاي هيوضح ممكن الميكانيزمات اللي بيحصل فيها الدراج نيوترينت انتراكشن. هو 3 major ways. اول major pharmaceutical ممكن تاثر على الكومباتيبيليتي او السوليابيليتي او الاستابيليتي بتاع الدراج. تاني نقطه ممكن تاثر على الفارماكوكاينetics، وساعتها ممكن تاثر على الابزوربشن ديستريبيوشن ميتابوليزم اند اكسكريشن، وممكن تاثر على الفارماكوداينامكس، تاثر على الترانزكشن او على الجينيتكس والمورفيزم او الانزيم او الترانسبورتر او الريسبتور اللي بيمسك فيه الدراج. الاوت كام بتاعتها ممكن ان تاثر على فور ثينجز، ممكن البايو افابيليتي بتاع الدراج، الفوليوم اوف ديستريبيوشن، الكليرنس عن طريق الكدني او الليفر، والبايو ماركرز. At the end we have the patient outcome. It can be positive, it can be negative. Positive, the patient will be improved and optimal, and maybe negative, it worsen or maybe toxic effect, and be nothing at all happen and would be the same. ان شاء الله هناخد كل انتراكشن الواي اللي ممكن والمين اكزامبل اللي ممكن بنشوفه في الكيسز بالنسبه للفارماسيست لو على الكاونتر او بالنسبه لو دكتور في المستشفى. اول مثال هو مثال الابزوربشن. في حاجات بتاثر على الجاستريك بي اتش وهي اشهر حاجه ليها الانتاسيدز او الPPI. الانتاسيد والPPI بتاثر ان هي بتديكريز الستومك اسيديتي، ودي هتاثر على امتصاص بعض المواد منها الكالسيوم، المغنيسيوم، الايرن will not be efficient absorbed من الجسم. عشان كده لازم ننصح البيشنت لو هيستخدمه لفتره طويله ان هو ياخد معاه مالتي فيتامين، والفيتامين الوحيد خاصه اللي بينقص جامد مع الPPI هو فيتامين B12. فات is good advice to give فيتامين B12 مع واحد بيستخدمه for chronic use. ممكن كمان ياثر على بعض الانواع، ممكن تاثر على الجات موتيليتي، وعشان كده هنلاقي ان الاكزامبل ليها هو الاوبيويدز. الاوبيويد it is not just in cases of anesthetics، برضه في بعض ادويه الكحه بيبقى فيها مشتقات اوبيويدز هتاثر على الجات موتيليتي، فهتاثر على الابزوربشن بتاع الدراج. ممكن كمان تاثر على الجات فلورا، واشهر حاجه ليها هي الانتيبيوتكس. الانتيبيوتيك بتشتغل ان هي كيل الهارمفول بكتيريا، بس للاسف هي بتكيل كمان اليوسفل بكتيريا او البينيفيشال بكتيريا، فعشان كده بتاثر على شغل الجت وبتاثر على امتصاص المواد. ومن اشهر المواد اللي ممكن يتاثر عليها الانتيبيوتيك فيتامين كي. في نقطه فيتامين كي دي انا حابب اسال سؤال صغير. فيتامين كي with certain drug هو يعتبر يعني انتيدوت لسيرتن دراج. لو زاد الفيتامين كي هيعمل كلوتنج، ولو قل هيعمل بليدنج. ايه الدراج اللي بيعمل انتر اكشن مع فيتامين كي؟ في حد هنا عنده هذه المعلومه يقدر يفيدنا يكتبها في الكومنتات؟ والسؤال مره ثانيه، فيتامين كي هو انتي دوت لدراج بيعمل سيوله في الدم. لو الفيتامين كي زاد هيأثر ديكريز الافيكاسي بتاعته، ولو الفيتامين كي قل هيزود الافيكاسي بتاعته. الاجابات ما شاء الله. تمام. دكتور محمد، محمود، تركي، دكتور لميا، مظبوط يا دكاتره، فعلا هو الورفين. فعشان كده ممكن بيشنت انا مش عارف ان هو بياخد ماشي على الورفين والكيس محتاجه انتبيوتيك، وطلعت انتبيوتيك، وتلاقي في الاخر الكيس البيشنت حصل له بليدنج زياده، انا مش عارف السبب ايه، نتيجه ان حصل تشينج في الميكروفلورا اثرت على الفيتامين كي فعمل بليدنج الكيس. دي صوره توضح امتصاص بعض المواد في منطقه الانتستين، هتلاقي والجاستريك كمان. فهتلاقي مثلا في الجاستريك فانكشن هي بتاثر على الفيتامين بي 12، الايرن، الكالسيوم. في الديودينم بنلاقي الايرن والكالسيوم والكبر والزنك والفوليت. الجيجينم في الايرن والكالسيوم والمغنيسيوم. وده يبين لنا قد ايه ان اي تشينج في المنطقه ديت بيحصل نتيجه انتيبيوتيك بيعمل تشينج في الكالسيوم في الفيتامين والمينرال بتاعت الجسم، فبتاثر بالتبعيه على البيشنت. نيجي بعد كده نتكلم على الميتابوليزم. بعض الحاجات ممكن تاثر على ليفر انزيم زي السيتوكروم بي 450 انزيم which speed up the metabolism of the drug, potentially reduce its efficacy. ومن اشهر الحاجات اللي بيطلع في الصيدليه عندنا اوفر ذا كاونتر ممكن كتير، ودايما بينصح بيه دايما ان هو الكيس تتعرف كامله، الساند جون وورت، لان هو ليه انتر اكشن كتيره جدا مع الدراجز، فلازم نعرف الكيس كامله عشان ندي الساند جون وورت للبيشنت. لانه بيزود السيتوكروم بي 450، فبيأثر على كتير من الادويه اذا كان كرونيك او سايكوتيك دراجز، او يكون انزيم انهبيتور فيقلل الاكتيفيتي بتاع الليفر انزيم فيزود الافيكاسي بتاع الدراج. واشهر ليه مثال ده الجريب فروت جوس. وبيأثر على السي واي بي 3 اي 4 ليدد تو اليفيتد البلاد ليفل بتاع الدراج، زي مين؟ زي الستاتين، كالسيوم شانل بلوكر، اند سيرتن اميونو سبريسنت. وكمان ممكن بعض الحاجات بتأثر على الفيز 1 والفيز 2 ميتابوليزم. Nutrient may influence the liver ability to carry out الفيز 1 اللي هي عمليه الاكسيديشن او الريدكشن، او فيز 2 هي عمليه الكونجوجيشن. ومن بعض الحاجات اللي ممكن تعمل كده هي الفيجيتابل الكولسيفورس، زي مين؟ زي البروكلي، بيأثر على فيز 1 ميتابوليزم اند لور دراج ليفل. وبعض الكومباوند زي الجارليك توم بيأثر على الفيز 2 ويعمل كونجوجيشن زياده فيزود الميتابوليزم فيقلل الافيكاسي بتاع الدراج. نيجي لثالث حاجه هي الاكسكريشن. الاكسكريشن زي ما احنا عارفين معظم الحاجات يا رينال عن طريق الكدني، او عن طريق هيباتيك عن طريق ليفر. فبعض الدراجز بعض الاكل ممكن ياثر على يكون بيطلع عن طريق نفس الحاجه، طريق الكدني، فساعتها الدراج يعمل مفعول اكتر، يقعد في الجسم اكتر ويأخر الاكسكريشن، فساعتها الافكسي تعلى عند البيشنت. زي مين؟ الدايوريتكس العكس، الدايوريتكس بتزود شغل الكدني، هتؤدي الى loss of electrolytes such as البوتاسيوم او الكالسيوم والمغنيسيوم. وكمان الاس انهبيتور اللي بتستخدم للبلاد بريشر بتقلل البوتاسيوم اكسكريشن، فيحصل ان البيشنت عنده هايبر كاليميا. وزي ما احنا ربطنا الكاليميا ممكن تتربط مع لو واحد عنده كمان بيستخدم ديجوكسين، فهتلاقي الجرعه بتاعت البوتاسيوم مش مظبوطه، فهتلاقي لخبطه في البليدنج، واحنا مش عارفين البيشنت ليه مش متظبط جرعته، او الاي ان ار بتاعه ليه مش متظبط، وساعتها لازم نعمل تحليل اي ان ار عشان نعرف الجرعه مظبوطه، او الاحسن بيبقى ساعتها نبعد عن الاس انهبيتور ونديله جروب تاني عشان ما يعملش سايد افكت ده. كمان ممكن ياثر على البايل اكسكريشن. زي مين؟ زي الكوليسترامين، وده يعتبر بايل اسيد سيكويسترنت، كان بايند للفات سوليبل فيتامينز اللي هي A والD والE والK، فهيقلل الابزوربشن بتاعهم من الانتستين. بعد كده ممكن حاجه تاثر على الفارماكو دايناميك انتراكشن، ان هاو نيوترينت اند دراج انتراكت از ا سايت اوف اكشن. دايركت انتراكشن ات ذا ريسبتور ليفل، هتلاقي هما الاثنين مع الريسبتور ليفل، وده اشهر مثال احنا لسه قايلينه من شويه اللي هو فيتامين كي ويز وارفرين. both of them على سيم ريسبتور، زودنا الفيتامين كي هيقل الافيكاسي بتاعت الوارفرين، هيحصل كلوتنج زياده ومش هيحصل البلاد فلو اللي انا عايزه. عملت العكس، ايه اللي هيحصل؟ بليدنج بزياده. وعشان كده لازم نعمل اختبار الاي ان ار عشان نعرف الدوز، والبيشنت بيمشي على الحاجات اللي فيها فيتامين كي بنفس الكميه على قد ما يقدر يوميا عشان ما يختلفش ليفل الفيتامين كي. كمان ممكن يحصل معانا في الفارماكودايناميك يا سينرجي، الاثنين يقووا المفعول يبقى اقوى مضاعف، او انتاكونيزم، الاثنين عكس بعض. زي ايه؟ زي الفيتامين سي والابزوربشن بتاع الايرن. دايما بننصح البيشنت اللي بياخد ايرن ياخد معاه فيتامين سي، اذا كان برتقان او حتى افرفيسنس من الصيدليه، يشربه يحطه في ميه ويشربه معاه بحيث يزود الابزوربشن بتاعه، ده سينرجي افكت. وفي حاجه انتاجونيزم افكت، فيتامين اي مع فيتامين كي، هما الاثنين ضد بعض، وعشان كده ممكن يزود الريسك اوف بليدنج لو الاثنين اتاخدوا مع بعض بس في هاي دوز من فيتامين اي. كمان ممكن ياثر على الافكت بتاع الدراج ديو تو نيوتريشنال ستاتس. بعض الحالات بيكون لو البيشنت عنده ديكريز اوريدي في بعض النيوتريشنال ستاتس بتاعته، بتاثر على الافيكاسي بتاع الدواء لو انت خدته من بره. زي الاي ديفيشنسي ان فيتامين دي كان امباكت الافيكاسي اوف سيرتن ميديكيشن فور اوستيوبروسيس. البيشنت اللي عنده ديكريز في فيتامين دي وانا مثلا ممشيه على بيسفوسفونات، لو عنده فيه ديفيشنسي الافيكاسي بتاعت الدراج مش هتشتغل كويس، هتعمل مفعول اقل. والبيسفوسفونات هو ده الفيرست لاينز فور اوستيوبروسيس. فانا بدي الدواء وما الاقيش افكسي كويس ومش عارف ايه السبب، اجي اعمل تحليل فيتامين دي الاقي البيشنت عنده فيري لو فيتامين دي، فساعتها اديه كسبلمنت ليه عشان اخلي الشغل البيسفوسفونات يشتغل شغل كويس. وممكن كمان ياثر على كومبيتيشن في الابزوربشن سايت. سام دراج ونيوترينت بيبقى عندهم السيم ترانسبورت ميكانيزم في الانتستين، زي المغنيسيوم والكالسيوم والزنك شير سيميلر ابزوربشن باسوي في الانتستين. فعشان كده دايما لما يجي بيشنت بياخد ادويه كتيره، حتى لو انا مش عارف هو بيعمل انتر اكشن او ما عنديش المعلومه، دايما يفضل از ادفايس، وعشان تيجي نكير بزياده يفضل يكون في مسافه ما بين ساعتين ما بين اي فيتامينز، حتى لو بياخد فيتامين اونلي ما بينهم وبين بعض. ليه؟ عشان الجسم يعمل ابزوربشن بواي افضل ويستفيد بيها بالشكل المطلوب. وكمان بنلاقي مع الايرون والكالسيوم كمان بيكمبيت على السيم ابزوربشن، لكن الايرون زي ما احنا قلنا الايرون مع الفيتامين سي كويس جدا، لان الفيتامين سي بيحسن ابزوربشن مع الايرون، بينما مع الكالسيوم الاثنين كومبيت فبيقللوا الكونسامشن منه للجسم. نيجي بعد كده للديستربشن اوف نورمال جات فلورا، ودي قلناها اشهر مثال ليها هو الانتيبيوتيك. الانتيبيوتيك ما بتحددش هل يا ترى البكتيريا دي مفيده ولا لا، فعشان كده بتاثر على امتصاص فيتامين كتير. فيتامين كي اللي هو بالتبعيه بيأثر على اذا كان في بليدنج ولا لا، وكمان بتأثر على فيتامين بي 12 والفوليت، ودول مكون اساسي جدا في تكوين الدم. فلو بيشنت بياخد كورسز متواصله من الانتيبيوتيك كل ما بيجي له دور برد او بيجي له يو تي اي انفكشن بسهوله جدا بياخد ديفرنت كايند اوف انتيبيوتيك، ممكن البيشنت يدخل في انيميا نتيجه ان الابزوربشن بتاع الفيتامينز ضعف زي الفيتامين بي 12 والفوليت. واز وي نو الانتيبيوتكس عشان كده دخلت بريسكريبشن دراجز. عشان الفيرست لاين هنستخدم ادويه الاو تي سي اذا كان مثلا انتي ستامين او ادويه كولد اند فلو، الادويه العاديه اللي مش انتيبيوتيك. وبعد كده لما بيمشي عليها البيشنت from 1 week 10 days ومفيش افيكاسي، ساعتها الجا للانتيبيوتيك واعمل ريفير طبعا للدكتور عشان يكتب له الانتيبيوتيك، وبعد كده يصرفه لو انت فارماسيست او لو دكتور يكتب انتيبيوتيك. لكن از فيرست لاين اوف سوليوشن انتيبيوتيك دايما لا، نتيجه السايد افكتس على المدى البعيد هو ده. لكن على المدى القريب معلش هو كان بيأثر على الفيتامينز، لكن على المدى البعيد كمان الريزيستنس اللي احنا بنشوفها من البيشنت بعد ما يوصل عمره 40 50 سنه يجي يدخل المستشفى عنده انفكشن، يجي نستخدم كل انواع الانتيبيوتيك في ريزيستنس منها، وبساعتها الموضوع بيبقى صعب جدا على الدكتورز. وده دياجرام صغير يبين الافيكاسي اللي ممكن تحصل ما بين فود دراج انتراكشن. في المعظم ممكن تؤدي الى انكريز اكتيفيتي بتاعت الدراج، ودي منها الانسولين مع الكحول او ستاتين مع الجراب فروت، او كمان ممكن يحصل ان الكالسيوم شانل بلوكر مع الجريب فروت بتزود الافيكاسي، والكترايل ديسفانكشن مع الجريب فروت ادويه الكترايل ديسفانكشن زي الفيكتور. ديكريز الافيكاسي اشهر حاجه الوارفرين مع فيتامين كي، وعشان كده احنا قلنا خلي بالك مش فيتامين كي از اونلي سبلمنت، لا كمان الاكل اللي فيه فيتامين كي، اي حاجه خضراء زي البروكلي بيبقى فيها عالي جدا من فيتامين كي، عشان كده لازم نظبطها. وبعض كمان الادويه بتاثر على فيتامين، المشروبات انا اسف بتاثر على فيتامين كي زي الكامومايل. وممكن الديجوكسين كمان مع الهاي فايبر دايت، والتتراسايكلين مع اي حاجه كونتيننج كالسيوم هنوضحها قدام، وممكن يعمل توكسيك افكت زي الاسيتامينوفين اللي هو الباراسيتامول، لو اتاخد بكميات كبيره ممكن يؤدي الى ليفر دامج. والمونامين اوكسيديز انهبيتور مع الفود، ودي ادويه انتي سايكوتكس، ممكن بعض الاكلات بتؤدي الى معاها هايبرتنسيف كرايسيس. دلوقتي هنتكلم على اشهر الدراج نيوترينت انتر اكشن اللي انا اخد بالي منها بحيث البيشنت ما يحصل له ديتريشن للكيس بتاعته بحاجه انا مش عارف هو ليه ايه اللي حصل. اول مثال احنا قلناه كذا مره اللي هو الوارفرين وفيتامين كي، ده مهم جدا لان فيتامين كي موجود في اشياء عاديه جدا زي ما مذكور اهو الكالي، السبانخ، البروكلي، كل الحاجات دي البيشنت ممكن ياخدها عادي جدا خضروات، وانا اقول بمنتهى خدها براحتك مش هتاثر على اي حاجه، وهي في الاخر هي بتعلي فيتامين كي بتاثر على مفعول الورفين لو البيشنت ماشي فيه. والعكس صحيح، لو البيشنت اوريدي ماشي متعود عليه وانا مظبط الاي ان ار على كده ومره واحده اوقف الغذاء ده، فيتامين كي عندي هيقل فهيحصل مفعول زياده من الدرج. عشان كده دايما في اكله لازم اظبطه ان هو يكون ثابت الى حد يعني اقصى حد يقدر البيشنت عليه من الادويه من الاكل اللي فيه فيتامين كي عشان ما يحصلش اي سايد افكتس من الاكل اللي بياخده البيشنت. وعشان كده دايما الاي ان ار ليفل هي اهم حاجه وي كان مونيتور عشان نعرف الانتي كواجوليشن ليفل البيشنت واصل ليه. كمان الانتيبيوتيك مش بتاثر بس على الفيتامينز كي او بي 12، هي بتاثر على جميع انواع الفيتامينز والمينرالز نتيجه ان هي بتقتل النورمال مايكرو فلورا. واشهر حاجه من الحاجات دي كلها من السيبروفلوكساسين بيقلل امتصاص الفيتامين كي في الانتستين، وبالتالي هيزود معدل الريسك اوف ذا بليدنج للبيشنت. نيجي بعد كده للكالسيوم والتترا سايكلين انتيبيوتكس. اي منتجات تحتوي على الكالسيوم كونترا indicated to be taken with tetracycline. منتجات البان، تشيز، كالسيوم سبلمنت. ف it is very important advice لاي بيشنت بياخد tetracycline antibiotic ان هو to be far away from tetracycline at least 2 hours before or 4 hours after taking it. ولازم نعمل مونيتور للساينز ازاي؟ عن طريق ان احنا نشوف الافيكاسي بتاع تترا سايكلين عمل مفعول ولا لا. لان لو البيشنت بدون قصد خد الكالسيوم مع تترا سايكلين، الدوز يحصل انتر اكشن مع بعض، فالدوز بيبقى هاز نو مينينج. بعد كده الستاتين والكو انزيم كيو 10. الكو انزيم كيو 10 ده موجود في الصيدليات على هيئه تابلتس، في منه كونسنتريشن كتير. وجدوا ان الستاتينز مع اي غذاء فيه الكو كيو 10 هو بيقلل امتصاص الكو كيو 10، بيتفاعلوا مع بعض بيأثروا، فبيقلل الافيكاسي بتاعه. ولما الكو كيو 10 بيقل في الجسم، بنلاقي البيشنت بيجي بيشتكي من اعراض عامله ازاي؟ زي ماسل بين او ويكنس. عشان كده اي بيشنت يجي لك على الكاونتر وبيشتكي من، او هو عنده هايبركوليستيميا وبيشتكي من ماسل بين، it is usually advised to know الهيستوري بتاع الدراج اللي هو بياخده قبل ما فيرست لاين افكر ما ادي بين كيلر. ايا كان طلعت ديكلوفيناك، صوديوم وباراسيتامول، ايا كان بين كيلر طلعته، الافضل اعرف الهيستوري بتاع الدراج بتاع البيشنت اللي بياخده، بحيث maybe it's just needing a supplement, there is no need for any other drug. كده انا حليت اصل المشكله، انا مش اديت حاجه مؤقته. البيشنت خلاص راح البين وهيرجع تاني برضه نفس الحكايه، هيرجع له البيت مره تانيه لان انت ما حللتش المشكله لو اديته بين كيلر. بينما لو اديته السبلمنت زي كوكو 10 او نصحته بالاغذيه اللي فيها كوكو 10، ساعتها المشكله هتتحل عند البيشنت. وطبعا الستاتنز بتتاخد دايما once tablet per day at night. ويوجوالي when we start statins، او عرفت ان بيشنت او حد عندك في البيت عرفت ان هو start statins، first 2 weeks we have to monitor these side effects عشان نعرف هل بيأثر جامد على الكو انزيم كيو 10 وقلل، فنبتدي من بدايه خالص معاه السبلمنت، وبقدر الامكان نبتدي بدوز ممكن وسط 200 ونشوف الافيكاسي هل يا ترى كويس. السايد افكتس بتاعت الستاتنز قلت، ساعتها افضل عليها. ومع الوقت ممكن اقلل ل 100 او ازود ل 300 لو السايد افكتس لسه موجوده. بعد كده الانتاسيدز والمينرالز عامه، ايرون زي الايرون والمغنيسيوم والكالسيوم. زي ما احنا قلنا الانتاسيد والبي بي ايز بتاثر على جاستريك بي اتش، بتقلل الاسيديتي، فبتاثر على امتصاص بعض المواد. زي ايه؟ زي الايرون. الايرون من الحاجات اللي لازم اسيدك انفايرمنت عشان يمتص، فانا لو اثرت على البي اتش بتاع الستومك هيأثر على امتصاص الايرون. So if the patient need to take antacid، ايه الادفايس اللي اديها للبيشنت؟ ان انا ابعد ده عن ده، اخلي الديفرنس 2 hours ما بين الانتاسيد والايرون، وكمان ازود ادفايس زياده، اخلي الايرون يتاخد مع فيتامين سي، فساعتها امتصاص الايرون هيعلى، والانتاسيد مش هيعمل سايد افكتس مع اي حاجه فيها ايرون، اذا كان نيوترينتس او كسبلمنتس. metformin and vitamins B12. Any diabetic patient come لازم ياخد فيتامين بي، لان ميتفورمين اول حاجه ده فيرست لاين لمعظم البيشنتس بيستخدموه، ده واحد. والدايابيتيك بيشنت اوريدي معرض لديتيريشن في النيرفز، والفيتامين بي 12 بيقلل حدوث الديتيريشن مع الوقت. فاي بيشنت دايابيتيك لازم انصحه ان هو ياخد فيتامين بي 12، لان الميتفورمين بيقلل الابزوربشن بتاع الفيتامين بي 12، وكمان از سايد افكتس لحاله الدايابيتس ميليتس بيقل الافكاسي بتاعت النيرف، فاحنا عايزين ناخد فيتامينز تقوي النيرفز. والفيتامين بي 12 it is a soluble vitamins there is no risk for toxicity ولا حاجه، ممكن يستخدمها البيشنت even 6 months متواصله، مفيش اي مشكله فيها. ودي الصوره بتوضح ازاي الميتفورمين بيأثر على بي 12 بجميع الطرق. بيشتغل ان هو بيأثر عليه في الجاستريك فايتال سيل وول، بيقلل انترنسيك فاكتور، بيأثر فيه في الليفر ان هو بيعمل اكيوميليشن ما بيخلوش يطلع في البلد، كمان بيأثر عليه في السمول انتستين، وبيأثر كمان ان هو بيخلي الفيلايت تسحبه، الجسم ما بيستفيدش منه. كل دي بتؤدي الى ديكريز الفيتامين بي 12 اللي هو موجود اوريدي في النيوترينتس. لو البيشنت ماشي على ايفن على لايف ستايل هيلثي واخد فيتامين بي 12 صح، او لو بيتاخد كسبلمنتس البيشنت بياخده من بره. فبحاول بقدر الامكان ابعد الاثنين عن بعض، واديله كمان سبلمنتس فيتامين بي 12 جرعه 500 مايكرو جرام ل 1000 مايكرو جرام بير داي، عشان اعوض النقص اللي حاصل نتيجه الميتفورمين، وكمان اللي بيحصل نتيجه السايد افكتس بتاع الدايابيتس ميليتس. حاجه كمان مهمه جدا، الجريب فروت جوس مع الستاتينز، عصير طبيعي جدا مفيد، ممكن اي انسان يستخدمه، بس ليه سايد افكتس بتحصل مع بعض الدراجز، واهمها الستاتينز، نتيجه ان هو بيأثر على السي واي بي 3 4 انزيم اللي في الليفر، فبيأثر على امتصاص او وجود الستاتين في الدم، بيزود تكسيرها او الميتابوليزم بتاعها، فبيقلل الافيكاسي بتاعتها للبيشنت. اهم عرض ممكن نشوفه، هنشوف الماسل دامج ممكن تؤدي الى مايوباثي، ممكن يؤدي الى ليفر دامج، ممكن يؤدي الى كدني دامج. عشان كده we have to advise the patient to avoid grape juice while taking الميديكيشن، عشان ما يعملش مور ما يعملش افيكاسي زي ما احنا قلنا. بعد كده نيجي للهايبرتنسيف بيشنتس واستخدام ديوريتكس، ومعظم البيشنت بيستخدموا زي لازكس. يوجوالي ان الديوريتكس بتخلي الالكترولايت كلها مفيده او مش مفيده، ومع الميه بتفقد كلها، فبنلاقي في نقص في البوتاسيوم، في الصوديوم، في المغنيسيوم، واللي بنشوفها في هيئه سايد افكتس بيجي لنا على الكاونتر زي ماسل كرامبس، ويكنس، بعض الكيسز ممكن توصل للاريزميا، وكمان ممكن نلاقي ان البيشنت بينهج جاست من نورمال ورك اوت بيجي له فاتيج بسرعه. Therefore we have to give him as a supplements، خاصه المغنيسيوم، لان المغنيسيوم دايما هم بيتكلم عنه مع الديوريتكس، لان المغنيسيوم هو مكون اساسي في الماسلز. لو نقصه حاد جدا ممكن البيشنت يجي له كرامس بسهوله جدا، ممكن تلاقي ويكنس في العضلات من يعمل اي اكشن بسيط، طلوع سلم او مش قادر. اوكي we will take questions. اوكي at the end حاضر هسمح، هنفتح وناخد اسئله. حاضر. ايه بقى المغنيسيوم ريتش فود اللي ممكن البيشنت يستخدمها تعوضه لو انا مش عايز اديله سبلمنتس؟ مكسرات، ليفي جرينز، اي حاجه ورقها اخضر، الهول جرينز، كل الحاجات دي ممكن تعمل ليفل اوف مغنيسيوم كويس. نيجي بعد كده البوتاسيوم مع الاس انهبيتور. زي الانابريل والليزينوبريل، بنلاقي ان الانتراكشن بتاعهم ان بيحصل هايبر كاليميا. والهايبر كاليميا من اخطر حاجه ان هي بتاثر على نبضات القلب، فهنلاقي ممكن يحصل معانا كاردياك اريزمي، وكمان ماسل ويكنس وفاتيج. عشان كده when patient take ACE inhibitor بوتاسيوم ليفل لازم نعمل له مونيتورنج ونعرف هو فين. وساعات لما بيبقى زياده شويه بنجوين معاه دايوريتك، لان الدايوريتك بتقلل البوتاسيوم. طب ايه الادويه اللي انا سوري النيوترينتس اللي انا بحاول اخد بالي منها مع استخدام الاس انهبيتور لانها غنيه بالبوتاسيوم؟ زي البنانا، توماتو، ليفي جرينز. وي هاف تو مونيتور اتس يوز للبيشنت، ونقول له خلي بالك وانت بتستخدمهم عشان بتاثر على مع الاس انهبيتور بتعمل هايبر كاليميا بزياده، وممكن تعمل توكسيك افكت. دلوقتي هوري حضراتكم كيس ستادي صغيره. it have 4 points we have to speak about للبيشنتس. عايز حضراتكم تكتبوا لي في الشات ايه الاربع نقط، كل واحد يقول نقطه منهم اللي انا اقولها للبيشنت ياخد باله منهم بحيث ما يجيلوش اعراض جانبيه او يقلل حدوث اني توكسيستي موجوده في الموضوع. هدي حضراتكم دقيقتين كده قولي في الكومنتات. We have vitamin B12 مظبوطه عشان التايب 2 دايابيتس مع الميتفورمين. تمام كده ستيل 3. يا ريت كله يشارك. الصوت واضح كده يا دكتوره زهراء؟ دكتوره خوله برافو، الزينوبريل والبوتاسيوم مظبوط. طب الاتورفاستاتين ده عيله الاستاتين، احنا قلنا في حاجه معاه. يلا نغششكم. مظبوط كيتن، مظبوط دكتوره تجديد مظبوط. ونعمل كمان جاب ما بين الكالسيوم كربونات وايه كمان، هو بياخد كالسيوم كربونات وحاجه تانية، هما يفضل الاتنين يبعدوا عن بعض، ناخد ما بينهم ديستنس. تتراسايكلين، مفيش تتراسايكلين. مع الكالسيوم صح، الاتروفاستاتين مع الكالسيوم ناخد بالنا منه. هنشوف دلوقتي الانترفنشن بتاع الكيس ستادي اللي احنا خدناها. سوري. الانتراكشن اول حاجه زي ما احنا قلنا، الميتفورمين مع البي 12 زي ما حضرتك قلتوا مظبوط، عشان الامتصاص وكمان البريفرال نيوباسي اللي بتحصل. الجيزينوبريل مع البوتاسيوم، لان الايس انهبيتور بيزود البوتاسيوم ليفل. الاتروفوستاتين مع الكيو 10، لان الكيو ليفل الكيو 10 بيقل الابزوربشن بتاعه، فبيعمل ماسل بين ويكنس، فندي سبلمنت كيو 10. وكمان الكالسيوم كربونات والاتورفاستاتين انترفير مع الابزوربشن، فعشان كده يفضل لو البيشنت هياخدهم ناخدهم بعاد عن بعض عشان ما يحصلش انترفير في الافكتيف بتاعته. ازاي بعمل كده؟ بعمل مونيتور للبي 12 واكوردنج بدي بي 12 سبلمنت، واعمل مونيتور للبوتاسيوم، واعمل ريكومنديشن ان البيشنت ياخد كيو كيو 10، وادفايس ان يحصل فيه سبيس ما بين الادويه. طيب دلوقتي انا عايز اعرف ان في نيوتريشنال ديفيشنسي ولا لا. ازاي اعرف؟ لو من بعض ممكن اعرف عن طريق بلاد تيست، لو اقول للبيشنت يروح معمل، او في بيبقى فاست تيست زي مثلا موجود في الصيدليات الفيتامين دي، بيحدد البيشنت، مش بيحدد رقم بس بيحدد البيشنت عنده ديفيشنسي ولا لا. ممكن بالسيمتومز استنتج ان البيشنت بياخد ستاتين فتره طويله وما بياخدش معاه كيو كيو 10، فساعتها انا بقى محتاج بستنتج ان هو عنده ديفيشنسي نتيجه كيو 10 هو اللي عمل ماسل ويكنس، فساعتها بطلع السبلمنت. ممكن يكون دايت اسسمنت، وده بيحصل برضه في المعمل، بيعرف الاشياء اللي ناقصه في جسمه من نيوترينتس وتغذيه البيشنت محتاج يعوضها. او ممكن اعمل ريفيو للميديكيشن هيستوري، لو بيشنت قديم عندي وعارف هو اوريدي بياخد ايه وماشي على ايه، او طبعا لو في الهوسبيتال وموجود الهيستوري بتاعه. ازاي اقلل الريسك بتاع الدراج نيوترينت انتراكشن؟ اول حاجه ان انا امشي على هيلثي دايت، وات از نوت ريكومندد ان انا اريبليس الدايت بفيتامينز او مينرالز. انا بريبليس لما يكون البيشنت مش عارف يعوض نتيجه عنده نقص حاد، او نتيجه اللايف ستايل بتاعه مش مناسب، او نتيجه ان هيلثي فود هو ماشي عليه، فممكن ساعتها بدي سبلمنت. بس دايما it is better to take it from the healthy diet. Follow direction on how to take الميديكيشن، اقرا الليبلز المكتوبه على البريسكريبشن، او حتى لو كان اوفر ذا كاونتر دراج. دونت شير الميديكيشن، وده واضح جدا في الاكزامبلز اللي احنا خدناها، لان بعض الميديكيشن في بعض الكيسز ممكن تكون تو افكسي كويسه، وبعض الكيسز ممكن تكون مضره. زي بيشن مثلا لو عنده رينال فيلير وبياخد باراسيتامول عادي، بس هو بياخده مثلا بكميه كبيره، بقى متعود ياخد الطبيعي ممكن حبتين 4 مرات في اليوم، لكن بالنسبه للرينال فيلير ده دوز عاليه جدا، بيفضل تبقى حبه 3 مرات بس في اليوم، عشان ممكن تعمل توكسيستي بسهوله لان هي بتخرج عن طريق الرينال. فدايما it is advised to use the medications alone, don't share it with others. Tell the physician about everything you are taking عشان الانتراكشن اللي ممكن يحصل، حتى لو كان هيربل برودكتس، لان بعض الهيربل برودكتس وبعض منتجات الهيربل ممكن تعمل انتراكشن زي ما وضحنا. كمان keep a list of medication اللي بتاخدها قبل كده او خدتها من فتره بسيطه، عشان الدكتور او الفارماسيست بيكون عارف هيدي ايه او يمنع اي انتراكشن. وطبعا ask الفارماسيست او الفيزيشن for any inquiry. دلوقتي هنتكلم عن الفيتامينز والمينرالز، ايه اهميتهم، انواعهم ايه، ولو في ديفيشنسي بتبان ازاي على الجسم. عايز اسال حضراتكم سؤال صغير كده بسيط. الفيتامينز they are divided into two main groups. What are they؟ وجزء تاني منه، ايه الجروب اللي انا ببقى قلق منه يحصل منه توكسيستي؟ which one؟ اوكي مظبوط صح. دكتوره ناهد، دكتور عمير، دكتور حسن، مظبوط. ووتر اند فات سوليبل. which one بيبقى فيه خوف ان انا يحصل توكسيستي؟ مظبوط دكتور عبير، مظبوط دكتور هنوف. الفات سوليبل فعلا، لانه بيقعد في الجسم مده اكتر. سؤال كمان. الفات soluble they are four types. حد فاكرهم؟ دكتور ديل استاذنك، طيب لو كده اكتب السؤال في الشات واجاوبك عليه. ايه والاي والدي والكي. مظبوط ما شاء الله. تمام تمام. فاحنا عندنا النيوترينز هي تو تايبس، ماكرو ومايكرو. الفيتامينز والمينرال يعتبروا مايكرو نيوترينز، والماكرو هم الكربوهيدرات والبروتينز والفاتس. As a patient or even as a healthy one we have نعمل بالانس. we have to balance between الفيتامينز والمينرال عشان هم بيساعدونا نستفيد من الانرجي بتاعه الكربوهيدرات والفات. الكربوهيدرات والفات والبروتينز. لو ده مش مظبوط هيأثر على ده، ولو ده مش مظبوط هيأثر على ده، فده ما يغنيش عن ده. عشان كده دايما اول لاين لاي كيس كرونيك ديزيز او بيشنت في حاله عاديه، وجهه نظر شخصيه هي النيوتريشن. نيوتريشن نحاول نظبطها مع البيشنت، نعرف الديفكت ايه اللي ناقص اكوردنج للكيس اللي قدامي. لو انا حسيت ان البيشنت نتيجه اللايف ستايل بتاعه صعب ان هو ياخده في الاكل بتاعه، ساعتها الجا لموضوع السبلمنت، ياخده من بره وما ياخدوش لمده طويله الا في لو ووتر سوليبل ممكن ادي مده طويله وانا مطمن. لكن لو فات سوليبل لا، تبقى مده بسيطه ويعمل تحليل ويشوف هل يا ترى الدنيا ظبطت ولا لا، واكوردنج للتحليل يعرف يكمل عليه ولا يوقف عشان ما يجيلوش توكسيستي. As we say they are micronutrients macronutrients. المايكرو هي الفيتامينز والمينرالز، وكمان الماكرو اللي هم الكربوهيدرات والبروتينز والفات. They are divided into 13 vitamins and 8 of these vitamins are B group. والبي جروب هي كلها water soluble vitamins. So the water soluble vitamins, they are easily to be excreted and not easily stored في التشو. وعشان كده it is not common at all ان ممكن يحصل منها توكسيستي، بس ممكن يحصل لو مثلا كيد فور اكزامبل خد شريط كامل في الكيسز ديت، لكن واحد بياخدها عادي جدا is something abnormal ان يحصل منها توكسيستي. زي فيتامين بي 1 اللي هو الثيامين الاسم العلمي بتاعه، او فيتامين بي 2 الرايبوفلافين، فيتامين بي 3 النياسين، فيتامين بي 5 البانتونيك اسيد، فيتامين بي 6 البيريدوكسين، وده اللي مشهور جدا في النوزيا للبريجننت وومن بنديه اللي هي فيتامين بي 6 لانه سيف على البريجننت. فيتامين بي 7 البيوتين، طبعا ماده البيوتين معروفه للشعر والسكين والهير والنيل. بي 9 الفوليت، والفوليت هو بيحصل له اكتيفيشن يتحول لفوليك اسيد. فاحنا يعني البي 9 هو جزء يعتبر من الفوليك اسيد، هو بيتحول في الجسم لفوليك اسيد. او كمان اخر واحد فيتامين بي 12 اللي هو الكوبلامين، وقلنا حاجات كتير عنه وقد ايه هو مهم خاصه مع الدايابيتيك بيشنت. بياخد ميتفورمين او ايفن ما بياخدش في الميتفورمين، هو محتاج. Taking very high doses of vitamin B6 can lead potentially irreversible nerve damage, while taking large amount of niacin exceed 2 gram can cause liver damage. احنا لو شفنا العلبه بتاعت النياسين هنلاقيها محسوبه بالمايكرو جرامز اكشولي الكميه اللي انت بتاخدها. فعشان تريتش 2 جرامز اكشولي كميه كبيره جدا من التابلت محتاج تاخدها عشان يجي لك الدمج بتاعتها، ودي حاجه انلوجيك انها تحصل يعني. نيجي بعد كده للفات سولبل فيتامينز زي ما حضرتك تفضلتوا، هما الاي والدي والاي والكي، وهما الار مور لايبل ان هو يحصل له منهم توكسيستي. وعشان كده دايما it is advised نكون واضحين جدا في الدوز بتاعتهم للبيشنت، خاصة في واحد منهم بيلخبط دايما ولانه uncommon في الاستخدام بتاعه، هو الفيتامين دي. فيتامين دي it has different concentration موجودة في الماركت في 1000 2000 5000 10000 and 50000. كل واحد بيستخدم فيهم according الصح بتاعه، يعني ان هو تستخدمه according للتحليل اللي البيشنت عمله. طب يا دكتور I don't know الكونسنتريشن، ساعتها الجا للقليل يوميا اللي هو هيبقى مين؟ 1000 5000 every day. ابقى ضامن ان التوكسيستي عمرها ما تحصل من هذا الكونسنتريشن. الكونسنتريشن تمام ويستخدمها لمده شهر او شهر، وبعد كده يعمل تحليل لو البيشنت مكسل ان هو يعمل تحليل. لكن الصح ان هو يعمل تحليل ونعرف الاول فيتامين دي قليل ولا لا. طب البيشنت صعب عليه ان هو ياخد حاجه يوميا، هدي ال 50000 جرعته كل قد ايه؟ حد عارف المعلومه؟ ال 50000 used once per مظبوط. مظبوط دكتور نجدة، دكتور محمد، حسن، شيهان، دكتور لايف. once per week مظبوط. once per week maximum for 3 months، وبعد كده البيشنت ممكن يستخدمه كبروفلاكسز once per month زي ما حد كده، بس هو لا كتريتمنت ما ينفعش، هو once per week. once per week، لكن بروفلاكسز ممكن نستخدمها once per month بعدين. لكن از تريتمنت واحد انا عارف متاكد ان هو عنده فيتامين دي ديفيشنسي، واهم اعراضها دايما بتيجي على الكاونتر اللي هو خمول، تعب، ارهاق، مش قادر، مع انه بياكل كويس. واز any person living in the Gulf countries يعني بنسبه 95% فيتامين دي ديفيشنسي موجوده. فامر سو كومن يعني. So now هنقول بعض الحاجات اللي ممكن تحصل منها توكسيستي لفيتامين A، بتبان على هيئه هايبر فيتامينوزيس A. ودي بتحصل او العلامات بتاعتها ازاي؟ ممكن نلاقي نوزيا، انكريز في الانتراكرينيال بريشر، بتلاقي ضغط الدم في الدماغ قوي جدا، وممكن كوما، وساعتها هتبقى هوسبيتال ادميشن. فيتامين دي it is so dangerous because of the 50,000 dose, especially it's so dangerous of this dose. عشان لو ما قلناش احنا كهيلث كير بروفيشنال للبيشنت، ساعات بعضهم بيتكسف يسال، يقول لك ما هو اكيد هيبقى زي اي دواء بيتاخد مره في اليوم يعني، فبياخدها مره في اليوم. ودي انا وجدتها مرتين يعني، وسبحان الله يعني ربك ستر ان هي كانت مثلا 3 4 ايام بس البيشنت استخدمها، فيعني ستيل لسه الجسم ما عملش اكيوميشن عالي. لكن لو البيشنت ما سالش فتره طويله، خدها من اي مكان وما سالش، بعد شهر ممكن يدخل في توكسيستي بسهوله جدا. دي هتبان ازاي؟ ويت لوس، ابيتايت لوس، والريجولار هارت بيت. وممكن لو اتثبت فتره طويله تؤدي لاورجن دامج. كمان الفيتامين اي بيأثر على البلاد كلوتينج، ممكن يؤدي الى هيموريدج ستروك. نيجي بعد كده نتكلم على الفيتامين اي. الفيتامين اي هو اهميته تكمن في الاميون سيستم، بيساعد الجسم ان هو تو فايت اني ديزيزز، كمان بيساعد على الهيلث سكين، وكمان بيسبورت الريبرودكشن والجروث، وبيهلب الفيجن. وهو مشهور اكتر حاجه كمان في الفيجن عشان الاسم العلمي بتاعه اسمه كارتينويدز، وهو مشهور في ضعف البصر. ودايما لو حد عنده زغلله او دايما بنطلعه ايفن كسبلمنتس في كيسز اللي بيجي فيها بلور فيجن، او بيشنت عنده غمامه بسيطه، ندي كونسنتريشن بسيط وانس بير داي فيتامين اي. ايه المصادر اللي ممكن الاقي فيها فيتامين اي بعيدا عن السبلمنتس؟ اي حاجه لونها اورنج اند يلو. موضوع بسيط. معظم الخضار اللي فيه لونه يلو او اورنج زي الجزر، ايوه مظبوط، جزر. ده مقوله معروفه، الجزر يقوي النظر. ليه؟ لانه احتوائه على فيتامين اي. كمان الريد كابسيكم اللي هو الفلفل الاحمر، والمانجا، سويت بوتيتو اللي هي البطاطا، والبامكن والكنتالوب. وكمان اي حاجه ليفي جرين زي البروكلي او البسله، ممكن نلاقيها كمان في الكبده والبيض كمأكولات حيوانيه. طيب انا حصل ديفيشنسي، ايه ممكن الشكل اللي الاقيه؟ ممكن الاقي نايت بلايندنس، ولو كان ديفيشنسي قوي جدا ممكن يبقى irreversible. نلاقي البيشنت بلايندنس نتيجه ديفيشنسي قوي جدا، وده غالبا بتبقى مش ان هيلثي فود او اكل عادي، لا غالبا بتبقى في المجاعات بان حاجه زي كده، لكن في الاكل العادي صعب جدا. كمان بنلاقي في الجلد كرياتين، زي قشور، قشور على الجلد بتتكون. وكمان الاميونيتي بيتقل عشان زي احنا قلنا ان هو بيأثر على اميونيتي الجسم. نيجي بعد كده للفيتامين بي. فيتامين بي اهميته الكبرى في ان هو انرجي ييلدنج نيوترنت. يعني ايه؟ يعني بيخلي النيوترنت اللي انا باخدها في الاكل استفادتي للطاقه، بيعرف يخليني استفيد بيها كطاقه. وده اللي بيخلي معظم الناس الديابيتك عندهم خمول بعيدا عن السكر وبهدله السكر، فيتامين بي عندهم في ديفيشنسي، فبيخلي استفادته من الغذاء اللي هو بياخده اقل من البيشنت، من الشخص العادي. فعشان كده بنلاقي دايما ارهاق بسهوله، تعب، خمول، مش قادر، نتيجه نقصان الفيتامين بي. وده اللي يخلينا دايما، عشان كده بقول دايما الهيستوري بتاع البيشنت هو مفتاح الموضوع. خمول بالنسبه لحد عادي مش دايابيتس، دايما بفكر في فيتامين دي. لكن خمول لشخص عنده دايابيتس، ممكن اقول لك انا باخد الدواء زي الفل يا دكتور، بس ما بياخدش فيتامين بي. ليه؟ هيحصل ايه؟ هيحصل ان الاكل اللي هو بياخده اذا كان كربوهيدرات او فات او بروتينز مفيش فيول، ما بيستخدموش كويس، فالطاقه بتاعت الجسم اقل من المعتاد. فساعتها كمجهود بيعمله ايفن نورمال، حتى لو تركيز في مذاكره مش زي الطبيعي. طيب زي ما احنا اتعودنا، احنا بنحاول بقدر الامكان يبقى مش نلجا بس ان هي تبقى بسبلمنت. في بعض الحالات يبقى سبلمنت زي الدايابيتس ماشي، محتاجينها تبقى سبلمنت لانه محتاجها بكونسنتريشن عالي. لكن بالنسبه كهيلثي بيرسون، لا، ناخدها من اكل افضل. زي ايه؟ زي اللين ميت، الفيش، الهول جرين، الفروتس، الفيجيتابلز بمختلف انواعها، البقوليات اللي هي الليجمز. ونقلل، ودي مهمه جدا جدا جدا، limits the processed food، الاكل المصنع بجميع انواعه. كل انواع اي ما تدخل فيه البشر هو اكل مصنع موجود على الرف. السوبر ماركت كله مصنع يعتبر يعني، ما عدا بعض الاشياء البسيطه. نحاول نقللها، ناكل حاجه الرو ونطبخها. لكن في كانز، في بريزرفاتيف، دخلنا بروسيسد فود. ليه بنبعد عنها؟ بعيده عن الضرر بتاعها الدايركت. الاندايركت واي هي بتمنع امتصاص الفيتامينز المفيده اللي انا باخدها لجسمي، فبالتبعيه بتاثر سلبيا على الجسم. من اهمهم الفيتامين بي، بتقلل امتصاصه لما باخد بروسيسد فود. عشان كده البيرسون اللي عنده بور دايت تيز ادفايس دايما مع البيشن ياخد فيتامين بي. مش محتاج حتى يبقى دايابيتس، بس هو عنده بور دايت والدنيا مش مظبوطه، ياخد فيتامين بي كويس، هيستفيد على الاقل كويس من الكميه البسيطه اللي هو بياخدها. ايه الاعراض اللي ممكن اشوفها من مريض او من حد جاي لي على الكاونتر وعنده اعراض وعنده فيتامين بي ديفيشنسي؟ it have two levels. لو مايلد هلاقي فاتيج، هيدك باستمرار. ممكن اهو هيدك جاي لنا بدل ما ادي حبه صداع، في الاخر يكون هو نتيجه بس نقص فيتامين بي ديفيشنسي. هو مش محتاج خالص باراسيتامول، هو محتاج بس يظبط الفيتامين بي هيروح منه الصداع. الاقي unreasonable weight loss، هو مش عامل دايت، بياكل كويس بس عنده ويت لوس. ليه؟ جسمه ما بيستفدش من الاكل كويس زي ما انا وضحت، بالتبعيه هيحصل له ويت لوس. طب سيفير impaired بالانس، هتلاقي توازنه مش مظبوط، muscle weakness، مود تشينجز ممكن تؤدي الى ديبريشن. ودي مشترك معاها في المود تشينجز فيتامين دي. لو ايفن فيتامين دي لو في سيفير ديفيشنسي، هنلاقي البيشنت ممكن يدخل في حاله ديبريشن unknown بدون اي مشاكل في الحياه ولا اي حاجه، بس هو حاسس بديبريشن. فيتامين دي بيعمل نفس السايد افكت. نيجي بعد كده لفيتامين سي. فيتامين سي هو من السوليبل فيتامينز، سو ديفيكلت ان هو يحصل منه توكسيستي. الاسم العلمي بتاعه اسكوربيك اسيد. موجود عندنا في كذا دوزج فورم. الفرفيسن دي اشهر حاجه ليها، في منه تابلت، كبسول. هو انتي اوكسيدنت مهم جدا، وعشان كده في فتره الكورونا دايما كنا يعني اتس ادفايسبل تو يوز ات از انتي اوكسيدنت. بيساعد الجسم ان هو يقي من اي ميكروب هيدخل. لكن از تريتمنت لاين هو there is no use at all، ومفيش اي scientific evidence ان هو بيحمي الجسم او بيدافع، بس هو بيساعد الجسم كاز انتي اوكسيدنت لو في ميكروبي دي. لكن كتريتمنت الفيتامين سي هاز نو ايفيدنس ان هو كتريتمنت. استخداماته ايه؟ بيستخدم كانتي اوكسيدنت زي ما احنا قلنا، بيستخدم كمان في الكولاجين فورميشن اللي هو للجلد، وعشان كده بيبقى ليه توبيكال يوز في مستحضرات التجميل. كمان بيستخدم في الايرون ابزوربشن، واحنا قلناها قبل كده في الاول خالص ان هو تيز ادفايس دايما ناخد كوبايه برتقال مع حبايه الايرون، ان هو بيزود الامتصاص بتاعته، في سينرجيزم افكت بتحصل. كمان في الانفكشن فايتنج ان هو مهم جدا للاميون سيستم زي ما وضحت لحضراتكم. وكمان بيستخدم يعني بشكل ما او باخر ليه اهميه بسيطه في النيورو ترانسميتر، مكون بيدخل في النيورو ترانسميتر اللي في البرين. موجود فين؟ زي ما احنا قلنا فيتامين اي موجود في اي حاجه لونها اورنج او يلو. الفيتامين سي موجود في الحمضيات بمختلف انواعها واشهرها البرتقال والليمون. كمان بنلاقيه موجود في الجرين ليفز ومختلف انواعها. وزي ما حضراتكم واضح كده اهميه الخضار والجرين ليفز اللي لازم تبقى موجوده على السفره على قد ما نقدر، لانها موجوده فيها جميع انواع الفيتامينز. يعني لو احنا شايفين الكابج والسبانخ والبروسلز شبه يعتبر 80% من الفيتامينز موجوده فيها. لو انا اوريدي باخدها بكميات موزونه يوميا، انا مش محتاج خالص اخدها سبلمنتس. انا يعني مش محتاج افكر يعني ان انا اخدها سبلمنت بجانب الاكل الكويس. جاست تيك ات في هيلثي دايت اند ذاتس ات. كمان موجوده في الستروبري والتوميتو والميلونز. طيب لو انا بقى فيتامين سي ديفيشنسي حصل في البيشنت، ايه الاعراض؟ اكثر حاجه معروف فيها السكيرفي. السكيرفي ودي ديفيشنسي، سيفير ديفيشنسي في الفيتامين سي. ليها كيسز مختلفه. بتبتدي بفتيج، بس الفتيج الى حد ما بتبقاش باينه قوي للدكتور او ايفن لو الفارماسيست جاي على الكاونتر يعني. بس هي مشهوره جدا في حاله البليدنج اللي بيحدث في التيث. يا دكتور انا بدعك سناني بالفرشه وبيجي لي بليدنج. طيب في سكر؟ في عندك سيوله؟ مفيش. كل ده نتيجه deficiency اللي هو ادى الى وجود ستيج 2 سكارفي نتيجه deficiency في فيتامين سي. ف بسايد التريتمنت التوبيك اللي احنا بنستخدمها مثلا توث بيست يكون ضد البليدنج، it is advised to know البيشنت بياكل او نوعيه اكله ايه. فاحاول بقدر الامكان اشفت النقطه ديت ان هو يزود، او ادفايس البيشنت ان هو يزود حاجات اللايم زي الليمون، اورنج، الميلون، الليفي جرين زي ما احنا قلنا، ياخدها فيحسن الفيتامين سي فيقلل الاعراض. بسايد الحاجات التانيه التوبيك اللي انا بديها للبيشنت. كمان السموكينج وجدوا ان هو بيأثر على الابزوربشن بتاع فيتامين سي نتيجه ان هو السموكينج بالمواد اللي سبحان الله يعني عشان كده يعني هو حاجه مضره جدا للصحه. لقوا ان المواد اللي فيه بتزود الاستريس بتاع البيشنت بتاع الجسم، فالجسم بيستهلك فيتامين سي اعلى من الشخص الطبيعي، فعشان كده بيحتاج فيتامين سي اعلى من الشخص العادي. فلو السموكر بيبقى معرض اكتر، وده فعلا هتشوفوه، هتلاقي ان السموكر بعضهم كتير بتلاقي بينزف من لسه. لو هو خاصه السموكر وماشي بتوتر مثلا او لايف ستايل اكل مش كويس، على طول تلاقي النزيف لسه موجود. اعراض نتيجه ايه؟ نتيجه فيتامين سي ديفيشنسي. فيتامين دي. فيتامين دي اشرح لي اللي هو ريجولار فيزيكال اكتيفيتي، الصحه. فيتامين دي في منه جزئين، في منه نوع نيوتريشنال ونوع منه الاهم. احنا ممكن في الخليج كلنا نيوتريشنال الحمد لله كويسه، بس نقطه السن لايت هي دي المعضله الكبرى بتاع فيتامين دي اللي بتخلي الناس كلها محتاجه فيتامين دي who live in Gulf countries. التعرض للشمس. احنا بنتعرض قليل، فالنيوترنت اللي انا هنقولها قدام اللي فيها فيتامين دي ما بتستخدمش الفيتامين دي اللي موجود عندنا في الجسم، فبنضطر ناخده على هيئه دوزج فورم does not need the sun to be activated، فبناخده على هيئه سبلمنت. عشان كده الفيتامينز اللي يعني بنسبه 90% بتاخده، ما بتفكرش ان انت تاخده كسبلمنت عشان حته الصن، ان هو محتاج وجود شمس عشان تو بي اكتيفيتد وتستخدمه. عدم تعرض للشمس ولو فتره بسيطه حتى ربع ساعه في اليوم في وقت ما يكونش فيه ضرر في اشعه الشمس، ساعتها جسمك هيستفيد بيه وهتبقى فيتامين دي طبيعي جدا. لكن نتيجه الحراره العاليه اللي موجوده في الجلف كانتريز وما بنتعرضش للشمس، فساعتها بناخده كسبلمنت. موجود فين؟ موجود في الفاتي فيش، موجود في البيض، موجود في كمان طبعا اللبن. طيب انا ما باخدوش من الكميه الكفايه في الاكل، او باخد حتى كميه كفايه بس ما بتعرضش للشمس. ايه الاعراض اللي ممكن تكون عندي؟ ممكن يحصل هشاشه في العظام، سيفير ديفيشنسي، ممكن يؤدي بعد كده الى اوستوبيروزس، ممكن تلاقي بون فراكشر، وده اللي بيحصل نتيجه كبار السن بالذات اللي بيطلعوا من البيت قليل، دي بنشوفها جدا كتير. تلاقي حد كبير في السن بقى له مثلا 5 سنين قاعده هي قاعده في البيت وما بتطلعش نتيجه سنها وعمرها وحاجاتها التقيله. تلاقي وقعه بسيطه جدا في المطبخ او قايمه الحمام، حد وقع، بوم فراكشر، مع انها وقعه ما تعملش اي حاجه، نتيجه سيفير ديكريز في الفيتامين دي. وساعتها هيبقى الحل الامثل كبريكوشن قبل ما يحصل حاجه زي كده، قبل كده ان انا ادي فيتامين تي سبلمنتس ويمشي عليه البيشنت، وكل 3 شهور اعمل اناليسيس اعرف هيمشي على بروفلاكسيس دوز ولا يوقف خلاص، ولا يوقف كده زي الفل، امور طيبه يعني. طيب بنلاقي كمان في اليونج، في الشيلدرن، بتظهر على هيئه حاجه اسمها ريكتس. بتلاقي الرجل ليها تقوس، مش نقطه نازله بربنديكولار، لا، في تقوس داخلي. ده نتيجه الريكتس، نتيجه فيتامين دي ديفيشنسي. عشان كده برضو نرجع تاني نقولها، بالنسبه للكيدز once they are born لازم فيتامين دي دروبس، نستخدم جرعتها السيف دايما، بعيدا بقى عن تحليل او مش تحليل، فلازم نستخدمها كده كده، لان هو بطبيعه الحياه هو على طول ملفوف، فتعرضه للشمس شبه معدوم. 4 دروبس بير داي. وناخد بالنا ان الكونسنتريشن بيختلف في بعض الادويه، ساعات بيبقى اعلى من بس معظم الدوزج فورمز يعني الدروبس هي بتبقى 4 دروبس بس، بعض الحاجات بيبقى الكونسنتريشن بتاعها الدبل او التريبل، فساعتها تبقى 2 دروبس بس في بير داي، بس المعظم الموجود بيبقى 4 دروبس بير داي. عنده اعراض او ما عندوش اعراض، انا بديها كبروفيلاكسز ان هو ما يحصلش ريكتس للشايلد لما يكبر. نيجي بعد كده للفيتامين اي، وده من الفات سوليبل فيتامين، وده انتي اوكسيدنت مهم في الفيجن والاميون سيستم والسكين، قريب شويه في الامبورتنت بتاعته من الفيتامين اي. بيساعد الجسم ان هو يحمي اي دامج ممكن يحصل من الفري راديكالز، زي الموجوده مثلا في راديشن، نتيجه راديشن معين في الصن، او مثلا اللي موجود في السيجرت سموكينج، لو حد ايفن اندايركت سموكر او دايركت سموكر بيحصل له تعرض للفري راديكال، الفيتامين اي انتي اوكسيدنت ليها. وعشان كده دايما اللي بيبطل سموك دايما اتس ادفايس تو يوز انتي اوكسيدنت لمحاوله تنقية الجسم من الفري راديكال اللي موجوده في السجاير. طيب موجوده فين الفيتامين اي في الفودز؟ موجوده في الميت، في الايج يوك بياض البيض، موجوده في السبانخ، البروكلي، وزي ما واضح مشترك السبانخ والبروكلي في حاجات كتير جدا فيها الفيتامينز. موجود كمان في النتس، المكسرات، موجود في الهيلثي اويلز زي الصويا بينز والاكسترا فيرجن اويل، موجوده في unprocessed cereals تكون unprocessed، مش موجوده عندنا في السوبر ماركت في علبه، لا اللي هي بتبقى non processed at all. كل ده بيلاقي موجود في فيتامين اي. طيب لو حصل deficiency ممكن نشوفها على هيئه ايه؟ نلاقي cystic fibrosis بيحصل في البيشنت، وممكن كمان في الشيلدرن بنلاقيها بتحدث على شكل erythrocyte hemolysis، خاصة في الانفنت نيو بورن before vitamin E is transferred from the mother period to birth. الترانسفير اثناء قطع البلاسينتا، الترانسفير فيتامين اي اقل من النورمال الجد عنده، فهيحصل له erythrocyte hemolysis، وساعتها بيتعلق له اي في فيتامين اي بدوز معينه بحيث توقف الاريثروسايت هيموليسيس للشايلد. فيتامين كي، وقلنا قد ايه هو مهم، لانه بيأثر دايركتلي مع البلاد كلوتينج ميكانيزم، وكمان عرفنا ان هو بيأثر على ادويه اللي بتأثر على اي حاجه بتشتغل على البليدنج، اهمها الوارفرين. الامبورتنت بتاعته بتنمو في الهيلثي بونز، في البلاد كلوتينج اند ووند هيلينج، ومع الاطفال في حاله بتمنع حاله اسمها الهيموراجيك ديزيز اوف ذا نيو بورن او اتش دي ان. ده سيريس بليدنج بيحصل لو في deficiency في فيتامين كي. طيب السورسز النورمال او النيوترينتس اللي موجوده فيها الجسم، طيب استاذن دكتوره لبنى ودكتور مصطفى لو في اي كويشن لو ممكن نكتبه في الشات واجاوب حضراتكم، مفيش مشكله خالص. موجوده فين؟ موجوده في الليفي جرين فيجيتابلز زي السبانخ والكالي، موجوده كمان في الفروتس، الفروتس اللي هي افوكادو، كيوي، وكمان في الفيجيتابلز اويل. طب عشان نشوفكم بس مصحصحين ولا لا، فيتامين كي there is something to measure، عشان اعرف الفيتامين كي اخباره ايه، تاثيره على البليدنج، بحسب ايه؟ ممكن حد يقول لي؟ دكتور سلطان ما شاء الله ركز معانا. بص، البي تي تي والاي بي تي تي كل الحاجات دي بتعرف عمليه البليدنج مظبوط صح، بس اللي مسؤول مع الفيتامين كي دايما بقيسه عشان اعرف انا رايح فين هو الاي ان ار. البي تي تي بيقيسوا نفس قريب منه ده، بس ميكانيزم تاني خالص، بس مش ملوش علاقه خالص بالفيتامين كي. اللي انا بقيسه عشان اعرف تاثيره على مساله البليدنج واعرف احدد بيه الدوز بتاعه الورفين هو الاي ان ار. بس البروس رومبين تايم ده ميكانيزم تاني بيعمل بلاد كلوتنج، هو صح في العموم، بس فور فيتامين كي وخاصه لما بيستخدموا مع الورفين بحسب الاي ان ار. بالنسبه للسؤال انا اعرف من فين الفيتامينز قليله، عن طريق التحاليل ولا من السيمتومز؟ actually from both. بس اللي بيحصل ان انا لما يجي بيشنت اعراضه يعني مش واضحه قوي، وانا هدي حاجه ليها توكسيستي عاليه زي الاي او الدي او الاي او الكي اللي هي الليبيدز، هيز ادفايس دايما ان انا اعمل تحاليل، او على الاقل هعمل التحاليل اللي بيتعمل في فاست اناليسيز اللي بيتعمل موجود في الصيدليه، اللي هو يقول، هو مش لازم يقول رقم، اللي هو يقول يس there is deficiency او no there is no deficiency. بيبقى عباره عن نقطه دم بتحطها في سوليوشن، بيجيب لك ريزلت على طول، يعني في خلال 5 minutes ممكن تعمل حتى وانت واقف في للكاستمر وانت واقف في الصيدليه يعني. وتعرف خلاص في ديفيشنسي هتطلع الدراج. لكن في معظم الكيسز لو الاعراض واضحه والبيشنت مدي كلام يوحي ان هو الاكل بتاعه ضعيف والتغذيه مش كويسه والشغل يعني تقيل والى اخره، فمضطر بياكل من بره كتير، ساعتها بدون ما تفكر خلاص طلع وانت مطمن ان المساله ان مفيش توكسيستي والاعراض هتتحسن. ودايما انا يعني لاي حد بتعامل معاه، هي المربط الفرس الفيدباك. الاعراض قلت، ومش على طول، يعني مثلا اسبوع 10 ايام اعراض قلت ولا ما قلتش؟ قلت يبقى يو ار اون ذا رايت تراك، كيب اون، هتكمل لمده شهر شهر ونص، وبعد كده ايه؟ هنوقف لو رجعنا للطبيعي الكويس الصح، يعني كده وصلنا اللي احنا عايزينه وكمل. لكن بيشنت اوريدي مش ماشي على، يعني هو على ده العادي بتاع حياته، ان هو مفيش هيلث لايف ستايل، مفيش هيلثي فود، مفيش هيمشي على خاصه لو ووتر سوليبل هيمشي على بتاع على طول، مفيش مشكله 6 شهور ويوقف ويرجع تاني وهكذا. لكن لو حاجه انا مش عارف اديتكت وشاكك في حاجه معينه، تبقى سبايس ان هو يروح اللاب ويعمل اناليسيس، وساعتها اكوردنج للاناليسيز طلع هو محتاج ايه. فيتامين كي ديفيشنسي اللي ممكن تبان قدامي زي ايه؟ هي عمليه البليدنج طبعا. الانتي ايرين دراجز، البلاد ثينر ميكوز بروبلم وذ فيتامين كي، عشان كده دايما تشيك مع الدكتور الفيتامين كي. وكمان النقطه الثانيه اللي هو، عفوا دكتور عمير، آه وكمان النقطه الثانيه اللي هي نقطه الانتي بيوتكس. الانتي بيوتكس يعني نحاول ناخدها كده از ادفايس، ان هو اي بيشنت او ايفن حتى في الفاميلي عندنا، لو حد بيعاني من السيوله، لاست اوبشن تو جيف انتيبيوتيك، نتيجه ان هي ازاي بتاثر على الفيتامين كي. هي من الاخر انت هتلخبط الدنيا كلها، فليه ميك ات لاست اوبشن. خلاص اضطرينا لكده. ويفضل تكون مع الدكتور اللي بيتابع الحاله، مش دكتور جديد، يعني الدكتور اللي عارف الهيستوري بتاع البيشنت، هو اللي هيديله الانتيبيوتيك، هيعرف لمده قد ايه، هيظبط له فيتامين كي. يفضل مش دكتور في مستشفى تانية مثلا مش عارف الهيستوري بتاعه، فساعتها اوكي ماشي، مش يعني مش هيركز في هذه النقطه. لا انا عايز دكتور عارف الهيستوري بتاع البيشنت، فساعتها هيدي الانتيبيوتيك. وحتى لو اضطر ان هو يديه نتيجه الكيس محتاجه، هيديه ببريكوشن معينه هتظبط مع الفيتامين كي، فما ياثرش على حاجه اهم زي البليدنج او الكلوت، لو يعني فورميشن العكس، يعني يعمل بليدنج او يعمل كلوت حسب اكوردنج هيعمل ايه في الفيتامين كي. بس غالبا طبعا هيعمل بليدنج لانه هيقلل الفيتامين كي. نيجي بعد كده لتاني حاجه مهمه جدا، الا وهي المينرالز. المينرالز برضو حاجات تعتبر من الماينور مش الماكرو، بتستخدم مع الفيتامينز هما الاثنين عشان الاستفاده من الانرجي، وكمان to gain some added benefits للجسم. زي ايه؟ زي الكالسيوم، الفوسفورس، البوتاسيوم، السلفر، الصوديوم، الكلورايد، والمغنيسيوم. كلهم بيأثروا بشكل ما او باخر، بس اللي احنا قلناهم الاولانيين دول الماكرو مينرالز، واللي ذو اهميه اعلى، واللي بيتاثروا اكثر بالادويه. ولو حصل فيهم ديفيشنسي بيبان بسهوله ويأثر على الجسم. باين هيأثروا برضو على الجسم وكل حاجه، بس الديفيشن بتاعتهم بتبقى بصعوبه. زي مين؟ اللي هم المايكرو مينرالز، هم الايرون، الزنك، الكبر، المنجنيز، وكمان الايودين والسيلينيوم. نيجي نبتدي بالكالسيوم. الكالسيوم زي ما احنا عارفين طبعا ان هو اكتر حاجه مهمه للبونز والماسلز، وكمان في بعض بيستخدم في الانزيماتيك فانكشن والترانسميشن للنيرفس سيستم مسج. في سؤال بقى ممكن يجي، طب انا يا دكتور عندي حساسيه كالسيوم، انا مضطر اخده كسبلمنت؟ الاجابه نو، مش مضطر اخده كسبلمنت، لان الكالسيوم مش بس مقتصر عن الميلك واليوجرت والشيز، هو كمان موجود في بعض الحاجات، في بعض السيريالز، موجود في البارسلي، في البروكلي، في الشويه والالموند، اللوز، فهو موجود في حاجات هركز عليها اكتر عشان اعوض اللي هو مش موجود اوريدي. انا مش هاكل لو عنده الرجي لاكتوز انتولرنس فور اكزامبل وبيعاني من الكالسيوم. ممكن اهتم بالكالي والبرسلي والبروكلي والموند. مش عارف اركز في اللايف ستايل بتاعي بالحاجات ديت، ساعتها هرجع كسبلمنتس، مفيش اي مشكله. بس از فيرست لاين لحد اوريدي صغير وهيمشي عليه فتره طويله عشان هو عنده لاكتوز انتوليرنس، وانا خايف يحصل معاه ديفيشنسي، فهيبان اعراض ويك بون او ماسل فاتيج، او ممكن تاثر على بلاد كلوتنج. عشان ابعد ده كله، خليني ماشي على سبلمنت بلانت بيزد يمشي عليها البيشن، يركز ان هو ياخد حصته من اليوميه من الالموند كويس والبروكلي مثلا. فساعتها صح، مظبوط، مظبوط. وصويا ميلك، مظبوط. والصويا ميلك صح، مظبوط دكتور. والصويا ميلك هيعوض اللاكتوز انتولرنس، وساعتها ياخدها بشكل طبيعي من غير قلق. بعد كده نيجي على الايودين. الايودين واهميته الكبرى في الغده للثيرويد هرمون. ذيس هرمون كنترول الميتابوليك ريت. فاحنا بنلاقي ان البيشنت عنده هايبر ثايروديزم، حرقه عالي جدا. هايبوثايروديزم، حرقه بسيط جدا. معظمهم بيعاني من الاوبيزيتي. موجودين اشهر حاجه في السي فودز، في الايجز and some vegetables. لو فيهم deficiency ساعتها هيحصل مرض جويتر، وساعتها it's advised to go to the doctor. الايودين دايما ما بناخدوش كسبلمنت، احنا بناخده في الفود بس. اشهر سورس ليه طبعا هو السولت، ملح الطعام، موجود في السي فود والاكل والسي فود والايج. بس بعض الكيسز بيبقى البيشنت محتاج سبلمنتس، ممكن بس دايما الدكتورز هو اللي بيحددها، لان اذا ماست لازم يكون انا عارف النسبه بتاعته كام. فعشان كده الدكتور هو اللي هيطلعه. فده سؤال مثلا الدكتور عمير كان بيسال هعرف الكيسز ايه. ده سبلمنت مش بيطلع خالص غير الدكتور لازم يشوف الكيس كلها ويعمل تحاليل، فمش هيطلع بالاعراض خالص. لازم هيبقى هوسبيتال ادميشن ويعرف منه الرقم بتاعه قد ايه. نيجي بعد كده للزنك واهميته. الزنك بيساعد في عمليه الجروث والديفلوبمنت، وكمان بيأثر على الاميون فانكشن. ولو في ديكريس فيه هنلاقي مفيش اكتيفيشن للفيتامين اي، فساعتها هيبان كل اعراض الديفيشنسي اللي احنا قلناها قبل كده. منها الفيجن بلايندنس اللي بتحصل، ممكن منها الاميون رياكشن هيبقى اضعف. لو في اي سؤال يا دكاتره اكتبوه في الشات، او على اخر المحاضره هنفتح الاسئله باذن الله ان شاء الله. نيجي بعد كده للمصادر بتاعه الزنك. مصادر الزنك ممكن نلاقيها في الريد ميت، الشيل فيش، البوتري، الدجاج، الميلك والتشيز والهول جرينز. بعد كده الحديد. الحديد هو مكون رئيسي في الدم، عشان كده لو في عجز بيحصل انيميا، واللي هي اهم اعراضها بنلاقي الفتيج وعدم الوعي او القدره. وساعات لو ناقص جامد ممكن يدخل في كوما المريض ويتعلق له محاليل فيها ايرن. موجود فين؟ از عشان نبعد، لو عايزين نبعد عن السبلمنت ناخده في الفيش، ناخده في البولتري، ناخده في الليجمز، ناخده في الايجز. وكمان بعض السيريالز ممكن نلاقي فيها مدعمه بالحديد. الايرون ديفيشنسي دايما كومن شويه، تحدث في 1 8 اشخاص. عشان كده دايما ادفايزد ان احنا لو البيشنت جالنا عنده اعراض انيميا، عشان انا عايز اخليها لونج تيرم، وجهه لي كلايف ستايل. ممكن بس في اول شهر مع النيوتريشن الكويسه ادي معاها تابلت. طب انا البيشنت بتاعي جه لا عنده يعني اعراض السيفير ديفيشنسي اوف ايرون، خمول جامد، وعمل تحاليل لقى عنده انيميا. the only solution اي في يتعلق وبيتحط فيه الامبول محطوط في المحلول، ويتعمل اي في دريب للايرن بحيث ان هو يعلي بسرعه، لان الايرن عشان از تابلت وايز بيحتاج فتره طويله، بيحتاج فتره يعني ممكن 3 شهور عشان يبان، يعلي مثلا نص رقم في التحليل يعني، محتاج رقم كبير ومواظبه من البيشنت. وطبعا من الادفايس دايما، احنا قلنا ادفايس منهم قبل كده ان الايرن is advised to be taken with فيتامين سي. ومن الحاجات اللي ما يتاخدش معاها الايرن غير الكالسيوم، اللي كمان ما يتاخدش مع الكافيين، ودي غلطه بنقع فيها كتير مننا. شاي او قهوه، اخد الحبايه واخد بعدها على طول شاي او قهوه، هتاثر على الامتصاص، فالافيكاسي ممكن تقل 50% ايفن مورس من بعض الكيسز لو البيشنت عنده مثلا كوموربيديتي ثانيه. فتلاقي في الاخر برضو الحديد مفعوله بيقل والجسم ما بيستفيدش منه في حاجه. فعشان كده الاثنين ادفايس مع اي حديد. ولوس اوف ابيتايت، مظبوط يا دكتور ناهد، مظبوط. وعشان كده لازم الادفايس يفضل فيتامين سي معاه على قد ما يقدر، ويبعد عن الكافيين اللي موجود في الكوفي او التي. مظبوط. نيجي بعد كده على مينرال كمان مهم جدا، خاصة في اللعيبة او اي حد بيعمل رياضة او جيم او أيا كان، هو المغنيسيوم، وهو اللي مسؤول على استخدام، وهو المسؤول عن استخدام الجلوكوز واحساس الطاقة. وعشان كده لو في deficiency دايما اعراضه اللي هو سبازم. انا بلعب لسه لاعب جيم بقيش اسبوع، وكل شويه بيجي لي سبازم، وكان ما بيجيش سبازم. هو اكشولي هو البيشنت بيبقى معرض للسبازم عشان هو عنده قليل المغنيسيوم، بس مع الرياضه الاستهلاك بتاع المغنيسيوم اللي جسمه محتاجه عشان يعمل ريبيلد للمصل عالي، فعشان كده ابتدى يحصل له السبازم. لكن هو اوريدي هو قليل من الاول، هي بس الجيم او الرياضه بينت الموضوع اكتر، لان الاستهلاك زاد اكتر، فبان على هيئه على عرض ايه، على شكل السبازم. ساعتها فيرست لاين سبازم حد بيلعب رياضه هي بتبقى المغنيسيوم سبلمنتس، او طبعا كذا فود سورس ان هو يهتم بيه، وهي مكسرات خاصه الكاجو، الليجومز. لا، المغنيسيوم will not build muscles، لا هو مش بيلد، هو بيساعد على اعاده آه، طبيعه المصل مره ثانيه. المصل في اي رياضه بتتكسر وبتعاد تاني مره ثانيه، هو مكون فيها، مش بيبيلد مصل. هو بيساعد على الريبيلدينج بتاع المصل، ان هو تعاد بناء، مش يكبر المصل او حاجه، لا هو بيساعد ان هو يعني يعيدها للطبيعي بتاعها بعد المجهود اللي اتعمل. دارك جرين فيجيتابلز، السي فود، الهول جرينز، والشوكليت. طبعا مش كل الشوكليت فيها مغنيسيوم، عشان ما اونلي دارك شوكليتس هي اللي بتبقى فيها. مركز مع دكتور سلطان، مظبوط، فور ريليف الماسلز باس، مظبوط كده. نيجي بعد كده للبوتاسيوم ودوره الكبير جدا في البلاد بريشر، وده اهم حاجه. واللي احنا قلنا كان في عيله من انواع الهايبرتنشن اللي بتزودهم. بما انكم متصححين معانا كده، ممكن تفكرونا كده ايه اللي كان بيأثر على البوتاسيوم من عائلات الهايبرتنشن دراجز؟ ما شاء الله يا دكتور سلطان. دكتورة خولة. شكرا جزيلا، شكرا جزيلا دكتورة شاطحة، شكرا جزيلا. هو الايس انهبيتور لانها بتعمل هايبر كاليميا، ولو زي ما احنا قلنا لو البيشنت لقينا عنده هايبر كاليميا، هي دي مش ده طبعا الفيزيشن هو اللي بيقولها، بس بيدي دايما عشان نكون عارفين هو ليه بيعمل كده الدرج الدكتور، بيدي مع الهايبر كاليميا، لا قصدي سوري الايس انهبيتور بيدي معاها دايوريتك عشان يظبط مساله البوتاسيوم في ان هي ما تبقاش عاليه. ايه بقى الادويه اللي فيها اوريدي بوتاسيوم وبحاول بقدر الامكان اظبطها عشان اخلي البيشنت ما يتعرضش لهايبر كاليميا بزياده مع استخدام الايس انهبيتور؟ البنانا، الابريكوتس، المشروم، السبانخ، النتس، كل الحاجات دي يفضل استخدامها بكميه معقوله. والسبايرونولاكتون مظبوط، السبايرونولاكتون من الحاجات اللي بتعمل هايبر كاليميا مع الايس انهبيتور مظبوط، يعني ما ذكرتناش في المحاضره بس صح، السبايرونولاكتون بتعمل هايبر كاليميا مظبوط. اكتر بيشنت دايما ما بلعبش معاه في حته ضبط البوتاسيوم دي او يعني معنى صح خلي الفيزيشن هو اللي يعملها، الكدني ديزيز. الموضوع بتاعها صعب كارقام تشوف الكونسنتريشن، عايزه تحليل بوتاسيوم يعرف كام بالظبط، والكدني هي بتشتغل ب 50% و 70%، فدي ساعتها الكيس بتبقى محتاج فيزيشن وهوسبيتال ادميشن يعرف الكيس نفسها محتاجه ايه. لان الكدني ديزيز، لان البوتاسيوم والايس انهبيتور او السبيرونولاكتول بتطلع هما الاثنين عن طريق الكدني، فهيأثروا جامد على عمليه الاكسكريشن للكدني ديزيز بيشنت. تاني حاجه بقى كمان معانا هو الصوديوم. الصوديوم هو مهم جدا، maintain correct volume of circulating blood، ولو حصل فيه لخبطه بنلاقي ان البلد ممكن يحصل له هايبر او هايبو، عشان كده مهم جدا ان هو يفضل في النورمال واي. زيادته بتؤدي زي ما احنا عارفين لهاي بلاد بريشر، والبيشنت بيجي له هايبر تنشن، بس مش بالضروره من مره او مرتين، ده اكيد عشان تو سي ان البيشنت عنده هايبر تنشن نيد مونيتورنج لمده 2 ويكس، البلاد بريشر ما بيقلش اعلى من 130 على 80، فاتس نوت ذا كيس، بس ممكن تؤدي لواحد نورمال ان هو يجي له اعراض الهاي بلاد بريشر يوم او يومين لو خد كميه صوديوم عاليه مره واحده، ممكن تجي له السيمتومز بتاعه البلاد بريشر. المصدر الرئيسي للصوديوم ألا وهو الملح. السولت هو ده المصدر الرئيسي للملح، بيتاخد بكميات معقولة، عمره ما يسبب هايبرتنشن إلا لو تاخد بكميات عالية جدا ساعتها أو على فترات، يعني كميات أعلى من المتوسط. في ناس بتبقى مثلا طبيعتها إنها بتاخد ملح زيادة، ما بيبانش الايفكت بتاعته الا لو فترات طويله جدا، قعد 4 5 سنين اون ذا سيم ليفل، ساعتها ممكن يجي هايبرتنشن ليه نتيجه استخدام بكميه كبيره. بس از يوجوال الهايبرتنشن معظم هو ستريس كوز، معظم البيشنت بيجي له نتيجه ستريس كوز مش نتيجه نيوتريشن عمل فيه كده يعني. وطبعا اشهر اشياء فيها صوديوم عالي مستخبي احنا ما بيبقاش باين علينا هي البروسيس فود، يعني وبروسيس فود مش معناه ان هو في كام بس، بروسيس فود برضو ان هيلثي فود، برجر، فرنش فرايز، اي حاجه من الحاجات الان هيلثي فاست فود كلها بتبقى الكميه السولت فيها عاليه جدا، فبتؤدي الى الهايبر تنشن مع الكونتينوس يوز بتاعها على مدار طويل. ندخل بعد كده على الاكزامبلز بتاعه الفيتامين توكسيستي. فيتامين توكسيستي زي ما احنا وضحنا هي معظمها لما بتحصل في الفات سوليبل مش في الووتر سوليبل، ولكنها ممكن تحدث في الفيري هاي دوزز زي مين؟ زي الفيتامين سي. فيتامين سي بيبانها في هيئه دايريا، البيشنت بتلاقي وعنده كرامس ونوزيا فوميتنج، وممكن كمان صداع نصف مايجرين. بس في دوز عامله زي 6 جرام بير داي. احنا دايما when we advise patient take effervescence take 1000 بير داي، فيعني ده كنت تتخيلوا ان هو ياخد 6 effervescence بير داي نفس الجرعه، ودي جرعه يعني unpredictable انها تحصل، بس maybe فيكون عارفين هذه المعلومه عشان لو حد جه قال لك انا خدت بتاع دوت تعرف ان هي هاي دوز ولا نورمال واي ولا لا يعني. تاني حاجه الفيتامين بي 3 نفس الحكايه، ممكن يؤدي لهاي بلاد بريشر، ممكن يؤدي لابدومينال بين، ممكن يؤدي لامبيرد فيجن، ممكن يؤدي عشان نتيجه ان هو بيطلع عن طريق الليفر يؤدي لليفر دامج. ده لو استخدم من 1 ل 3 جرامات بير دي. الفيتامين بي 6 وزي ما احنا قلنا فيتامين 6 هو من الادويه الانتي نوزيا اللي مشهوره جدا للبريجننت وومن لانها السيفتي بتاعتها عاليه وبتتحسب بالميكروجرام. لو اتخذت بكميات عاليه من 1 ل 6 جرام ودي كميه كبيره جدا، ساعتها ممكن نلاقي بعض الاعراض زي نوزيا، هارت بيرن على البيشنت. وفيتامين بي 9 اللي هو الفوليك اسيد اللي بيدخل في تكوين الدم، ممكن يأثر على المينتال فانكشن لو اتاخد بكميات عاليه جدا، والاميون سيستم، وكمان هيعمل ماسكينج للسيمتومز بتاعه السيفير فيتامين بي 12 ديفيشنسي. لو في اعراض الفيتامين بي 12 ديفيشنسي هو هيعمل ماسكينج للسيمتومز بتاعتها لو كميه عاليه جدا. So it is advised to take it as reasonable in good quantity او الاحسن من كده زي ما احنا قلنا عشان نحاول keep this in a normal level to take it in nutrition، بعيدا عن ان هو يكون فيتامين ده فيرست شويس ليا، وبعد كده اديه سبلمنت لو البيشنت ما عرفش. تايم ليفت ان شاء الله نصلنا ان شاء الله ربع ساعه. لو البيشنت ما عرفش يحافظ على الليفل بتاعها بالنيوترنت ساعتها اديله as a supplement. Can taking too many vitamins be deadly? Yes, but it is a kind rare from the vitamin to cause death of the patient. So, for example, vitamin A can taking large dose of over 200 milligram or chronic use of recommended dose for long time can cause toxicity اللي ممكن تؤدي إلى كوما and spinal fluid pressure and ممكن death of the patient. تاني مثال وهو ده أنا اللي more probably ان هو يحدث في الحقيقه هو فيتامين دي toxicity to take 50,000 daily over a long period of time. ساعتها هتؤدي لزياده في الكالسيوم رهيبه لان الفيتامين دي احنا عارفين مع الكالسيوم بيساعد على الابزوربشن بتاعه فيعمل اوفر دوزنج، فممكن يؤدي لليفر دامج وساعتها هيبقى فيتال كيس. وزي ما احنا وضحنا اللي هي ما تكون على لونج بيريود اوف تايم، مش 1 ويك فساعتها البيشنت خلاص، لا فور لونج بيريود اوف تايم حد ما سالش خده ومشي عليه على طول وما حسش بالسايد افكتس او معنى صح لم يبالي بيها اهتماما اللي حصلت له، ساعتها هيجي له بعد شهر ممكن ليفر دامج. طب يا دكتور انا عايز اخد الفيتامينز من سيف، how can I do this؟ best way as I said is well-rounded diet, a well-balanced diet according على الايدج، genetic disorder، mental condition. وده دايما اللي بحب اقوله ان هو انا مش معنى ان كميه مثلا 50 مللي جرام هو ده اللي كويس للشخص لا يبقى انا زي ده زي ده زي لا، احنا مش كلنا زي بعض، كل واحد بيختلف عن ده according للكيس واكوردنج للكوموربيديتي الموجوده معاه. طيب ازاي اخده؟ اخليه كمالتي فيتامينز، لان المالتي فيتامينز فيها كذا حاجه، فهتعوض الفيتامينات كتير، لان لو اديته فيتامينات كتيره ممكن ما ياخدهاش، فاديله مالتي فيتامينز في نسب صغيره من كل حاجه، انا ضامن انه مش هيجيله توكسيس دوز نتيجه ان كميات بسيطه، وفي نفس الوقت هتعوض الحاجات اللي موجوده فيها. بس از ادفايس لو البيشنت انا عارف هو ايه معين عنده ناقصه، اديله اللي هو بس اللي عايزه وخلاص. الفات سولبل فيتامين الاي والدي والكي از ادفايزد تيك ات من فود او من بلانت بيس دايت، ابعد عن التابلت فورم. الووتر سولبل فيتامين تو تيكن اد ريكومندد دوز، وابعد ساعتين ما بينهم وما بين اي دواء او اي حاجه تانية عشان ما يتاثرش امتصاصهم بيها. بالنسبه للبري ناتال فيتامينز زي الفوليك اسيد، مشهور جدا لازم يتاخد، وكمان يفضل قبل الحمل، مش حتى مش بدايه الحمل، في البدايه في الحمل وقبله، عشان نمنع اي سايد افكتس للمذر وايفن للشايلد. بناخده دايما in the evening before bed time. والايرون سبلمنتس، الايرون سبلمنت انا وضحت ان هي تاخد ازاي سيف، قلنا مع الفيتامين سي، وقلنا ان هي تبعد عن اي حاجه فيها كافيين او فيها كالسيوم. بالنسبه للمينرال سبلمنت زي الزنك والكالسيوم والمغنيسيوم، ادفايس دايما تو تيك ات ويز فود بات ا ديفرنت ميل. لو البيشنت بياخد عندي زنك وكالسيوم، ياخد واحد بعد الفطار، واحد بعد الغداء، واحد بعد العشاء، بعاد عن بعض، فعشان كده الافيكاسي بتاعت الحاجه هتبقى احسن. كده احنا وصلنا للنهايه، ارجو ان هي تكون